Good morning, one and all. On behalf of the Department of Otolaryngology and Head and Neck Surgery, I, Dr. Marina Saldana, extend a very warm welcome to all the delegates and the faculty for today's 17th OSCE workshop and online case presentation. This workshop started in 2004 under the guidance of our beloved Vice Chancellor, Professor Dr. Satish Kumar Bhandari. Under Sir's guidance and by the help of the department, over the years, this workshop has evolved, and it has benefited many postgraduates, DNB graduates, as like even the faculty. So the unique feature of our two-day workshop is the online clinical discussions and the valuable clinical input we get, which has helped not only benefited the postgraduates, the faculty, and because of the clinical expertise of all our faculty, it has helped to improve our program. Now, starting on this note, I request our dear Head of Department, Professor Dr. Vadish Bhatt, to deliver the welcome address.
Good morning, very good morning to all. The Department of ENT KSHEMA is always in the forefront of conducting various academic programs, and I am very proud and happy to continue the tradition set by my seniors. Initially, our own Vice Chancellor, Honorable Vice Chancellor Professor Dr. Satish Kumar Bhandari, and followed by Dr. Rajeshwari. And now it's been very easy for me to continue the tradition set by these people. This year, we are on the 17th year of OSCE workshop, and it has been a success all over the year, and this OSCE program has grown over the years, and the popularity has also grown and benefited a lot of students, both MS, DNB, and those who are opting for some foreign examinations.
Yeah.
So initially, we used to call it as it was an academic feast, and aptly called by our Honorable Vice Chancellor as academic pilgrimage. But we had a testing time in 2020 and 2021 because of the COVID pandemic. We had some hurdles, but as like many other people around the world, we too adapted to this newer situation and adopted the newer technology, and we went on the hybrid mode in 2021. And this year, further change because of the NMC assessment in various medical colleges, we are going on virtual mode on full day on the first day, and the OSCE is being conducted on live on the second day, that is tomorrow. So I'm very happy to have eminent faculty around from Karnataka as well as elsewhere. And to inaugurate this program, we have our Honorable Vice Chancellor, our own Professor Dr. Satish Kumar Bhandari, who is actually dreamt of having these workshops long back. And he is always supportive to us. And in spite of his busy schedule, he has given time for us. I welcome, sir, on behalf of the Department of ENT. We too have,
yes,
welcome, sir. We have our own Dean of KSHEMA Medical Academy, Professor Dr. Prakash, sir. And sir was busy and he told that but still he has taken time from his pocket and he has given time for us. I welcome sir on behalf of the organizing committee and the Department of ENT. And faculty, yes. So all this workshop, the success of this workshop belongs to you, sir. I dedicate the success to the faculty, and many of you are with us for many years. And this year too, we have a galaxy of faculty. Dr. Azim sir from Kolar, and our own president of AOI, Dr. Bharati MB, and we are very proud to have you this year because you are in the chair of president. We have Dr. Sapna Nambiar from Calicut. We have Dr. Anil Kumar Hargo from KLA Belgaum. We have Dr. Arun Kumar JS from Dharwad, Dr. Raghunath Shanbag from Dharwad. We have Dr. Gangadhar Somaji, Registrar of Enapoya, deemed to be University. Our own ENT faculty. We have Dr. Balakrishna sir. Dr. Mohan Appaji will be joining in the afternoon because he is busy with some non-academic work in the morning. And we have Dr. Suja Sridharan, Dr. Kailesh Pujari from KMC, Dr. Vijayalakshmi from Enapoya, Dr. Dev Prasad D, an all-rounder I would call because I know him for more than nearly 3 decades. And we have Dr. Mahesh SG from AJ Institute, Dr. Kuldeep Moras from Father Muller Medical College, Dr. Sunil Pai from Srinivas Medical College, Dr. Mahesh Bhatt from Father Muller. Also, we have today's workshop. To make it special, we have the president of AOI Karavali. We call our AOI Mangalore as AOI Karavali, Dr. Gautam Kulamarva, and secretary of AOI Karavali, Dr. Rukma Bandari is also there with us. One thing what I want to mention is that the AOI Karavali is conducting case presentation for postgraduates of Mangalore, all the medical colleges in and around Mangalore every Thursday. And that is one thing which actually we got the clue to make this event a bigger one. Thank you, Dr. Rukma and Dr. Gautam for the great idea. Also, we have the delegates. We have a lot of registration for this, but some had to withdraw because of the NMC assessment, but many are still in the race. And I welcome all the delegates from all around, both coming both for the first day program, today's case presentation, and OSCE. And I welcome all the faculty and the students of the Department of ENT and all the departments of the KSHEMA Medical Academy. And I welcome all the non-teaching staff, especially the IT staff. Yes, this event being virtual, their role is very important. I welcome the IT staff, ably guided by Mahesh, Savita, and Bharati. And I welcome all others. I cannot name everyone, and there are a lot of others here to witness this great event. And I wish from the Department of ENT, on behalf of the Department of ENT, I welcome one and all.
Unmute. You can ask others to mute the mics and you can unmute. Yes.
I request our Honorable and respected Vice Chancellor of Nitte University, Professor Dr. Satish Kumar Bhandari, to deliver the inaugural address.
Good morning. I am really delighted to be with all my colleagues from my fraternity. I don't want to name all of them, but as the protocol demands, the president of our AOI, Dr. Bharati is there, and our AOI Karavali president, Dr. Kulamara is there, and the dean of the medical school, Dr. Prakash, and all my distinguished colleagues from the ENT. Thank you very much for accepting our invitation and participating in this OSCE program. And my dear delegates who have been registered for the OSCE and also for the long case presentation we are having today. I am delighted for 2 reasons. One, the sustainability of this particular program, which we started way back in 2005. this is the number 17 shows that it can be sustained only by the efforts of my colleagues, and particularly the Department of ENT. I should congratulate Dr. Vadish Bhatt and earlier Dr. Rajeshwari, the head of the department who was there earlier, who continued this legacy of having CMEs from the department, and particularly this OSCE program, which started in the year 2005. The intention of having this particular method of examination system, because as you all know, not only teaching and learning is very important, assessment is very important part of the university responsibilities. Assessment, one of the, I know that there is no one single valid method of assessment. Every method of assessment has got its own advantages and disadvantages. But universally accepted, one of the most reliable method is OSCE, as you all know. But unfortunately, it was not very popular in our country, but slowly it gained popularity because of the DNB examination. But the routine post-grad examination, we could not adapt because we had the luxury of having patients, and we could continue with and because of the statutory body also, we had to conduct long cases, short cases, and instruments and other method of examination, YOC. But as Dr. Vadish Bhatt said, during COVID pandemic, the OSCE method came to our rescue, and we had to have a blended mode of examination. The dean will agree with that we had blended mode because we had a shortage of cases. We had certain number of cases. At the same time, we had to method other form of examination. But from my department, from the ENT department, for formative assessment, we are using it for the last so many years. Almost, I think, for the last 17 years, we are using OSCE method of examination during formative assessment, and we have found it very useful. And the biggest advantage is the validity, reliability, and uniformity of the examination. And all of you will agree with me that long cases have got their advantages and disadvantages. And the uniformity sometimes at stake because of the continuous assessment of the candidates from morning till evening. And uniformly assessing the candidates may become difficult. There are disadvantages of OSCE, but OSCE has got, because biggest challenge of OSCE is creation of OSCEs, and number of assessors and number of people who are dedicated to OSCE is very, very important. And it's very labor oriented by the teachers. They have to fully involve in the formation of OSCE and assessment. Suppose the students are more, we have to create more centers, more stations, and it requires a lot of effort by the faculty. But I should congratulate my department, who have done this continuously for the last 17 years. And when we started in the year 2005, we were probably one among the very few centers in the country who used to train students in OSCE. When I was examiner for DNB examination in Goa, I found that once the student goes to the OSCE stations, he cannot go back. And if he has committed the mistake because of his lack of awareness about how OSCE stations run, he'll get less marks, or he used to get failed in the examination. So with that, once he gets the mode of examination, the pattern of examination, he goes to that through the stations and understands the formation of stations, what they should do. The passing rate improved because after our 1 or 2 OSCEs, we got the feedback from DNB students that this type of mock examination is really good for appearing for the examination. With that encouragement, and this particular our OSCE program became very popular, and every year we get around 40 to 50 students coming from various states who are appearing for the OSCE. And again, I should congratulate the department for continuing this program in spite of all the hardships because of the pandemic situation. I think last year also they did it. This year also they're continuing. And the last few years we are adding long case presentation also, because PGs, MS PGs, they have got the still the traditional way of examination because of the new NMC guidelines or the Medical Council guidelines, they have to undergo the same pattern of examination. We cannot change it to the OSCE type of examination. So till the things change, or there may be again, even in OSCE stations, we have got short case presentations, small, again, short, but it is a validated case presentation. So till then, we have to continue the same pattern of examination for PGs. So with that intention, we are also adding PG long case presentation. I think this day, first day of this particular program, we have got 5 to 6 cases will be presented by different students from different colleges. And it will be really good to have very distinguished faculty who will be assessing the candidates. But unfortunately, due to COVID, we could not have it physically. And I understand it is again conducted in virtual format. I hope both this program, both long case presentation and tomorrow's OSCE, will be a great success and it will be beneficial to our students, both our MS and DNB students. Again, once again, I thank all my distinguished faculty and colleagues from Mangalore, all my ENT fraternity for participating in our program. And I hope your sustained support to our academic events will make us more encouraged to continue this legacy of having continuing medical education from the Department of ENT. Thank you very much.
Thank you, sir. I now request our respected Dean of KSHEMA Medical Academy, Professor Dr. Prakash PS, sir, to speak a few words.
Good morning, one and all. Honorable Vice Chancellor, sir, other dignitaries for attending this program, the postgraduate students, my own faculty of ENT. It's a commendable job which the Department of ENT is carrying, the legacy set by our Honorable Vice Chancellor, and even being continued today. We had this DNB program initially when we started the college in 2005. And 2005, we discontinued the DNB program, but still, in the interest of DNB students, the department has been conducting this OSCE workshop. And till 2019, it was a physical workshop where a lot of students had benefited and excellent feedback was given. But 2020 and 2021, unfortunately, happened to be COVID, and we could not carry on with these programs. Now, the Department of ENT has again initiated, though in an online mode. I'm sure this program is going to benefit lots of students, get exposure to the various examiners they're going to face, the methodology. I think the OSCE system is the way forward, even though Medical Council or National Medical Commission has not yet accepted this mode. Sooner or later, this is the system that's going to be introduced because the objectivity. Right now, the examination process, lot of subjectivity is there. So I think sooner or later, this system is going to be introduced, and I'm sure the ENT department will be the trendsetter, and they could guide the other departments how to conduct these programs, and they can create a workshop among our own other heads of departments and faculty and train them how to prepare for the OSCE stations in their own subjects. I'm sure the students are going to benefit from this. With these few words, I thank the Department of ENT. They have done an excellent job, and I thank one and all. Thank you.
Thank you, sir, for your support. Today, we have a very eminent personality among us, Professor Dr. Bharati MD. She's our own National President of Association of Otolaryngologists of India and Professor at GSS Mysore. Madam, I request you to speak a few words.
Hello, sir. Respected Vice Chancellor of Nitte University, Dr. Satish Bhandari, sir, then Dean of KSHEMA Medical Academy, and Registered Dr. Somayaji, and all my friends, Dr. Azim, Dr. Vadesh. First of all, I thank Dr. Vadesh and his team for inviting me to be here for this inaugural function, as well as to be a resource person in this academic event. And this event shows what Dr. Satish Bhandari sir had at 2004 is visionary. And this visionary of yours is been continued with the support of the department, and they're able to do it so academically and so beautifully, and they design everything so neatly. That shows what visionary Dr. Satish Bhandari sir had has been continuing with the help of the department. And now this event is what there are so many students who are there registered for this. What I need to tell for them is, see, there are two things we need to be focused on. One, the teaching. You should learn from your teachers in day-to-day activities. Yes, every day, the 3 years you spend with your teachers, you learn from them. Don't only depend on your YouTube channels. I see so many of these students, they say, oh yeah, this whatever it's operation is there, I'll see and then do later. No, it is, the 3 hours of surgery or 2 hours of surgery is just made it into 1 minute or 2 minutes of YouTube. You'll not learn everything. Whatever the things, what your teacher does, he'll teach you step by step, and what are the positive points or negative points, what are the difficulties he undergoes, and how he prepares pre-operatively and how he manages post-operatively. All these things you should learn from your teacher, not only the surgical, as well as the clinical rounds. You attend properly, you have you read and come. Whatever the cases are there in the ward, you make in the evening, when they are admitted, make notes of it. You read. Next day when you attend the rounds, you learn from your teachers. So this is what you need to do on every day-to-day basis. These are all the framed workshops which you attend. When you learn these 3 years, when you go to these workshops, then you will be perfect. Just attending a workshop without learning anything in your 3 years program will not help you. This is one thing I need to advise to the students who are there in this. And another thing is respect your patients. Okay, always have the faith, get the faith from your patient, and they should believe you. Okay, this rapport you develop with your patient, and never it's not the technology which help your patient, it is the belief of the patient in you, and then your skill that will help the patient. It is not the technology. You might be in a corporate hospital or whatever it is, but if you have the faith of the patient, then half of his disease will be cured by that faith, that belief of the patient in you. Then another 50% is what you do, that is there. So with this word, the AOI always supports the academic activity, and I want the youngsters to be there as well as learning all this. They should involve themselves in the research. Dr. Azim is there, is one of the very good researcher, and Dr. Satish Bhandari sir, I know he has done so many research, and Dr. Anil Kumar is there. So you should learn from your teachers all this research. It need not be very, mega research. A small point which you observe in your day-to-day, then you put it across, discuss with your teacher. That itself can be a small research project like that. There are so many funding agencies also. You apply for these funding agencies, and then you make yourself, you run in that path. You can be both clinician as well as a researcher. It's not like that. Like in my younger days, I used to say, no, I've got so many cases, I can't do research. It's not like this. You have to be research oriented along with your clinical. When you learn the clinical acumen, you get it. The research automatically comes in you. So with these few points, I thank Dr. Vadish Bhatt and his team for inviting me to be in this academic activity. Thank you, sir. Thank you, everyone.
Namaskara. ಒಂದು ನಿಮಿಷ ಅಜೀಮ್ ಅವರೇ, ನಿಮ್ಗೆ ತುಂಬಾ ನಾನು ಧನ್ಯವಾದಗಳು ಹೇಳಲಿಕ್ಕೆ ಇಚ್ಛಿಸ್ತೇನೆ. ಯಾಕಂತ ಹೇಳಿದ್ರೆ because Azim is a great supporter and he comes physically here in spite of all odds. Because I have to mention here, in all our workshops, physical, in spite of all difficulties, he came here and supported us. I should thank him for his this thing, dedication for teaching. Thank you very much. That's what one thing. And Dr. Bharati, as you said, we have got we are encouraging our own colleagues to get involved in research. We have got, I think whether you know or not, I would like to ask Vadish to put this thing, brochure on display. We have got Nitte University Healthcare Hackathon on 8th, 9th and 10th. Vadish, can you send the brochure to all our colleagues and institutions so that I request more ENT, both faculty and students to participate in that hackathon. And we have given 18 ideation and 8 of them from our own university. I think all our colleagues, all from my distinguished universities, JSS is there from Kolar and other universities also, Belgaum and Sapna is there. And we are sending this invitation. You can participate, even if it's 1 or 2 days late also will accept. I think immediately I request Vadish to give more visibility to that hackathon. And I think participation by our ENT colleagues will make us more encouraged or joyous. Thank you.
Thank you, sir. Thanks a lot. It's indeed a pleasure being here. In fact, I deem it my honor and privilege to be among you all in this prestigious teaching program, which has been going on since 2005, and with so many eminent faculty, Bharti Madam, Dr. Balakrishna Mohan Appaji, and yourself, Vadish, earlier Srinath, and Rajeshwari Madam. So many of them. It really adds to our knowledge also, and we feel younger being among the youngsters and sharing our thoughts and a clinical experience with them, guiding them. It's indeed a pleasure. And as Dr. Bharti Madam told, research is a part of a medical care. The people who are not giving medical care will not have clinical research. In fact, the term clinical epidemiology was coined in hardly in last decade. So things are changing, and the 3 aspects of our duties are patient care, teaching, and research. All 3 should go hand in hand. We'll definitely collaborate in various projects, sir. It's indeed a pleasure being here. Thank you, sir.
Thank you, sir. Thank you, madam, for your valuable advice on research and even to have a good rapport with the patients. I'd also like to thank all the delegates who have come for our online case presentation today. So saying that, let us start our academic program now. So today we have our first speaker will be from the Department of ENT, Dr. Kalam S.N. And our examiners for today are Professor Dr. Bharti MD from Mysore, Dr. Sapna Nambiar is a faculty from Calicut Medical College, Dr. Anil Kumar Hargu from KLE University, Belgaum, Dr. Devi Prasad, Head of Department of KMC Mangalore, Dr. Kuldeep Maras, Head of Department of Father Muller's Medical College. I welcome all of you examiners, and we look forward to academic feast today, both for the delegates and for the faculty.
Thank you.
Yes.
Thank you. You have to unmute. We can't hear you.
What this?
We can't
You
hear
are not audible. Not audible.
Am I audible now?
Yeah, you're audible.
Yeah, sorry. Sorry.
Good morning, all. What we thought is 1 hour for each case. The total, including the case presentation and the discussion. And 15 minutes, the examiners can give suggestions and opinion after that. So what could be done better and what was not good. Thank you. Shall we start now? Thank you. Thank you all for being here. Dr. Kalam, you can start.
Can we, Vadish, can we just have Dr. Kalam's video, maybe just
Yes.
problem later, we can put it off, but if you could just see.
Yes, he is present. Dr. Kalam, you can keep your video on.
Yes, sir. Sure. I was just setting it up.
Yes.
Good morning, everyone.
Yes, thank you.
Good
morning. Just before his presentation,
Yes.
I would like to put few words, sir.
Yes, sir.
Till today, I feel we are students. We learn a lot of things from Bharti Madam, Azim sir, and whenever we meet, so indirectly we learn many things. So that is a just input I wanted to put. And thank you, Madam, for your encouraging words to all of us.
Thank you, Dr. Anil.
It's mutual, sir. We also learn from you.
I know.
Thank
Any
you.
of these workshops or CMEs we go, we read and go, no? So we update ourselves.
Actually,
Yes,
the more we
Yeah.
interact, the more we learn.
Yes.
And the process should keep going.
Okay, sir.
Kalam, can we see you?
Yes, yes, ma'am. I'm audible.
Yeah, you are audible, but we cannot see you.
One second, just a second.
Video on karo. Your
Yes, ma'am.
video.
Just a second, ma'am.
No, he's done his video on. Madam, can you see? I can see him.
Yeah,
we
can see him.
Good morning, Kalam. Yeah.
Yes. I'll just stop my video. I'll start again.
Yeah, we can see you.
So all the best.
Yeah.
Good luck.
Be relaxed and present well. That's
Yes, ma'am.
important.
Sure. Thank you. Good morning, everyone. I am Dr. Kalam, second year ENT resident of KSHEMA Medical Academy. Today, I'm going to present a case of patient Muhammad Shamas, 18-year-old male. Is a college student hailing from Kannur district of Kerala. He presented to the hospital complaints of discharge from the right ear since 1 year and hard of hearing in the right side since 1 year. The history of presenting complaints: 18-year-old male was complaining of discharge from the right ear and hard of hearing in the right side since 1 year. The discharge was insidious in onset. It was gradually progressive, continuous, scanty, foul-smelling, and purulent, and occasionally blood-stained. Again, he had associated hard of hearing on the right side, which was insidious in onset, which was noticed after the beginning or after the symptoms of ear discharge, which was non-fluctuant and no aggravating as well as relieving factors. There was history of mouth breathing since childhood and associated snoring and occasional nasal obstruction. No associated or no history of nasal discharge, earache, tinnitus, vertigo, trauma to the ear, headache, fever or vomiting, double vision, difficulty in swallowing, no change in voice, or no history of deviation of the mouth. There was no signal.
1 minute, Kalam.
Yes,
You
ma'am.
mentioned about ear discharge,
Yes,
right?
ma'am. Yes, ma'am.
Could you specify? Could you just go back on that slide that you mentioned? Yeah.
Yes,
What did you mean by? How do you quantify this? You said he mentioned about scanty ear discharge, right?
yes, ma'am.
How did you quantify it as scanty?
Ma'am, according to the history of that 18-year-old boy, he has told that he would get discharge when he puts an earbud inside his ear.
No, you
That
mean
would
to
be-
say he uses earbuds and that's how he found he had discharge, or was he having discharge really?
Yeah, initially it was found only in the earbuds that he has inserted for regular cleaning. He had got, every time he inserts the earbud, he used to get yellow color also.
So how do you quantify ear discharge? Can you just tell me?
Quantification, was like it is scanty. It was in the beginning only during when he
No,
was.
I'm just asking you what are the types. So you say if it's scanty, it can be what, profuse. How do you go about? What are the?
Yes, ma'am. According to history, if you want to classify it as scanty or profuse, like if the patient is getting ear discharge or he's noticing ear discharge every time he takes a bath, or when he wakes up in the morning, if he sees a discharge on the pillow.
Exactly. That's the point. So when you find that a person's ear is profusely discharging, that is profuse ear discharge. Now you here are saying that he puts earbuds, which is again a habit that is condemned. And on top, he is getting a discharge, which really you have to be careful, because scanty is a word when you talk of that discharge. It's something that the patient doesn't say. It's sometimes when you examine and you find, and you actually do a mopping, that you find scanty. So if the patient gives you a ear discharge, most of the times it's either moderate or profuse or maybe intermittent. Now you said it is continuous.
Yes,
do you really think a scanty ear discharge is continuous?
Actually, ma'am, from history-wise, we cannot exactly take out whether it is continuous. But when I asked him, every time he used an earbud, there was a discharge.
Yeah, no. So that's where you have to be careful, because you're contradicting yourself.
Yes.
So be a little careful when you're using these words. I think you rightly said that it was progressive. Maybe you could say it's scanty rather than the patient complaining it's you who found it, and on examination. Then you said foul smelling, right?
Yes.
Can you tell me where do you get foul smelling and what is it really?
Foul smelling ear discharges is usually found in like if you the causes of foul smelling discharge. It is usually seen in the obstructed foreign body in the ear. In the external canal, it can cause foul smelling discharge, or meningitis externa can cause. Otherwise, chronic otitis media.
Obstructed foreign body, you're talking of, I think, nasal discharge. That's where the foul smelling unilateral nasal discharge. Yeah. What are the common causes of foul smell in the ear in a discharge? Some organism?
Yes, ma'am. Definitely. Otitis foul smelling. Pseudomonas can cause foul smelling discharge.
Okay. More of anaerobic organisms that you're looking for. Okay. Yes. Okay. And why do you think that's the only reason? Which other is the cause?
Definitely chronic otitis media with that is unsafe ear can also give a foul smelling.
Yeah, I think we've given up the safe unsafe. We now talk of mucosal and squamosal.
Sure.
So it's squamosal, which type?
Squamosal active type of squamosal.
Yeah, so you're talking of a cholesteatoma, you're thinking of a cholesteatoma, and you're thinking, right? Now you've written occasionally bloodstained.
Yes, ma'am.
What do you mean by occasionally bloodstained, and what do you think is the cause for that?
Occasionally bloodstained, sometimes he gave a history that whenever because he is more interested in getting this pus out from the ear, he usually puts the earbuds and gets blood in the earbud. And the most probable reason, I think it should be either it can be a trauma, or otherwise it can be the breaking of the granulation tissue that is usually formed.
So how can you distinguish between the two? One is a self-inflicted, is it self-limiting?
Yes, ma'am. If it is a trauma, it is always self-inflicted. But otherwise, if it is a granulation tissue, it is not self-inflicted, it is a part of the disease.
So here it is, here according to you, it is traumatic, right?
Ma'am, like in the history, actually what he said, we can consider it as traumatic, but there was no ear pain. So if at all there's a trauma or otitis externa, there should be associated ear pain, but there was the patient.
So again, we have a discrepancy there. We are talking of trauma, but there's no ear pain, right?
No.
Okay. Go ahead.
I think
yeah.
We need to add certain things here. History of bloodstained discharge, whenever he puts earbuds, that should be specified. And this gradually progressive, is it how do you this thing justified gradually progressive? Usually we don't use this word whenever there is a ear discharge. What it means from foul smelling, scanty, is it becoming this thing increase in the quantity? Do you mean to tell like that?
Actually, yes, sir. He, according to his history, that initially, that is 1 year back.
No, history is fine.
Yes,
But
sir.
pathophysiologically, how will you put gradually progressive? Usually, we don't use that. Progressive means something which is going from scanty to this thing.
Profuse.
Profuse.
Yes.
By 1 year, it should be flowing all the time.
Yes, sir. It's not actually flowing out, so I think I should change that to gradually progressive.
No, I feel personally the gradually progressive, that is the word. Usually we don't use it.
Yes,
I want opinion from Dr. Azim and Bharti madam.
You're right, sir.
Yeah.
Usually it has become a habit.
Yes, sir.
There are so many habits like that. In general examination, moderately built and nourished.
Yeah. Yes,
Dwarf,
exactly.
they say moderately built. He may be debilitated. They say moderately nourished. All this has become a habit. It's not a checklist. We have to speak according to the patient.
Yeah.
By definition, as you said, as Sapna madam said, if scanty discharge is there, it happens only on when he tries to clean the ear or he feels little wetness, nothing beyond that. If it's not staining the pillow, it cannot be profuse. If you say gradually progressive, I'll presume that either unsafe otitis, that is squamosal active otitis, or superadded trauma has led to maybe a traumatic perforation of the pars tensa, adding a middle ear component to it, adding a tympanic component to it rather than attic only. So it rather derails the history. I would have preferred the history being hearing loss associated with ear discharge. Or of course, the patient has come with hearing loss, we respect the patient's words. But this gradually progressive should not be there when you say scanty.
Yes.
Yeah, I think we go with that. Next slide.
Thank you.
Okay. Hard of hearing on the right side, incident. It started with the ear discharge, or like
After
what was
the-
the time gap between the two?
Around what he has told is around 1 to 2 weeks, but he also cannot recollect. The thing is,
Okay.
after the ear discharge, he has started getting reduced hearing.
Okay, correct. And then your notice started, correct. 2 weeks after the ear discharge, it started. Non-fluctuant. Why you have made this term non-fluctuant? What made you to?
I just want to know whether it was due to the ear discharge, because ear discharge was continuously it was going on throughout the ear, or it is due to any other diseases, just like if I said some viral disease can suddenly cause
No, here, see, you said scanty discharge.
Yes.
It is not profuse also. Profuse, at least if you clean the ear, maybe the patient might hear.
Yes.
And then afterwards, again, when it fills it, they'll not. But here it is scanty discharge, and only when the patient cleans the ear, he feels the discharge. I think this non-fluctuant you can take off.
Yes.
And hard of hearing your written. How do we assess clinically? Like in the history, you should ask the patient, what is the grade? Like you can assess it, no? How do you assess it?
Ma'am, that he is attending lectures in the college. So he told me that whenever the speaker or the lecturer speaks without using a microphone, it is difficult to hear on the right side.
That is what conversation you mean?
Conversation.
So you cannot hear the conversation voice.
Yes.
Okay, whispering?
Whispering, I haven't asked it.
That also. So how much of loss is there if at all the patient cannot hear the whispering, and how much of loss is there when he cannot hear the conversation voice?
Conversation usually around 25 to 30 decibels.
And whispering?
Whispering, I think it should be lesser than.
Any other students are there, or we only have to answer? Other medical, students are there with you, final years?
I think Bharti, he will be the one who would be answering, I think so. Isn't it,
Yes,
Bharti?
Yes, ma'am. Others can post in the YouTube.
In the chat, yeah.
Chat
They are
box,
not there on the Zoom.
Yes, ma'am.
Okay, let them
They're
post,
not-
then
yes.
we'll come back to that later.
Yes.
So these are the things you need to ask, Kalam.
Yes.
Whenever you say hard of hearing, insidious is correct. notice, that is after how many days of ear discharge. Non-fluctuant, depending on what condition, you should attach the terminology. Otherwise, here it doesn't hold good. No aggravating or relieving factors. When do you get this aggravating and relieving factors?
Ma'am, if there is any.
Can you be little loud?
Yes, sir.
Please.
Hello.
Yeah, tell. Continue.
So, aggravating and relieving factors like, for example, when he uses any medications and the discharge has to come down, and if he is better.
But according to you, it's a continuous discharge. There's nowhere the discharge is, not there. So this is also a little contradicting statement.
Sorry, Dr. Kalam.
Yes, sir.
You have written continuous in the beginning itself.
Yes, sir.
So if it increases or decreases, the aggravating and relieving factors come into picture. Okay.
Yes, sir.
Fluctuant hearing loss is a condition where a sensory component has been added to it.
Yes,
in this case, it can be a complication,
yes,
the labyrinthine fistula. Okay.
Yes,
So as Bharti Madam said, that term should not be here. Okay.
yes, sir. Yes,
It can increase and decrease a little bit. That comes under aggravating and relieving factors. Okay.
Dr. Kalam, one question.
Yes.
Can we add progressive here with respect to the hard of hearing?
Respect to hard of hearing.
Does it fit there here in context to hearing loss?
I think so. We can fix.
See, as the disease or the pathophysiology progresses, your hearing loss progresses here.
Yes, madam.
That you can put here. Okay. Yeah.
Because it just indicates how the disease is progressing. Okay. So maybe it's related to the destructive process, maybe in the middle ear, okay, or related to ossicles. So you can add it here.
Yes.
Okay. Not in the discharge. Fine.
Yes.
I think Dr. Azim will agree with us.
Sure, sir, definitely.
Yeah. Thank you.
Thank you.
Kalam, I think Madam just mentioned, Bharti Madam rightly mentioned, see, when there is discharge, Azim sir also said, when there is discharge, you wrote non-fluctuant. Can you give any example of fluctuant hearing loss? Or when does it take place? Why does it take place? I mean, for that you'll have to know the physiology of hearing. Does it happen with a chronic otitis media, fluctuating hearing loss? Can you explain? Since you put the word non-fluctuant there.
Just a second. Ma'am, fluctuant hearing loss, maybe in case of any, I think you can consider.
Don't worry, I'm sure in your practice, you must have seen some patients coming and saying, when immediately this thing is cleared, or when the ear in fact is filled, he hears better.
Yes,
have you ever gone why it happens like that? Can you just probably throw light on that?
Ma'am, like when we remove the.
I think this question is important. What Dr. Sapna Madam is asking.
Like if
somewhere he has given clue also.
Yes, actually, if there is an obstruction in the external auditory canal and we have removed it, then the hearing can improve. Hello, sir.
Obstruction in external auditory canal or elsewhere?
Even in, for example.
No, I think Madam has made very clear in context to this thing, physiological correlation. Okay.
Sir, for example, if the ossicles,
what we mean to tell, it may not exactly fit into this continuous discharge. Okay.
So if the ossicles,
relation, you can try to correlate with physiology and the fluctuant hearing loss, especially in CSO.
In CSO, sir, if when the medullary cavity is completely filled with discharge, it might affect the movement of the ossicles. Where after medications, if the discharge has come down, the hearing can improve. In other diseases, for example, in case of a squamous cell disease, if there is any erosion of the ossicles, it can the hearing can actually decrease, and later when that cholesteatoma is going or is making the occipital continuity, then again the hearing can actually improve. Then so that can be one example of fluctuant hearing.
Okay.
I think
I think
Again,
yes, madam.
again, I would not put it as fluctuant, Dr. Kalam. I would put it as aggravating and relevant. Okay.
Okay, sir. Sir, I think to do with I think we are getting into that steppies foot plate or anything hypermobile steppies foot plate. But it also
Dr. Kalam, whatever your cholesteatoma may bridge the ossicles, it's not going to replace the ossicle. It cannot
Yes,
become part of the transformer mechanism, isn't it?
Yes, sir. Correct.
Why did you ask for history of mouth breathing and snoring?
Ma'am, because we have to find any cause for any infection in the middle or a root of it. So I was just.
Tell us the duration of this.
Pardon me, sir.
1 year.
1 year.
1 year.
1 year.
Yeah.
So,
Okay. Next slide.
How is it relevant here? Mouth breathing, snoring for last 1 year in this kind of.
Sir, actually, mouth breathing and snoring since childhood he is having. And I explained you.
So why do you think it is still persisting? Mouth breathing and snoring?
Yes, sir. It is still persisting.
No. What could be the reason at this age? He's 18 already.
Yes, sir. He's 18 already. From since childhood, he's having this complaint, and it is still persisting.
So do you think it is relevant for this particular trouble that it is causing in the ear?
Sir, I think it should have some relevance because when we are looking for any medullary pathology, we also have to find the source of medullary pathology. So there is no history of trauma. So from the history side, I think we can discard any entry of infection from the external.
There should be some issue in the nose and the nasopharynx.
Yes, sir. Yes, sir. I am suspecting any.
But for a squamous cell type of disease, do we still keep blaming the nasopharynx and nose?
Sir, yes, sir, definitely we can. I think because
I don't think that is relevant. You mean to say you're going to treat that first, or you're going to treat his ear first?
Sorry, in this case of squamous cell disease, we have to treat both actually.
Then what difference will it make?
Yes, sir. We have to make the ear safe, as well as we have to treat the cause if there is a nose and paranasal sense of
if it has been persistent problem since long, we may have to treat it as, but I don't think that is directly going to affect the way you're going to treat his disease. If it is squamous cell, we don't know yet.
Yes, sir.
So that's why I'm asking. So this is also something that probably you need to look into. Why is still breathing through mouth?
Yes, sir.
And what are we looking as the primary cause for that?
Yes.
Okay, fine.
Dr. Kalam, I would agree with Dr. Dev Prasad. If it's tubotympanic, of course, we have not gone to findings, so I don't want to tell anything prematurely when I have not seen the perforation. But yes, the attic, the ventilation is totally different. It depends on tympanic diaphragm and his isthmus between it. So unless there is a tubotympanic component, I don't think this patient will have much contribution from any nasopharyngeal pathology.
Yes.
It's very common to find a normal pars tensa with cone of light with adequate middle space that you can probably make out because there's no retraction, but you'll still find all attic pathology in those patients. So again, this obstruction, I understand patient has, you need to mention that is true.
Yes,
but if you're trying to put these two things together,
yes,
I don't know whether that will actually match.
Okay.
You can go on.
Okay, sir.
When do you get earache in these patients?
Madam, earache, actually one of the cardinal signs of chronic otitis media is ear pain. That can be considered. Otherwise, if there is an otitis external, which is caused due to that discharging ear, that can cause an earache.
Yes. I mean, but you said in this case, it's a continuous ear discharge. Then also, whenever there is exacerbation is there, you might get ear pain. The other one is whenever, because of the trauma the patient is doing to the external aortic canal, you might have otitis externa. Or if the mastoid air cell system become inflamed, then you can get the pain. Or in complications. Okay. Anyway, with the history, you don't have any complications in this patient. But in other patients with complications also, you can have ear pain, like petrositis or lateral sinus thrombophlebitis, all this. And then another thing is, see, when you have a ear discharge on this side, patient might not move his, he might not chew on this side at all. So the temporomandibular joint problem also can cause earache. This is the last thing you can think of. Okay. Then you said hard of hearing. With that history of hard of hearing, is this third and the fourth symptom is important for you?
Tinnitus and vertigo again, if it is a chronic otitis media, and if it is going for any complications of chronic otitis media, we have to check for we have to ask the history of tinnitus.
Yeah. See, whenever you have a hard of hearing, this history, the other aspect, it might be the inner ear may be involved. So with tinnitus and vertigo may be a part of it. So you might think that you are hard of hearing, whether it's a conductive type or SN loss, depending on these two symptoms, you can go ahead with your history. I'm not 100% sure here. Okay. Trauma to the ear, headache, fever, vomiting, double vision, all these are, you have asked for the complications, isn't it?
Yes, ma'am. Complications.
Okay. They're not there. Okay. I think we can move on to the next slide, no?
Yes.
Yeah.
No significant past history as well as
this past history. See, the 1 year history, you asked for nasal, what is that, snoring and mouth breathing. Actually, you should have asked here rather than there.
Okay.
Okay. Then it would have made some sense. Okay. Yeah.
What is the significant word? So what are significant, what all history did you ask in past history, Kalam, for 18-year-old child, an 18-year-old boy who's coming to you with this symptom?
Ma'am, actually, I asked if he had any complaints.
Pardon? Can you be loud?
Any complaints of ear? Any other complaints?
Okay, okay, good.
That has been asked. Any complaint in the opposite ear also asked.
Okay.
Then I have asked if he is having any history of asthma or regular upper respiratory tract infections.
Okay. Is there any history being in a nation, kind of a country, any particular thing that you would like to ask and rule out? It can present like this?
Tuberculosis, ma'am?
Very good. Yes, you must ask for tuberculosis. So you must write no history of COX and COX contact.
Yes,
it is important with hearing loss, especially.
Yes.
Anything else? What other diseases? I'm just trying to find out what you would have asked or what is relevant. So what happens is when you mention that, I know that you already know it. When you write like this, I have to really ask you a question to know what it is. So maybe telling a few relevant things would be better. That's all. Go ahead. Good.
And go ahead with the slides.
Yeah, go to the next slide.
Again, no family history. Personal history, there is normal sleep and wake cycles, normal blood and bowel.
Sorry to intervene.
Yes.
All the significant no family history. You may have so much family history. Nothing contributing to your case. That's all. Yes. Use the term contributory to your case.
Yes,
okay?
Sir. Yes, sir.
In anything else you would like to personal history you want to add, which is more particular or relevant in this kind of presentation? Because I have not seen a patient with chronic otitis media having any issues with bowel, bladder, sleep and all that. So I usually feel it is totally irrelevant to put the same things that we use in a case of maybe general medicine that we end up putting it here.
Yes,
You
yes.
should modify it for ENT, and so you should know what exactly to ask in personal history. It is very relevant. What would you ask under personal history? What do you expect this patient to do with his ears? What care he should take?
Already you have told it, probably in the history when we were discussing.
Yes, the cleaning of the ears.
Yes, his cleaning
Okay.
habits, whether he's allowing water entry to the ear while
Yes.
having
Yes.
bath, will be taking care.
Yes, sir. Actually,
These are things which are more relevant.
yes, sir.
Very unlikely that it will anyway affect his bowel bladder habits.
Yes.
Yeah.
Yes.
Rightly, as Azim sir mentioned, there are a lot of things you do as, general assumption. That is very bad. It actually creates a bad impression rather if you just tell the relevant things, Kalam, that,
Yes, ma'am.
impresses your examiners better. So, you're not just making a passing statement.
It's
There's
not
no
just,
way
yeah,
we take it like that.
it's not just examiner. You imagine the patient. He'll go
Yeah,
around
yeah.
saying, "Kivi tondre andre motion ge hogidra keltare." Isn't it?
Yes, sir.
It becomes
I'm very sure you wouldn't have asked about his bowel bladder habits for whatever reason while taking this, isn't it?
Yes, sir.
Exactly.
Yes, sir. General physical examination. Patient is conscious and oriented. There is no pyloric examination, clubbing or lymphadenopathy. Pulse rate was 88 beats per minute, and blood pressure was 180/70 millimeters of mercury.
Whenever you're presenting, Kalam, please don't use short forms like BPM and all. These are not acceptable short forms.
Yes, ma'am.
On the slide, either you don't write it or just write per minute,
Yes,
or don't make new short forms which, are not approved.
yes, ma'am.
Okay?
Okay.
Okay. Can you, in your summarized history, what did you feel is your patient having? Because you're going to examine your patient on that basis.
Yes, ma'am.
So what did you feel from your history? What does your patient have? Or what do you think your patient has?
Based on the history of the patient, that is, he's having a discharging ear, which was foul smelling and purulent. And then the complaint that he was having a hard of hearing or decreased hearing in the same ear for 1 year, I would actually think of a Medullary pathology and would like to proceed accordingly.
The Medullary pathology is a very gross term. You have to tell, what are you thinking? Are you
I'm thinking of
squamosal? What are you thinking?
I'm thinking of a squamosal disease.
Inflammatory condition of the middle ear, probably squamous type, isn't it?
Yes.
Yeah.
Examination of the ear. In the right ear, preauricular area, inner and postauricular area are normal. There was
One thing, Kalam, in your general examination, did you mention about the temperature of the patient?
Ma'am, he was febrile when he has.
Why is it important?
Because, ma'am, if you are suspecting any complications, then we have to check for
Which
temperature.
complication?
Like lateral sinus thrombophlebitis.
Okay, what are you suspecting there?
Ma'am, in lateral sinus thrombophlebitis, the patient can be febrile as well as the patient can go for bradycardia.
What does the patient have in lateral sinus? Can you please tell once again? I can't hear you. Can you be loud?
Yes, ma'am. Lateral sinus thrombophlebitis means complication of CSY, wherein the patient will have high-grade fever. High-grade fever as well as.
What kind of fever do they have? What is that called?
The picket fence type of fever.
So what is that? What is this picket fence fever?
Ma'am, it will have a regular spikes and then it will come back to normal.
What are the types of fever that you know about?
One is picket fence type fever. Then we have the step ladder type of fever where the temperature keep on increasing up to that.
Where do you get this step ladder?
That is usually in typhoid disease we get step ladder.
Okay, what are the other types? Good.
Ma'am, then we have the intermittent type fever where patient can have fever and then come back to normal state.
You mentioned intermittent, is it?
Yes, ma'am.
Yeah, what is intermittent fever?
Ma'am, intermittent fever, when the patient feels, the patient has fever, And then there are phases of normal body temperature.
Okay, what are the other type? What is the other type?
Other type, then we have the
have you heard of remittent?
Yes, ma'am.
What is the difference in intermittent and remittent fever?
Where the baseline temperature will not come down to normal in between.
No. The temperature is already high. It will not come to baseline in remittent. It will remain above.
Yes.
Whereas, and you have to know examples of all these kinds of fevers. Okay.
Yes.
Have you ever heard of something called Palpate fever?
Yes, ma'am. Palpate fever. I have heard about Palpate fever.
In which condition?
If I recollect Palpate fever, I think it is in
Any malignancy?
I mean, Hodgkin's lymphoma.
Yes,
Yeah,
yes. So if,
go ahead. Yeah, sir, carry on.
sorry. So if the patient had any feature of sigmoid sinus thrombophlebitis, he would have come to you with totally different complaints. He would not have been bothered about his hearing loss at all. He would have come to you with high fever.
Very high fever.
Yes.
Patient will be sick.
Toxic patient.
Fever. And
patient will be very sick. With toxic.
Headache, all that. Okay, it will be much more acute presentation. They will not come like this.
Yes, sir.
Okay?
Yes, sir. Moving on to the examination of ear. In the right ear preauricular area, pinna, and the posterior area was normal. There was no tragal or mastoid tenderness. External auditory canal on the right ear, we had seen purulent discharge, which was cleaned.
Okay. This mastoid tenderness, where did you elicit?
Mastoid tenderness also elicited on that Simba conchi. Yes. Against the mastoid.
Only Simba conchi or any other areas also you checked for?
Yeah, actually that the 3-finger test, but it is absolute I have heard. But
so one is at the Simba concha, then second one is?
At the mastoid tip, we can press behind.
Third?
Post-auricular region.
Posterior border of the mastoid. That is the, isn't it? So one is at Simba concha, that is you are checking over the mastoid antrum, tenderness over the mastoid antrum. Then other one is at the tip of the mastoid. Third is at the posterior border of the mastoid, where you will be checking if the mastoid emissary in that region is inflamed. Okay, these are the 3 areas we check. Then
whenever you use the term preauricular, postauricular, in between it becomes auricle. Pinna is layman's term, isn't it?
Yes, sir. So
you can start with pinna.
Yes.
Usually we teach all our students starting with pinna, then pre-postauricular area.
Yes.
Anil, generally here in the south we tell pre-auricular, post-auricular, and then they say the pinna sometimes. I don't know, but generally our students tend to tell about these 2 areas. I mean, it's okay. Either way, but it's fine.
Dr. Kalam.
Tragal tenderness, how do you elicit? Tragal tenderness.
Tragal tenderness can be elicited by pressing the tragus against the opening of the external auditory canal.
Okay. When do you get it?
Usually seen in otitis externa, that is the lateral to the auditory. But in otitis externa, we can get tragal tenderness.
How to make out?
Sir, the moment we press, the patient will withdraw the head, and it is very significant.
Children do. You try to touch their head, they will go back.
Yes, sir, they will go back. Yes, sure.
Is it going back the sign or it is a sign?
So actually, in children, actually, if you hold the pinna itself, if you try to just pull the pinna itself.
Pinna tenderness then?
Actually, not pinna tenderness, sir. That's actually called circumvention testing. It is when you try to pull the pinna,
Okay.
The child will have movement of skin in the external auditory canal, and then the child would actually refuse to cooperate for further examination.
Eliciting this in child is always a difficult task. In this context, 18-year-old, so when you press the tragus against the canal, what are you looking for?
We are looking for pain elicitor, sir. And he did not complain of
pain. Is what patient feels. You can't feel his pain.
Yes, sir. You can just look at the facial expression of the patient.
So that's what I'm asking.
Wincing.
So it is the expression.
Wincing.
If you don't press the tragus and ask, does it hurt here? He would have come for the same reason. He will say, yeah, it hurts here.
Yes.
So again, that doesn't become a sign. It
Yes,
doesn't become tenderness.
Yes.
You need to look for the expression because it is a sign that you're eliciting,
Yes.
and you can't be asking the symptom again because that happens with ear pain. You press on the mastod and ask the patient, you would have come for the same reason. He says, yes, that's where it hurts. That doesn't become mastod tenderness. Okay, you need to look for the expression. If the patient is wincing, then only it is positive.
Yes.
And coming to this discharge type, how do you know it is purulent or mucopurulent? How to make out that?
Sir, purulent discharges are usually yellow in color.
I didn't get you.
Purulent discharges are usually yellowish in color.
Okay.
Or
What
you
about
can see
mucopurulent?
frank pus. Mucopurulent, we can see whitish as well as sticky type of whitish, yellowish.
Stink is not the consistency. Stink is the smell.
Yes, sir. Sir, it's not
Sticky.
sticky.
Yeah.
I told sticky.
Mucoid, yeah.
Mucoid. Yes, sir.
So basically, when you are using doing a dry mopping,
Yes, sir.
if it is coming as a streak, then you
Yes,
know
sir.
there is a mucus component.
Yes,
Okay.
sir. Yes, sir. And it is mixed with purulence, it is mucopurulent. Otherwise, only sticky discharge means it is mucoid discharge. It is white clear type of discharge, it is serous discharge.
Okay. All right. So where was this discharge? Completely covering the canal or only on the floor?
No, sir. Only on the floor I had seen.
Then you better be precise.
You need to, yeah. See, whenever you have written purulent discharge, you need to characterize the discharge, what you see there. You need to put out, see, otherwise we wouldn't have asked so many questions, isn't it?
Yes, ma'am.
When you start making your examiners ask the question, then you'll be, track will change. Better is you yourself describe properly, then we'll not ask any questions here. Okay. So can you just tell about the discharge, what you saw in your patient?
It was purulent or yellowish discharge, which was seen in the floor of the external auditory canal.
The entire floor or only near the drum?
Only near the drum.
Huh.
Near the drum. It was very less, and it was not disflowing outside or external to the
I think these words are important. What Bharati Madam is telling. Okay, it is very close to the floor. Okay, or close to the membrane. It's just to indicate that it's scanty.
And when you cleaned with the probe, Jobson on probe, it's not
Yes,
sticky.
Yeah.
That point you should put.
Yes.
And then when you take it out, you need to smell it
Yes,
also.
smell.
Yes.
Yeah, that also you should put it. Okay. Yeah.
It was not smelling while I had cleaned it. I had smelled it and it was not smelling.
And examination of the ear, before you start, you should tell how you did the examination. Like how
by
you did
using bullseye lamp.
Yes, whether bullseye lamp or the headlight. These days we all use headlights, and even you people are also using. So you need not be like, like olden days only bullseye. You did not. You can, as the science advances, technology advances, we can also advance in the exams. It's not that only bullseye lamp I'll stick on. Okay. Headlight is used for your examination.
Yes,
and then you have explained to the patient that you are examining him, you are examining his ear, all that you need to tell. Okay.
Yes,
that you need to specify there.
I think I strongly agree with what Bharati Madam just said. We need to move with developments and technology.
Yes.
You only hitch is here. If the examiner has made the student examine with a bullseye lamp, he should also see with the bullseye lamp only. He cannot give a bullock cart to the student and drive a Mercedes Benz, isn't it?
Correct.
Same with laryngoscopy. If the examiner has used a telescope, give the same telescope to the candidate. You cannot give an ideal mirror and you assess by a telescope. And at this point, for the students also, it's very important. Even with technology, the conventional examination you should be familiar with. Indirect laryngoscopy has its own advantage. It gives a panoramic view. It will tell you how difficult the DL scope is going to be. So you should be conversant with both types. Okay?
Yes.
Yeah, next slide.
This is the right tympanic membrane, as you can see here. The right tympanic membrane, you can see a retraction in the pars flaccida with the scutum erosion, and polystitum of flakes can be seen within, and the margins were congested.
Kalam, do you have an autoendoscopic
Yes, ma'am.
picture?
Yes, ma'am.
Okay.
This is the autoendoscopic picture, as you can see now. Pointing here, this is the pars flaccida, where there is a retraction of the pars flaccida, as you can see here, and polystitum of flakes can be seen within, and the scutum has been eroded.
Yeah.
Part of the tympanic membrane was congested.
Why I asked is there is a difference in the picture you've drawn and the picture you're seeing on autoendoscopy. So there is a difference, because when you describe, your description should perfectly fit what you're saying. That's actually very important as a postgraduate.
Yes.
And this is what you need to actually practice over the years.
Yes.
Even in my days, I thought, how does it matter, when you say one here or one there? But it is when you get into surgery and see the results, and then you start that you realize why examiners. Even I, as a student, thought, people so worried if I say scutum and it's not eroded. But your diagram is not really in line with the autoendoscopic finding. So that is something you must. Why am I saying is the scutum is, what is scutum? Can you just tell us?
Scutum is the part of temporal bone which is lying above the sharpness membrane. That is above the pars flaccida.
Yeah. So in your diagram that you have shown here, it had that entire thing is gone in the attic, whereas the diagram is showing just a part of it that is involved. Modify what you have described about the right tympanic membrane once again.
Pardon me, I just lost some.
This description that you've written,
Yes,
would you like to say it in a better way from that picture that you see? What do you want to tell about the tensa to us?
Past tensa was not affected.
Dr. Kalam,
Yes, sir.
Straight away, what Madam was asking, do you feel the anti-retic is in node or post-retic is in node? Or whole of the retic is in node? Just we wanted to clarify. Because ultimately, the management differs whether it is a post-retic, anti-retic, or whole of the retic. That's what we want to know.
With the anterior retic is involved according to the findings.
Even few millimeters of difference, no? Yes, in the picture, what you have drawn and the autoendoscopic finding, yes, it makes a lot of difference. What yes, we mean to tell is.
How much of the scutum is eroded here? Is it important?
Yes, sir.
Why?
Sir, it will let us know the.
Go to the next slide and show.
Yes.
Yeah.
Here,
see, looks like the whole retic is involved. And what the diagram you have drawn, it is confined to the anterior. Okay? Because pathophysiologically, the antiretic pathology is different, and the posteretic the pathology is different. Whole retic is different. Okay, and the pathophysiology, how it functions, and the management. Because by this time, even all of us have understood, and you have also understood. But at the end of the third year, okay, the pathophysiology of the various types of cholesteatomas. Okay, so that will come to that. Okay.
How do you grade this retraction?
Sir, as there is scutum erosion, I shall grade it as grade 3, sir.
What is the difference between 3 and 4?
Grade 4, there is destruction of the adequate destruction of the scutum. So better grade it as 4.
Adequate the term? What do you mean by adequate destruction?
Like the entire scutum is involved or eroded.
Okay. Do you think here it is only minimal erosion of the scutum?
No, sir. Actually, if you consider the entire scrotum is actually eroded.
A pars flaccida is a very limited area actually. The
Yes,
amount
sir.
of destruction that you're seeing here,
Yes, sir.
I feel you can't call it minimal erosion of or minimal destruction of the scrotum. So, what are the gradings?
Sir, first grading is where there is just a retraction pocket, which is not heading. I mean, it is not in contact with the malleus, head of malleus.
Which part of the malleus?
Head of malleus, sir.
I differ with that. Any
Neck, sir. Neck of malleus. Sir.
Neck of the malleus. Okay.
Yes,
Two.
Yes, sir. And
Neck.
yes, sir.
So, which exact area is getting retracted here?
Sir, the pars flaccida is getting retracted.
I know.
Sir.
In pars flaccida, which is that exact part which is actually getting retracted?
Sir, the Prusac space, sir.
Fine. Yes, all right. So I see a significant destruction, and you see those flakes underneath.
Yes, sir.
So I would ask you to, I mean, rather upgrade it and say that there is a significant.
Dr. Kalam.
Yes, sir.
Am I audible?
Sir, there is a lot of disturbance.
Yeah, somebody's disturbance is there. Mohan, I mean, somebody is logging with two devices.
Oh, sorry, Bharti. I'll 1 minute. Sorry.
Yeah, yeah.
I'll mute it.
Dr. Kalam.
Yes, sir. Yes, sir.
Straight away, one question. Is there any attic perforation or retraction? According to you?
Sir, attic perforation.
Okay. Can you justify how it is perforation? Why it is not retraction?
Yes, sir. If just retraction, then.
No. You told it is perforation. Okay.
Yes, sir. Yes, sir.
So can you just add few points in favor that it is a perforation, attic perforation, not retraction?
Sir, formation of that, we can see polystatoma flakes in there, and that it cannot be formed in just a retraction because it can get cleared anytime.
You can get flakes in a retraction pocket.
We can get, ma'am, but this much of.
What you should see to say it is only
yes,
a pocket, and
no, that is
see that
definitely
it could be a perforation.
Yes, sir. That's definitely the medullary condense. If you can see.
No. How do you confirm it is not perforation and it is not? It's just it. How do you confirm?
If you see some part of this sac, you will say it is only retraction. And when you don't see that, you call it perforation. You'll have to assume that it is perforation.
Yes.
What is that?
What is that part of the sac which is, if seen, we said it's retraction?
So the margins of the sac.
Okay, the depth, what is it called? This is not your final exam. We can have it as a fun moment. So
No,
what
sir.
are we looking for?
Sir, if it is a retraction pocket, we can actually see the margins moving inside.
Margin is out here.
No, forget margins. Anything else with respect
The sac
to
itself.
the retraction. No, sac is a.
You have fun. So what is it?
They are giving you the clue, man. It starts.
Forget margins. Forget sac. Anything else
In the stomach, what starts with
retraction?
in the stomach?
Fundus.
Yeah, fundus. Okay. When will you make out? In addition to Dr. Devi he was telling, when do you see the fundus? What you would like to do? That will add to the next this thing, clarification, perforation or retraction. What we should do to find the fundus and perforation?
So you can go around the margins.
No, I think we need to go for this thing, suction clearance. Okay, using an endoscope. Okay,
yes.
We have to use that available latest devices, no? As we were telling. Okay, headlight. Next is the microscope or an endoscope. Okay. Yes. Nowadays, most of the institutions are having endoscope in their OPD. Okay, you can do as a outpatient procedure only.
So you examine this otoscopic finding, you're done. Okay, next continue, Karo.
Yes.
Continuing to the left tympanic membrane, I could see a healed perforation in the anterior part of pars flaccida. I have a otoscopic endoscopic picture of this. As you can see here, there's a healed perforation.
Along with this observation, any other test you do when you are doing otoscopic examinations? Anything you ask?
Like bilaterally, when I have found there is this one the Valsalva.
Yes, you need to see the movement, no?
Movement, yeah.
At least
Movement of
to a certain extent, you can observe with your otoscope also.
Yes.
Then you can confirm with your endoscope or microscopic examination. Okay.
Yeah. This is what exactly when you have got findings on both the sides. Sometimes we need to go one step behind. Okay, as Madam told, the eustachian tube again come back. Okay.
And is it safer to say the pars flaccida is thinned out? I understand it is looking much thinner than what it is usually. Yes. Because I am not very sure whether you get a healing in the pars flaccida. You say healed pars flaccida. I doubt that such a concept exists where the pars flaccida perforates and then heals. Pars tensa, yeah, we do agree it heals. Yes. But pars flaccida, once it perforates, I feel it is not going to be safe anymore to call it as a healed pars flaccida. I don't know whether theoretically that happens, but I would like you to probably put it as a thinned out pars flaccida.
Sure, sir. Shall consider this as a thinned out anterior part of the pars flaccida, as seen in the left ear.
Next.
Coming to the clinical test. So here we can, on exiting the release tester, the patient had a negative release on the right ear for 256 and 512 minutes of clinical test, that is release test, and the positive for 1024 hertz. The left ear was for all frequencies, it was positive. The Weber's test was lateralized to the right ear, that is the diseased ear. And the observed bone conduction test was same as that of mine. Facial nerve was within normal.
So with your tuning fork test, what is your inference? Go back to the last slide. Yeah.
Yes. Now, as you can see here in the release test in 256 and 512 hertz, the patient had better bone conduction than air conduction in both these frequencies. And the Weber test was lateralized to the Wasser ear. So I would suggest that patient was having a conductive hearing loss.
Approximately what severity?
So moderate severity.
Tell me in decibels. Approximately what decibels?
Sir, around 30 decibels, 25 to 30 decibels.
Yes, around 20 to 30 decibel in this. Okay.
Your facial nerve examination was within normal limits. Robert's test was negative and Fischler's test was negative. Proceeding to the examination of the nose, external framework was normal, columella vestibule was normal. Anterior rhinoscopy, there was a deviated nasal septum to the left with spur, and in posterior rhinoscopy, there was hypertrophy of adenoid tissue. Examination of the oral cavity. Yes.
About Kalam, hypertrophied adenoid tissue, what grade is it? What is it doing? Is it was it seen on posterior rhinoscopy? Is it obstructing your choana? Is it obstructing?
No, it was just size? It was just partially obstructing the choana. However, there was adequate space.
It is obstructing which choana? Both.
Both. Choana is actually posterior. It is common for both. It was on the both sides. It was obstructing.
Okay. Fine. So go ahead. I think we are less on time. So go ahead. Yeah.
An examination of the oral cavity, mouth opening was adequate. Lips and angle of mouth was normal. Gingiva buccal and gingival labial sulcus was normal. Teeth was crowded, anteriorly crowded.
What is your inference?
Sir, I have seen.
Are there any findings contributory?
Yes, sir. The patient was having adenoid facies.
Okay, something like that. Huh? Fine.
Yes,
Next.
In oropharyngeal examination.
Okay. Next.
Examination of the neck was also nothing.
What are you expecting in examination of a neck in a ear case? Just
Ma'am, if there is any complications of CSY, there can be swelling that can, or abscess that can break.
for the swelling.
Pardon me, ma'am?
Where are you looking for the swelling?
Ma'am, usually in the neck we will look in near the angle of the mandible, or we can trace the digastric muscle near to that point.
Which
Posterior belly of digastric and along the sternocleidomastoid.
Yes,
Yeah.
Resolved sepsis and fetal sepsis.
Okay.
Yeah.
Go ahead, go ahead.
Yes, sir. Systemic examination was all within normal limits.
Okay. Next.
I come to the diagnosis of our case. The 18-year-old male was suffering from chronic otitis media, squamous cell active with right-sided moderate conductive hearing loss and adenoid hypertrophy.
Can we start with side first?
Yes, sir. Sure, sir. Right-sided chronic otitis. I have just missed that.
That gives this thing, like because everyone is eager to listen which side is affected first. I think that's better. We should start with side.
So it is right-sided chronic otitis media, squamous cell active, because you are having the discharge with moderate conductive hearing loss, because your tuning fork test. History also, the patient was not able to hear the conversational voice.
Yes.
And on your tuning fork test, you had Rinne's negative with both 256 and 512. See, the speech frequency is normally, the Rinne's, we will be testing between 500 to 2000 hertz, isn't it? That's the normal conversational speech frequency. The 20 to 22 hertz, 20,000 hertz is there. But for the conversation, it is 500 to 2000 hertz. So you are testing with that. And then your Weber's was lateralized to the right.
Affected ear. Yes.
Okay. That's why we have put it as moderate conductive hearing loss. And with the adenoid facies. Yes?
Yes, ma'am.
And you have done posterior rhinoscopy, also showed anything?
Yeah, I have posterior rhinoscopy. There was adenoid hypertrophy. And actually, I went on to do a diagnostic nasal endoscopy, and I had a picture of it also.
Okay. Adenoid with adenoid hypertrophy. Okay. Now, how do you proceed with your patient? I think we are having another 15 minutes for the discussion.
Yes.
Okay.
Proceed with the patient. I would like to first. I would like to conduct a examination under microscope to confirm what findings I have seen through the otoscope.
Okay.
And whenever I see a discharge, I would like to collect a sample for culture and sensitivity so that I am adequate antibiotic.
How do you collect the sample from the external canal?
We can swab by using.
First, we need to clear the outer aspect.
Yes,
okay. That part you should not send. From the deep meatus, you should take and send it for what you write when you send it for?
Ear swab, middle ear. You write the middle ear secretions for the ear swab.
What do you write in the form you send for the microbiology? What test?
Culture sensitivity test.
Only culture sensitivity before that.
Gram staining.
Gram stain. Gram stain is done with what stain?
At least I just take liberty, madam.
Yes,
3-4 stains they should use. They should know like gram staining, Albert staining, ZF. Sometimes some examiners they will be very particular. So
yes.
If you don't know, you can you should try to memorize them. Okay.
Yes.
See, always whenever you send for any investigation, you should write properly in that form what you want from the either the microbiology, pathology, or radio imaging. Otherwise, how do they know? They just take your samples. That's all, no?
Yes.
If you write properly, they'll understand. So gram stain and culture sensitivity. And second one is you need all cases to be sent for fungus, KOH also.
Yes. Yes.
Okay.
Sure.
So these two things is a must.
Yes. Yes.
And from the deep meatus. So that is your first. Then what you do with either otomicroscopy or endoscopy?
Then when we continue with the examination under microscope, we'll look for we'll confirm whatever findings we have got. That is, we'll look for the attic erosion, with sputum erosion. We'll confirm it. We'll confirm
I think Dr. Kalam,
yes,
here a lot of information is given, especially in Scott Brown. What are the distinct advantages of auto microscopy or auto endoscopy or this otoscopic examination? Okay, so try to dig and learn, enrich yourself. Okay, so they are given directly. We can take culture from the middle ear. Okay, you can see the margins of the perforation. Sometimes ossicular movements we can see. Okay, and fundus perforation, those differences can be made out under microscope. Okay, plus patch test. These are some of the things which are given in the books. Okay,
and also the drum, whether it is fixed to the middle ear, promontory, or with suction tip, you can just slightly, like, all these are because you are doing in your minor OT. You should be very careful when doing all this. Okay.
Yes.
Then next.
Then actually I would like to do a pure-tone audiometry of the patient to confirm our findings as well as for a medical purpose.
Now you know the pathology now. Okay. So any one relevant good investigation.
HRCT of the temporal bone we have to.
Okay.
One investigation if you tell, that is HRCT temporal bone, to assess the condition of ossicles, whether there is how the extent of this polystatum, or whether it has affected the tegmen, and as well as the status of the mastoid cells.
Okay.
And how is it the involvement of the epitympanic or the mesotympanic also can be made out by HRCT temporal bone, and the facial nerve, whether it is descent anywhere.
So here, some of the examiners, they will be really interested to know, apart from the middle ear, the inner ear. Okay. So typical this thing, appearance of the cochlea, semicircular canals. Okay. So those things you must know like that. Okay.
You have to. You can also look for any.
No, we are not going into the details of that, but you must know them. Okay. Inner ear details. Okay. So that ice cream cone appearance, and okay, those things you know better than us. Fine. Madam, shall we go for management?
Yeah.
Managing this
Before
patient,
going, what exactly is HRCT means?
It's a high resolution CT scan. That is, resolution is basically a principle of differentiating two closely spaced points. So
what? I'm not hearing.
Resolution is basically defined as the ability to differentiate between two closely spaced points. Now, in our picture, points means it is pixel, that is pixel or picture image. So, when in a high resolution CT, the cuts of the CT are maintained in very close proximity, that is around 0.6 millimeter cuts, or very close cuts are mentioned, so that a smaller area can be seen with a larger resolution.
6 millimeter. Are you sure?
Ma'am,
even for a
0.6 millimeter.
Even 0.6 millimeter, because even for a conventional CT scan, they take 4 or 5 mm cuts. For high resolution, it should be less than 1.5 mm.
0.6 for because we have such complicated anatomy in the temporal bone, and what the middle ear is just 0.5 to 0.8 mm, isn't it, the cavity? So you need to have a thinner sections to know all the structures properly. Okay. Because of the time limit, we'll proceed with how do you manage this patient now. Now you have done the HRCT, you have done pure-tone audiometry, you have done your otoendoscope, microscopic examination of the ear. Now, how do you proceed? Treatment.
treatment, we shall start. We have to plan for a surgery, that is surgical management of this particular case, to make the ear safe. And the surgery that we proceed is we conduct is a modified radical mastectomy.
I think before you start drilling, I should ask, what consent would you take?
So the consent that we take is that there can be persistence of hearing loss, or there can be no improvement in hearing loss. That is very important for us to take. And we have to also take a consent that even after the surgery is done, sometimes there can be reduced hearing loss also, because if we remove the ossicles, if there is a bridging cholesterol, there can be reduced hearing loss. Other than that, we have to always take the consent that the patient might have a discharging ear from a cavity. The patient can have a discharging ear. The patient has to come for regular follow-ups. For the lifetime also, sometimes we have to see the patients.
Okay, in addition to what Dr. Devi Prasad is telling, you told about surgery. Okay, the patient is not willing. Okay, so how will you what advice you give to the patient so that he should not go for further consequences?
Sir,
he's not ready for surgery. Okay, you know the findings. Okay, in continuation of what Dr. Devi Prasad told.
Sir, we have to ask the patient to come for a regular follow-up, please.
How frequently? Weekly, daily, or once in 15 days? We don't know. No, just to just on the lighter side, we need to plan. Okay.
Yes, sir, we need to plan. Like in our hospital setup, we call such patients who are not fit for surgery, like every 2 months. We ask them to come, and then we actually suction and clean that particular area, that is up to
yes.
So keep on suction and cleaning.
You can advise that, okay, every second or third week. So even if they come a week later, that is fine. Okay. If you tell 2 months, then they will come after 3 months. Okay. Fine.
Yeah.
Okay.
And then in the consent form, you need to take even for the tinnitus also. The patient might not have, but when you're dealing with the cholesteatoma is more, and then you're dealing with the area of the foot plate, you might, the chances of patient having tinnitus post-operatively have there. So that also you need to take. And then for facial now also you need to take. Okay?
Yes, ma'am. I just want to add one word, madam. Last week only I had a patient. He got operated from somebody for vertigo with central perforation, but the vertigo.
Anil, we lost you.
I think what sir is trying to say is, don't tell the patient that vertigo and tinnitus are going to go just by closing the perforation.
Correct. That is there.
That's the idea of that. That's the point he's trying to put across, I think.
Yeah.
He was done.
That could be the concern, but that's not going to settle with your.
Yes.
Yeah. Now.
Continue.
How much exploration? I would rather suggest you to put it as mastered exploration is what you want to do.
Surgery, what you want.
Straight away decide to go about modified radical mastectomy.
Yes, sir. I would like to go for a mastered exploration.
How far to drill?
Sir, actually, in this case, we have to access, or we have to drill all the accessible air.
No, first, how do you approach the mastered exploration? What Dr. Devi Prasad will see, our plan might change when we go there, isn't it? Whatever you do, radio imaging, whatever you do, only when you open the cavity, you know how extensive the disease is. You might not go for canal wall down at all. With canal wall up only, you can clear the disease. So that's always better mastered exploration. And what incision you use?
We use a William Weld incision.
Post-auricular
William Weld incision.
Wild incision. Okay.
And if you want the plan for mastered exploration, we can go for reticotomy, reticoandrostomy. And then
first is how you open the mastoid. Where you open the mastoid?
We drill, ma'am, posterior to that spine.
What is that area called as?
The McEwen's triangle. That is, which is the surface marking of the antrum.
Okay. How depth the antrum is there?
Around 1.5 centimeters from the.
In the entire lifetime or in infants, it's.
No, ma'am. Infants, it is always very superficial.
Superficial.
Very superficial. So
Because the mastoid is not formed well. Yeah. And then what you do?
We open up the mastoid antrum and we saucerize all the edges properly so that all accessible, we can have a good entry of our bells. Then we have to accentuate all the accessible air cells possible. Diseased air cells should be accentuated. And then we have to identify the adductus that is happening into the.
So you have to outline the dural plate, the sinus plate, the sinodural angle, the mastoid tip, so that all the cholesteatoma which are there in these air cells, you're removing the disease and accentuating the cell. That's how we define mastoid exploration, isn't it?
That is
so you're doing that. Then
in short, we can tell that is.
Then how to see once I open the mastoid antrum, then you decide. I don't know whether at this point it's important for postgraduates, like whether to do canal wall down or canal wall up. How do you decide now?
And if you can, if you see that the cholesteatoma sac has extended, for example, in our case, it has come through the epitympanum to the adductus and then gone into the antrum. So if we can identify the cholesteatoma sac, then definitely we have to accentuate. We have to take down the wall and accentuate or remove the cholesteatoma sac from the middle ear.
What is Bondi's technique?
Sir, Bondi's technique is that atticotomy, another name for atticoandrostomy.
It's not just atticotomy, it is?
Atticoandrostomy.
Okay, fine. So why would that be a choice?
Sir, Bondi's technique, yeah, sir, if you don't want to go for total acceleration of the air cells, or if the sac has just reached that tick, then we can pull out that by using a technology.
Okay, Dr. Kalam.
Yes, sir.
If we are telling about Bondi's, okay,
yes,
and the post-auricular, okay, so yes, mentally one need to be prepared how to approach, whether inside out or outside in, those things they may come for the discussion, okay. Yes, so endoral approach, okay.
Yes, yes,
it may in this case may not be the perimetal, but endoral approach and post-auricular approach, okay. So yes, advantages, disadvantages, you must know about them, okay. Yes. Because nowadays a lot of people are doing these endoral approaches, okay, for limited disease, okay. Yes, yes. Of course, as a postgraduate, fine, okay, post-auricular, everything clearance, okay, then bother about reconstruction, but we need to know about them, okay. Yes. Endoral and inside out, outside in, fine.
Yes.
Okay.
Options of cavity problems. So examiners can ask how to prevent cavity problems, obliteration techniques, how to reconstruct canal wall. So depends on, sometimes the discussion may not take a lot of time in the history part. Examination also may go on smoothly if everything goes fine. Then you may have a lot more discussion during the management aspect. Yes, so these are the additional things that might cover that part of discussion in the management aspect.
Fine.
Yes,
yeah.
Azim sir, anything you want to add?
Yeah, Dr. Kalam.
Yes, sir.
The fact that this retraction pocket, what you said, with debris, is involving a large part of attic going into anterior attic. Do you think development of middle ear and embryology could have contributed to this case?
Definitely, sir. I think so, because we already know that the Bussac space as well as the superior that is a posterior epitympanum space rising from the same part.
But there is an evidence also no on the other side also.
Yeah.
Yes,
opposite attic also. Huh? So what Dr. Azim is telling is correct.
Yes, sir.
Yes,
both
sir.
Sides, both sides.
And how the disease has gone to the antrum, whether it is anterior or posterior,
yes.
which pathway is affected here? The cholesteatoma, I mean.
Yes, ma'am. It is going to the posterior pathway. Mostly.
No. I mean, or in the lateral to incus or medial to incus?
Yes. Exactly.
In our case, ma'am, in this situation,
Yeah.
ma'am,
Usually the attic cholesteatoma will enter the antrum through lateral to the incus, short process of incus. Okay. Here incudal space, and then lateral to the incus, and then it enters the antrum. So your mesotympanum, the posterior mesotympanum, is not usually involved here. Okay.
Yes, madam. Yeah.
Whereas
So
the
Dr.
posterior
Kalam,
pocket,
what
those are
madam
the
is
ones where
telling
the posterior mesotympanum is involved, and then that spreads through the medial to the incus. So that is very important for us in clearing the disease.
Yes. Dr. Kalam, you should make a chart. Okay? How this cholesteatoma spreads lateral to the incus, medial to the incus. Okay. Then the concept will be very clear. Okay.
And always,
so, madam has sensitized about that. Okay.
And always, which is the dominant isthmus in the tympanic diaphragm contributes a lot.
That is a posterior isthmus.
And that is usual, but in this case, you have to be prepared for anterior. Tell me, in what percentage of patients the anterior isthmus will be dominant and why?
Yeah.
Sir, percentage exactly I do not know, sir.
Though they are little supra threshold, but we must know. And we should try to know about this attic reconstruction also, especially in this case.
Yes, sir.
See, in brief, in this case, if at all, I mean, your what do you call HRCT temporal bone shows that the mastoid is involved with cholesteatoma. So as you said, postoral incision, then we enter through the antrum, then eccentrate all the air cells. Then after that, we'll remove the bridge. What is bridge, you should know. Then we lower the ridge. And how far we lower the ridge? How far we lower the ridge? Up to the level of the
where the facial nerve is there, but
lateral semicircular canal. Okay, that area, so that the facial nerve is protected by part of the external canal. Still, we leave behind the bone there. Okay, and then you don't open the cholesteatoma sac in all your drilling area as far as as far as possible. Protect the cholesteatoma sac with either the gel foam or the cotton, and then push it anteriorly, because you need to deliver the cholesteatoma sac as far as possible intact. But if it opens also, doesn't happen, I mean, no problem, but you push it through the adductus into the attic. Okay. Yes. And then once you, then anterior buttress, you should know, posterior buttress, you should know how far that, removing of these buttresses, so that a smooth, and what is the quality of the proper mastoid cavity, that point you should know. Because of the shortage of timing, we want to wind off now. Okay. That point you should, everyone should know. Okay. These are the points you should know. And then, as Dr. Devi Prasad said, the mastoid, once you do this, the entire mastoid cavity is there. Then you need to do the meatoplasty. What is the characteristic property of the good meatoplasty? You should know. And then how to do the meatoplasty. And then here in this patient, you need to do the reconstruction also, because the sputum is eroded. Okay. Always better to reconstruct that. And then the cavity obliteration. Okay. Either the musculoperiosteal flap obliteration or the cartilage or the soft tissue. It depends on the, the surgeons. In their experience, like they have good results with different techniques. But at the end, you should have a good proper mastoid cavity. Okay.
Yes.
Then I think anything else, any points to be added? Devi Prasad, Sapna, Anil, Azim.
You can get.
Then the reconstruction.
Yes.
This is about the cavity and all problem. Reconstruction.
See, always when you have an ear case, you should go according to priorities. As you rightly said earlier, the first priority is to give a safe, dry ear.
Yes.
The next priority is to retain or, if possible, improve the hearing apparatus. And the last priority is giving a near normal lifestyle.
Yes.
And according to that, you should manage.
I just want to add only one sentence. We should try to remember 4 E's. Okay. Expose the disease, excise the disease, exteriorize the cavity to the external auditory canal for proper drainage. Okay.
And then for the reconstruction of
Yes,
the
please.
hearing, I mean, we all use temporalis fascia, even
Yes.
if it is a revision case also, because temporalis flap is such a wide one, you can still go ahead. Only thing is you need to extend the incision above, that's all. Take the good amount of temporalis flap, and then you can use, so that it should drape your tympanic membrane area as well as the mastoid cavity. So you need to take a wide temporalis fascia, and then for the reconstruction of the hearing, then we all use, I don't know, I use the cartilage, either we take from the conchal cartilage, because the conchal bowel is there, take the conchal cartilage. Then if the stapes head is there, short columella graft, that is between the stapes head and the tympanic membrane, that is the temporalis fascia. Then in that columella, you make a socket like that, so that it sits over your stapes head. If at all, only foot plate is there between the foot plate and the the graft. Yeah. So the thing is, you need to maintain a good height of the middle. Okay, that is the one which gives you the good hearing. There are two things in the whenever we are planning all this, the good height of the middle ear and ventilation of the middle ear. And if at all, that's why, because the mastoid pneumatization system also helps in the hearing mechanism. Nowadays, we are going for soft tissue reconstruction of the that bridge which we have removed. Okay. Any other points anyone can add?
I think Kalam, I mean, you've really got words of wisdom. You have, all the examiners telling you how. I just want to tell this for the benefit of all postgraduate students, at least when we were taught. See, you are at a postgraduate level, your history and examination should be perfect. Kalam, you did well, but then you can do much better. As first year resident, maybe this is okay. But when you go into your second and final year, we expect something much more from you all. See, your history should flow like you have taken so many cases. So we must not be asking you questions at all. Now, the very fact that we spend a lot of time on history and examination means that you need to do much more there. So now what happened is we could not spend time on management. And this usually that happens in your case. Whereas in a postgraduate level, management may be the most important part, where we should have probably taught you and given you more advice, because no amount of reading, but words of wisdom would be, from examiners that you get, like, Dr. Anil mentioned about the 4 E's. Azim sir mentioned about the 3, things that you should give priority. You may read these in books, but when somebody tells you, I think you remember it much better. So you must get your discussion to management level as fast as possible. And that's probably a mark of development or growth in as possible. So definitely, and things like what percentage. Now you may feel that, oh, how is it important? I'm just clearing. But remember, reading literature, and that's where research and all this comes, because you must know how much percentage. And when somebody asks you in management, how would you like to go about? Never tell that, I want surgery. I'm going to tell surgery. You have no authority over the patient. The patient makes the final decision. So you are a facilitator, like we are facilitators as teachers. You are supposed to tell the patient what is the disease, what are the likely complications, what are the management options. So when you tell, you would say that, sir, I would like to, discuss the management options with the patient. This is the disease he has. This is its seriousness. It's like taking the car to a mechanic. I need the car every day. I cannot just keep the car in the, in the workshop. So it's just like that. Put yourself, the patient is in that position. So is it an emergency surgery? Can the patient wait? These are all very, catch-22 situations in medicine. So I feel that there we need to stress a little more. What kind of consent? How do we take it? What should you stress? Now, this is areas where you need more discussion, but these are all never-ending, discussions. Yes. But all the well, Kalam, you did well, but I think you must read more and go better to discuss more on management. So all the very best. Thank you.
Thank you.
Thank you.
Thank you, sir.
Thank you, Dr. Vadish. We'll be logging out.
Yeah.
Thank you.
Bye,
Yeah.
Thank you, everybody.
Thank you.
Dr.
Bye,
Azim,
sir. Bye, sir.
Madam, Bharti Madam.
Bye,
Okay.
Anil.
Thank you, madam. Thank you, sir. It was a pleasure being here.
Devi Prasad, bye.
It was a wonderful session. Thank you, sir. It was a wonderful session. I thank all the examiners for sharing their extensive knowledge in a very comprehensive manner. Not only Kalam, all residents who are attending this will be benefited by this discussion. And I thank one and all. And the ear case ends here. Next, we'll be continue with the next case, head and neck case. Dr.
Dr. Vadesh.
Azim sir, yes sir.
I'm sorry to intrude.
Yes, sir.
Just requesting, can we have the head and neck case next, because I'll have to catch my flight to come there.
Here, sir. Next is head and neck, sir. Hello, sir.
Yeah,
yes, sir. This is our head and neck case, sir. Next.
Okay, thank you.
Yes, sir.
Azim is always ready.
Yes, sir. No, sir. Actually, no, we are more concerned about Aziz coming here also, sir.
Okay,
so
thank you.
Next case will be
I think I'll leave it.
Thank you very much, Anil, sir.
Thank you, sir. Thanks a lot.
Madam.
Thank you, madam.
Very much.
Thank you, Azim, sir.
Thank you,
sir. Now, Sapna ma'am and Azim sir will stay back because we need 2 armed forces for the next head and neck cases.
Okay. Thank you. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you.
So, Dr. Kalam can stop sharing your screen and allow the next candidate, Dr. Next candidate has joined. Sorry. Yeah, Dr. Masira has joined. Kalam.
Yes, sir. I'll.
You should stop. Yeah.
Yes, sir.
Stop sharing your screen so that Dr. Masira can start presenting. And for the next case, we have Dr. Azim sir and Dr. Sapna Nambiar and Dr. Mohan Appaji and Dr. Mahesh SG from AJ. And we have our Madam Dr. Rajeshwari to conduct examination on head and neck case.
Good morning, Dr. Vadesh.
Good morning, Appaji sir. Yes.
I'm joining you from Assam.
Yes, sir.
Sorry, physically I was supposed to join you, but unfortunately because of a schedule program, I am in Assam, Guwahati. Anyway, I'm online for some time. I'll be online for some time. Okay.
Yes, sir. Yes, sir. We are missing you after very many years. Like otherwise, Appaji sir would be here always. And when you say Guwahati, that was my DNB center for my practical in 2006.
Right.
Good morning, Azim sir.
Good morning, madam.
Swapna madam and Appaji sir.
Good morning, madam.
Good morning. Good morning, Sapna Nambiar.
Good morning, sir.
I think Mahesh SG, Dr. Mahesh SG was here. Right?
Good morning.
Yes,
Good morning, sir.
Appaji sir, good morning.
Good morning,
Good morning,
sir.
madam.
Mahesh SG
I think Azim sir is more interested than the students. So he is asking for the next case.
Always.
Thank you, madam.
Dr. Masira, you can start presenting. Meanwhile, Dr. Mahesh will be joining. He was here. I think some connection issues. He'll join.
Going only whole.
So apparently we have 20 minutes.
Okay.
Yes. Somaji sir is also here. He was a OT schedule and now he has postponed it, and Dr. Somaji sir also will join here. Good morning, Somaji sir.
Good morning, Vadesh, and good morning, everyone. Dr. Azim, Madam, everybody.
Good morning, sir.
Azim sir, nice to see you.
Nice meeting you again, sir. Couple of times per year, I have to visit Mangalore.
Yeah.
Comfortable. Nice being here, sir. Thank you.
Yeah, Masira, I think you can go ahead.
Sir, I'm unable to share my screen, sir. It is permission. I think host should give permission to me to share. I think so, sir.
Did you open your presentation and then share the screen? Are you able to share or you're not able to share?
I'm not able to share, ma'am.
Okay. Radish, I think she needs to be made co-host for that.
Can you see the share screen icon? Good morning, Dr. Mahesh.
Good morning, Varish.
Dr. Masira, can you see the share screen icon there?
It's I'm just. Yes, sir.
But what it says when you click that?
It's showing only the host can share in this meeting.
Is it? 1 second, I'll make you call. Meanwhile, you can start presenting the history. You can start presenting the history. Sir, Azim sir, is it?
Yeah, sure,
yes,
sir.
Yes. Meanwhile, I will.
Yeah, good morning.
Good morning, sir. Good morning, everyone.
Good morning. Good morning.
Good morning.
Sir, today I'll be presenting a case of oral cavity. A patient named by Achappa, who is 62-year-old male patient, hailing from Puttur, occupation by farmer. He came with chief complaints of ulcer in inner surface of the cheek since 2 months. In history of coming to the history of presenting illness, patient was apparently normal 2 months back. Then he noticed a small ulcer in the inner surface of his cheek, which was progressive. It was insidious in onset, and it was rapidly progressive in nature, and it was associated with burning sensation in oral cavity on eating spicy foods. And he has history of 1 minute, sir.
Dr. Masira, you are co-host now.
Yes, sir. Yes, sir.
You can share.
You're sharing from your phone, is it?
Yes, sir, because there was issue with the internet in laptop, ma'am. So
coming like that. Just do play. I think it'll come.
Yes, sir. Can you see my screen?
Yeah.
So I'll start from beginning. A patient named Achappa, 62-year-old male, who is a farmer by occupation, hailing from Puttur, came with chief complaint of ulcer in inner surface of the cheek since 2 months. So coming to the history of presenting illness, the patient was apparently normal 2 months back. Then he noticed small ulcer on the inner aspect of the cheek, left side, insidious, which is insidious in onset, rapidly progressive, and it is associated with a burning sensation on eating spicy foods and bleeding from the ulcer. And there was no history of pain, no history of loosening of tooth, no history of sharp tooth or ill-fitting dentures. Then no history of reduced mouth opening, no history of pain radiating to ear, and it was not associated with difficulty in swallowing, no history of change in voice, no history of radiation exposure, no history of anesthesia or hypoanesthesia over the face, and no history of fever, and no history of weight loss, and there is no history of cough, hemoptysis, and bone pains.
And Dr. Masira, if I may intervene, you have said rapidly progressive.
Yes, sir.
Over 2 months, I would not call it rapidly progressive. 2 months is a long time.
Okay.
Gradually only. Okay?
Okay.
And just go to your next slide.
Yes.
Yeah. Why did you ask for history of radiation exposure, change in
Sir,
voice?
radiation exposure, like I'm like, because it's a male patient and according to age, and it is ulcer which is not healing since 2 months, I will be like, my differential diagnosis will be one of the carcinoma of oral cavity, sir.
So what radiation exposure will cause oral carcinoma?
Low radiation exposure of less than 20 grades in less than 20 years of the age will cause head and neck risk for head and neck cancer, sir.
See, that is, radiation-induced cancers are different, not squamous cell carcinoma. Okay.
Okay, sir.
So I would not put it here. And what change in voice and what difficulty in swallowing were you thinking of?
Sir, because I am thinking in the case of malignancy, so the oral cavity cancers have like second primary. So I want to rule out second primary by asking this difficulty in swallowing.
That's taking a little long shot. If had it been carcinoma tongue, I would have given you credit for difficulty in swallowing, because even in oral tongue, the initiation of swallowing is done by oral tongue, but not in buccal mucosa. Okay.
Okay.
And given change in voice, had it been an oropharyngeal malignancy, then it would have had credibility. Okay.
Okay.
Then again, one more thing, Azim sir, history of fever. What significance? I don't know.
I would not give much significance here at all.
Sir, because I'm thinking one of this tuberculosis ulcers, sir, to rule out that tuberculosis.
See, that way you can in fact add all the possible symptoms on earth.
See, Dr. Masera, whenever you present, you think of common things first.
Okay.
Isolated tuberculosis of oral cavity have you seen? Had it been bone, the situation is little different. Okay?
Okay. Okay. Shall I proceed, sir?
Which part of face are you thinking of? Anesthesia or hypoanesthesia? Which part of face?
Lower face, sir.
So I would be more specific over which region, isn't it?
Lower lip region, sir.
So face is a very big area. Okay.
Yes. Okay, sir.
So which nerve are you thinking of there?
Inferior ulnar nerves.
Good.
Shall I proceed, sir?
Yes, proceed.
Yes, please. Yes, please.
Coming to past history, the patient had history of aricanet and tobacco chewing since 15 years, and there was no history of alcohol consumption or smoking, and he is a non-known case of hypertensive or diabetes mellitus, tuberculosis, and asthma.
So you said patient has burning sensation in oral cavity.
Yes,
does
sir.
the past history correlate? What are you thinking of?
It's maybe because of ulcerative lesions that causing, because mucosal erosion.
Ulcerative lesion initially will not cause any burning sensation. The fact that he is addicted to areca nut, what does it ring? Does it ring a bell?
It's pre-malignant or a malignancy condition.
Which pre-malignant condition?
It's leukoplakia.
Leukoplakia will not cause pain.
Erythroplakia.
Even that will not cause pain.
Submucous fibrosis will be in case of stomatitis will cause.
Yeah, I would think in those terms. Okay. Please proceed.
Sorry for the interruption. Can we keep the mic muted and unmute only while speaking? Some echoing is there.
Yeah.
Okay. Thank you, sir. Thank you, sir.
Thank you.
Thank you, sir. Dr. Masera.
Yes. Okay. Coming to personal history, he takes mixed diet, appetite was normal, sleep adequate, bowel and bladder habits were regular, and family history was not significant. And coming to general physical examination of patient, a 62-year-old male patient, conscious.
Masera, you brief of the history. You have a strong positive history and gender, everything. So I think better you sum up the history before going to general physical examination.
A 62-year-old male patient came with complaints of ulcer in near surface of 6 inch tumor associated with burning sensation, which was and bleeding from the ulcer. And he has habits of aricanet and tobacco chewing since 15 years.
Okay. So now you have got some diagnosis in your mind, isn't it?
Yes, sir.
With the
Yes, sir.
based on the history. Okay.
Yes, sir.
Okay. Proceed.
Yes. Coming to general physical examination, a 62-year-old male patient, cooperative, conscious, alert, moderately built and moderately nourished. He is well oriented to time, place, and person. Performance status was 90 Karnofsky. Pulse was 76 beats per minute in right radial artery. Blood pressure was 126 by 72 millimeters of mercury measured in left arm supine position. Respiratory rate is 18 cycles per minute, and there was no pallor, no interest, no cyanosis, no clubbing, no pleurema, and generalized lymphadenopathy.
Dr. Masira,
Sir.
see again, I will not be going back into what we discussed for ear case.
Moderately built.
The checklist has to change. Okay. Pallor, I'll accept. How many cases of oral lesion you will see? Icterus, cyanosis, clubbing at least okay. Cyanosis, icterus, and all going the order which you expect. After pallor, I would expect generalized lymphadenopathy and engorged veins in that order. Okay.
Okay.
Right. What you expect should come first.
Okay. Next, coming to systemic examination.
I think you got cut.
Per abdomen, so tender and no organomegaly. Central nervous system, no focal neurological deficit. Cranial nerve examination is normal.
Excuse me. Instead of writing S1, S2 heard, you can write S1 and S2 normal.
Yeah, that's right. As long as he's alive, S1, S2 will be heard. I'm more interested whether S3 or S4 was there, or was there any murmur or rub.
You are not audible.
Yes, ma'am. Can you hear me, ma'am?
Yes, yes.
Yes. Next, coming to head and ENT and head and examination. First, I will discuss oral cavity. Lips were normal, angle of mouth normal, mouth opening was adequate, and oral hygiene was good, and tobacco stains were seen on cheek, gums, and hot palate. And
What do you understand by adequate mouth opening?
buccal mucosa.
Dr. Masira, what would you mean by adequate mouth opening? What is the inter-incisor distance?
Inter-incisor distance should be more than 3.5.
Yeah, 3.5 to 4.5 centimeters. Okay.
Yes, sir.
Okay. Please proceed.
Yes, sir. Then
Your voice is breaking off, Dr. Masira. We are not able to hear at all.
a proliferative growth seen in buccal mucosa left, measuring 5 into 4 centimeters. It is extending anteriorly 2.5 centimeters from commissure and posteriorly reaching till retromolar trigone, inferiorly involving lower gingivobuccal sulcus, and superiorly it is 1 centimeter below upper gingivobuccal sulcus. And this ulcer has irregular margins, everted edges, and irregular surface covered with the slough. And the surrounding mucosa appears healthy. Skin around the surrounding the cheek is normal.
You have not mentioned what is the base of the ulcer here.
It's base of the ulcer.
Have you gone to palpation?
Yes, sir.
Okay, then what is the base of the ulcer? What is the depth?
Depth is all, it's like on palpation, like it was indurated all around 5 mm, sir, almost all around the lesion.
See, that business, I would leave it to pathologist, or at least take a scale or tape and measure. But before that, what is the base of the ulcer? Is it the muscle? Is it the skin?
It was not involving the skin, sir, but it was not reaching outside the skin. It was still like in the mucosal side only, sir.
It was only in mucosa. 5 into 4 centimeter ulcer only in mucosa, not going deep, is little difficult to swallow. Was the muscle involved?
Yes, sir. Muscle was involved, sir. Buccinator.
Which muscle?
Buccinator muscle. Sir.
Okay. Let's proceed.
Yes. Then on palpation, ulcer was not fixed to underlying structures, tender and bleeds on the touch, and ulcer was like abutting the body of the mandible at the lower gingivobuccal sulcus, and there was a thickening of mandible present. Palpation of the tongue was normal, and right side buccal mucosa, gingivobuccal sulcus, gingivobuccal labial sulcus, and retromolar trigone were normal. And floor of the mouth was normal, and skin overlying the cheek was normal. Bilateral submandibular and parotic ducts openings were normal.
You say ulcer abutting the mandible. Was it involving the gingiva?
No, sir. Lower gingiva, it's free, sir.
It's free.
Yes, sir.
Okay. How did you palpate the mandible there?
Sir, by digital palpation, sir. One with index finger in the intraoral in the floor of the mouth, sir.
No. On both sides of the mandible, that is, both sides of the mandible on that side, you need to run along the inner table and outer table. You need to run your gloved finger. Look for any thickening, any elevation of periosteum, any irregularity and all that.
Oh, okay.
Otherwise, we'll not know whether submucosally it has gone into the bone.
Oh.
Okay. Please proceed.
Yes. Next, coming to my oropharynx examination.
You have written parotid duct opening normal. Where did you see it?
Sir, I seen upper maxillary opposite to the crown of second molar tooth, sir. So
it's little difficult to comment on that when you have a 5 into 4 centimeter growth there, isn't it?
Sir. Yes, sir.
So I would not comment on that now. Okay?
Okay.
Proceed.
Yes. It's coming to oropharynx examination. Soft palate was normal. Uvula, it's normal and central. Anterior pillars, it was bilateral normal. Tonsil, it was bilateral grade 1. Posterior pillars were bilateral normal. And posterior pharyngeal walls normal. Base of the tongue was normal on palpation. And there was intact gag reflex.
Okay.
It's coming to indirect laryngoscope examination. Base of the tongue was normal. Vallecula, bilateral normal.
Was everything normal here?
Yes, sir. It was normal.
Okay, proceed.
Okay. Next, coming to neck examination. Inspection, skin over the neck is normal. No scars and sinuses. No visible swellings and dilated blood vessels. And trachea appears to be in central. Next, palpation, single ipsilateral level 2 lymph node was palpable, measuring 1.5.
What is level 2, Dr. Masira?
Sir, digastric, sir.
Which digastric?
Jugular digastric.
I would put it as upper deep cervical. Jugular digastric is part of level 2A.
Level 2. It was measuring 1.5 into 1 centimeters, which is firm in consistency, mobile and non-tender.
Which is the area of drainage for oral cavity? Which is the first echelon?
It is 1B, sir. Submandibular is the echelon of oral cavity.
Okay, so there was no lymph node?
No, sir. Clinically, there was no lymph node, sir.
Did you insinuate your finger between the mandible and floor of mouth?
Yes, sir.
Okay. So if there was a lymph node in level 2, what would you call it? What do you think it is? Can you hear me?
Yes, sir.
What do you think it is?
Sir, if it is there, I'll think of oropharynx, sir. Level
No.
2.
No. You have seen the growth in oral cavity.
Yes, sir.
Why will you think of oropharynx then? It's either skip metastasis.
It is like
It's either skip
extending
metastasis.
to the oropharynx.
Dr. Masira,
Yes,
it's either skip metastasis or it is just a reactive lymph node because of some throat infection or whatever earlier.
Okay.
It's not the first echelon of drainage for oral cavity. Okay.
Okay.
What are the chances of skip metastasis in head and neck? What percent?
Skip metastasis. 26%, sir.
Oh, no. Less than 10%.
Okay.
Less than 10%. Okay. Please proceed. Someone's kept their someone will have to mute it. We are hearing a lot of unwanted noise.
That little angle they can make it, no? It will touch on us. Okay. What they can do is, if you touch money,
Please, someone's kept the mobile on. It's disturbing here. Could you please mute it?
They'll spend half an hour with them.
Dr. Bharti. Dr. Bharti, I think you have to unmute your.
Because it has on the right side, they have to bend forward in channel. I think that might come, but I don't think.
I think the host can mute all and the speaker can unmute when the person is speaking. That is better. Now madam is muted.
I muted, sir.
Okay. Please proceed, Dr. Masira.
Yes, sir. Sir, coming to ear examination, first I'll be telling right ear. Pinna was normal.
Was the ear normal?
Yes, sir. It was normal. Sir.
Okay, please proceed. Let us not waste time unnecessarily.
Yes, sir. And the nose and paranasal sinus examination was also normal, sir.
Okay.
Then coming to my provisional diagnosis, it's malignancy oral cavity, buccal mucosa left, clinical staging T4A, N1, N0, stage 4A.
Why are you saying T4A?
Sir, because on like palpating mandible involvement, sir.
You said mandible is free. Gingiva itself is free, you said.
Yes, sir.
Then?
So because on palpation, I felt like it is abutting the mandible and there is thickness of mandible, sir, in the body of mandible.
So that should have come during your oral examination. Okay. That's a very important finding then. Why is it important whether mandible is eroded or not?
So, because our treatment plan will change, sir.
What will change?
So because we have to go resection of this involved mandible, sir.
How much?
Sir, it is like if it is involving only cortex, we can go for marginal mandibulectomy, or if you're not able to save less than 1
I would not do a marginal mandibulectomy in this case because it's going right up to retromolar trigonal. It's 5 into 4 centimeter.
Segmental.
Yeah.
Segmental mandibulectomy.
Segmental, preferably hemimandibulectomy.
Hemimandible.
Okay. So if mandible was not involved at all, then I would go for marginal in this case because
T4.
No, not T4. Because the tumor is so big,
okay.
I would require a margin for resection.
Yes.
For that purpose. Okay.
Yes.
If you say mandible is involved, I'll straight away go for hemimandibulectomy here. At the most, I may save the condylar process.
Yes.
What is the significance of mandibular canal?
Mandibular canal, it's if it has like inferior alveolar nerves, actually passing through that canal and exit through the mental foramens.
Yes. So if that is involved, you'll have to take the anterior inferior alveolar nerve high up away from the mandible. It can have perineural spread. Okay.
Yes.
Right. Proceed.
Then to confirm my diagnosis, I'll be doing image biopsy followed by FNAC of the lymph node and imaging.
No. I will disagree with it. Why FNAC of the lymph node?
So because as it's not like echelon lymph node of
Suppose your FNAC shows reactive lymph node, you will not do a neck dissection?
No, sir. I'll do the neck dissection, sir.
Then anything which is more than T2 should at least have a selective neck dissection. That is minimum. Okay?
Yes, sir.
Because the chances of micrometastasis are upwards of 20%.
Yes, sir.
So no FNAC of lymph node in this case.
Okay.
Which investigation would you do first, imaging or biopsy?
First, I'll go for imaging, sir.
Yes. So what imaging would you do?
I'll do CT scans, so CT of skull base to mediastinum, sir.
Which area will you concentrate in this?
So I'll be concentrating on oral cavity and the mandible, sir.
Mainly the mandible and upper neck. Okay.
Okay, sir.
Will you request the radiologist to do any, to make the patient do any maneuver while taking CT scan? What is puff cheek technique?
Puff cheek technique, like they have to blow the egg so that we can clearly see in the buccal mucosa, sir. So that
not buccal mucosa, you will come to know whether the tumor is only abutting the mandible or going on to the gingiva. Okay.
Okay, sir.
Because you said gingiva is free initially.
Yes,
and then you had a controversy whether mandible is thickened. So it's all the more important in this case.
Okay.
Okay. And it's always contrast enhanced CT here.
Contrast enhanced, yes.
Yeah. Have you heard of panoramic view of mandible? X-ray?
Yes.
What do you call it?
Sir. Orthopantogram, sir.
Yeah. Which is better, OPG or CT?
CT, sir.
Very good. Why? What is the pitfall in OPG?
So we can see all surrounding.
That is why it's called panoramic view. But what is the pitfall? What is the disadvantage? At least 30% of the cortex should have been eroded to pick up on OPG. And secondly, the anterior arch of mandible, that area is unreliable because the vertebral bodies overlap. Okay?
Okay.
Please proceed.
Yes. Then according to my biopsy, then I'll go for biopsy of the lesion.
From where will you do?
Sir, from the edge of the lesion, sir.
Very good. Why?
Sir, because that is the high active part of the one, and
Yes,
central
central
contains the
part
necrosis.
Yeah, central part may be necrosis. Good.
Necrosis.
Okay. Continue.
Yes. Then I'll proceed with my blood investigations and pre-anesthetic checkup. Then I'll be planning for the surgery of the patient, wide local excision with segmental mandibulectomy with comprehensive neck dissection, sir.
So what would you put it as? The surgery. What will you call it?
Commando procedure.
Okay. Any newer term? Commando is in 1940s and 50s. Composite resection.
Yes, sir.
Composite resection. Along with a what neck dissection will you do here?
Sir, I'll do a modified radical neck dissection.
What is the modification you will do? What is the radical neck dissection first of all?
Radical dissection involves of removing all 1 to 5 lymph nodes and also 1 to 5 lymph nodes, sir.
You mean lymph node levels in the neck?
Yes, sir, lymph node levels, sir.
How many lymph nodes are there on each side of the neck?
Sir, level 7 lymph nodes are there, sir.
5 levels on each side plus central compartment and superior mediastinum. So those are the levels. If you ask lymph nodes, it's more than 300 and most of them are microscopic. That's why we do a neck dissection. So what are we doing here?
So we have modified radical neck dissections.
You will remove the entire plane, the end block removal of all lymph nodes and lymphatics on that side of the neck.
Yes, sir.
And what is the modification in MRND?
MRND of three types, sir. First will be we will be saving the spinal accessory nerve, sir. Second will be saving spinal accessory nerve plus internal jugular vein. Third will be saving spinal accessory, internal jugular vein, and also sternocleidomastoid.
Suppose I sacrifice spinal accessory nerve and save only internal jugular, what will you call it?
Sorry, sir.
If I sacrifice the accessory nerve,
Okay, sir.
and save only the internal jugular vein, what will you call it? There's no answer. So this was the drawback in that old classification. Okay. The American Head and Neck Society classification of 1997 does not classify type 1, type 2, type 3 and all that. Okay?
Okay.
It's only modified radical when at least one or more non-lymphatic structures among these three are saved. And you name the structure you have saved. Okay?
Okay.
Right.
Okay.
Continue.
Then I'll be, if like by after resection of the tumor, I'll be sending it for histopathological examination. If histopathological examination shows like positive margins or extra.
Why? Will you want to have positive margins in this case?
No, sir.
Why should you? You said it's 1 centimeter short of upper GBS.
Yes, sir.
You said you are removing the mandible, then there is no business for you to have a positive margin. What is the distance you will maintain from the tumor?
1 centimeter will be taking
the margin will be taken. And what about the third dimension?
Sir, sorry.
Third dimension. At least one plane deeper to the base of the tumor. Okay?
Okay. Okay.
Okay, continue. Continue.
Then I'll be sending for histopathological examination, sir.
Done.
Then if it is any extranodal extension is there, or if it is comes as a poorly differentiated carcinoma, then
Dr. Masira, you are going into too much of imagination. Most of the oral cancers are well differentiated, at the most moderately differentiated. Okay. And whether there is extranodal extension or not, you have given the staging as T4A.
Yeah.
So if it is T4A, you mandatorily have to give multimodality treatment.
Yes, sir.
That is, post-operative radiation is mandatory.
Yes, sir.
There are only two criteria which are accepted in various oncology groups, which mandate post-operative chemotherapy with radiotherapy. Which are these two criteria?
Sir, lymph node involvement.
Lymph node involvement is not mandatory. Extranodal
extension and depth of invasion.
And
depth of invasion.
No. Positive margins.
Okay, sir.
If you have one of these, then they require post-operative chemotherapy with radiotherapy. Okay?
Okay, sir.
Otherwise, post-operative radiotherapy alone is enough. Of course, each oncology group has their own criteria: perineural involvement, multiple lymph nodes, deep muscle involvement, and all that. Those are optional, but all oncology groups put together, two things are common. Extranodal extension or positive margins are the indication for post-operative chemoradiation. Otherwise, anything more than T2, you need to give multimodality. Post-operative radiation is enough. Okay?
Okay.
Yeah. Continue.
Okay, sir. After surgery, I'll be because I did a bilocal excision and hemimandibulectomy. I'll be reconstructing using the free flaps.
So, which free flap will you use if you have removed the mandible?
Sir, I will be using the fibula, sir.
Very good. Okay. Suppose you don't have a microvascular surgeon or patient has peripheral vascular disease. What are the other alternatives for reconstruction in this case?
Sir, I'll go for PMMC flap.
What is PMMC?
Pectoralis major myopia flap, sir.
What type of flap is it?
It's a pediculated flap, sir.
It's not pediculated, it's axial. Axial flap. That means it has its own named vessel supplying. Which is that artery? Which branch of
Acromion-thoracic artery, sir. Thoracoacromion artery, sir.
It's pectoral branch of thoracoacromial artery. And thoracoacromial is a branch of thoracoacromial is second part of axillary. You said you will you said you will do a free flap. Where does the vascularity come from? Which vessels will you anastomose?
So we'll be anastomosing peroneal artery, sir.
You'll be anastomosing peroneal artery. The perforators with what? With what?
With facial arteries.
Okay, facial or superior thyroid. And what about venous drainage? What about venous drainage? To what will you anastomose?
No idea, sir.
Any of the bigger veins, but the safest would be end-to-side anastomosis with internal jugular, because with fibula, the veins are all very thin. If you use a thin vein, they are likely to get thrombosed. Okay?
Okay, sir.
End-to-side anastomosis with internal jugular or at least external jugular. I always prefer internal jugular. Okay?
Okay, sir.
Right. So what would you give the prognosis as? For patient, it always boils down to prognosis.
Yes, sir.
So what prognosis will you give?
Sir, it has like 5 years survival rate of stage 4 as 56, almost 50 to 56%, sir, 5 years survival.
Where you got this digital numbers, 50 to 56%?
It's still around.
It's around 50%. Okay, we used to say 40 to 50. Now it has improved. Can be up to 60, 65% in selected cases. Have you heard anything called compartment resection?
Compartment resection?
Yeah.
No, sir.
You're not heard?
No, sir.
See, suppose the muscles of mastication are involved. How sure are you regarding your margins? There's no tumor barrier. What are natural tumor barriers? Periosteum or perichondrium. Okay. So that will be absent there. But your patient doesn't have trismus, so I presume there is no pterygoid involvement. Otherwise, posterior disease like this can go up along muscles of mastication into infratemporal fossa. So when we don't have barrier, we remove the entire compartment, the muscles, except maybe upper part of temporalis, okay?
Okay.
And the upper part of masseter. So that we call compartment resection.
Okay, sir.
Of course, since trismus is not there, that may not be required for your case.
Okay.
Okay?
Okay, sir.
You can read up my publication in 2018 in European archives, you'll come to know. There are most of the compartment resections are popularized either by Taiwan or by India. Okay?
Okay, sir.
So, end of the document. Okay. There's your slides, isn't it?
Yes, sir.
Okay. So, suppose your histopath gets, your histopathology report downgrades the tumor. What staging would you put it as? After histopath, what staging would you put it as? Here you have written clinical staging. So would you put any alphabet in front of your staging?
P, sir. Pathological staging, sir.
Yeah. Oh, so P. Okay. Now, post-operative radiation, how much of radiation would you give in this case?
So post-operatively, it will be 60 to 66 grays, sir.
Very good. Over what period of time?
So over 6 to 6.5 weeks, sir.
That's a bit too long, over 5 to 6 weeks. Okay.
Okay, sir.
Right. They usually give around 35 to 37 fractions.
Oh, yeah. Okay, sir.
What is IMRT?
Intensity modulator radiotherapy, sir.
So how is it given?
Sir, it is like it has like surrounding tissue damage will be very less, sir.
Why? It's 3D planning, 3-dimensional. Okay. Such that maximum dose is given to the tumor and surrounding regions, it's less. Okay. I think for some time I'll keep my mouth shut and I would request the other examiners to take over. Professor Sayaji, Madam Rajeshwari, Dr. Apaji sir, etc. And Dr. Mahesh, would you like to ask anything, sir?
Sir, you are the authority on the subject.
No.
You are there, I think we become students.
No, nothing like that, sir. Nothing like that.
Actually, from Azim, we can learn a lot of things. That's why
Exactly.
we are and now
endorse that.
So this
in fact, it's always a pleasure listening to Dr. Azim. In fact, I don't miss if I get an opportunity.
Thank you, sir. It's an honor to me to be among you.
Mashira, you can highlight what type of biopsy you have taken from primary lesion.
Wedge biopsy, sir.
Wedge biopsy. Okay.
I fully agree with you, but why not punch biopsy, Dr. Masira?
For including the normal tissue, sir.
No, that you can do with punch biopsy also.
Because oral cavity, we want to know depth of invasion will be better with wedge biopsy, sir.
Yeah, that is one thing. And more importantly, in this case, we are suspecting submucosal fibrosis. So your punch biopsy process it's like parchment paper. It will just jump off or tear the submucous fibrosis. So always a wedge is better. Okay. Now you said level 2 lymph node is involved, whereas I would expect level 1 to be involved in this.
Yes, sir.
So is there any method by which you can know whether there are metastatic lymph nodes at all? If it's not there, I can safely do a supraomohead neck dissection in this. And what is super selective neck dissection?
Super selective is like we'll be removing only the high risk, which are
No. That's not the way. We follow the principle of sentinel lymph node. What is sentinel lymph node?
Sentinel lymph node is the first lymph node which will be involved in, sir.
Yeah, the first lymph node to be involved, or lymph node group to be involved, isn't it?
Yes, sir.
So how to look for it, whether there is any involvement at all? It has a predictable pattern. I told you first echelon is submandibular in this case. Okay?
Yes, sir.
Level 1B. So considering a predictable pattern, you will inject a sulfur colloid, a blue dye, or preferably a radioisotope, technetium-99. And the first lymph node to pick up, if you have used a sulfur colloid, you will have to open the neck, which doesn't serve so much purpose. But if you have used technetium-99, you can use gamma probe and see which lymph node has picked up the radioisotope.
Okay.
So that will be the sentinel lymph node or group of lymph nodes. Only that you harvest and do a frozen. If it shows metastasis, go ahead with at least selective neck dissection. If it doesn't show metastasis, you can close it off. Okay?
Okay, sir.
This is sentinel lymph node biopsy, which is coming up in a big way.
Okay, sir.
Any other dye you can use which gives fluorescence, which you can again track on monitor?
Will in contact autofluorescence.
Yeah. Which is our country? Which is our country?
India.
India. In national flag, which is the lowermost color in the tricolor?
Green.
Now tell me which dye you will use. Have you heard indocyanine green?
Oh, okay. Yes, sir.
Indocyanine green can be used. Okay.
Okay, sir.
Costly. Okay. So we use technetium-99 with the gamma probe.
Okay, sir.
Okay. Now, You said level 2 lymph node. Just tell me what are all the areas which drain into level 2?
Sir, will mainly oropharynx, sir.
Okay.
Then in
What about
oropharynx,
nasopharynx?
tonsils.
When you say oropharynx, I presume it includes tonsil, base tongue, uvula, soft palate, and all. So oropharynx, I agree. Any other areas drain into level 2? What about nasopharynx? What about hypopharynx?
Oh, sir. Nasopharynx will primarily be 5th, sir.
No. It also drains to level 2. Okay. All 3 parts of pharynx drain to level 2. That's the first echelon.
Okay.
Which part of larynx will drain to level 2?
Which part of the supraglottis of
Very good. Supraglottis. And any salivary gland drains there?
So parotid, sir.
Parotid. So these are the areas which primarily drain to level 2. But it is the second echelon for oral cavity. Okay.
Okay.
Echelon is station.
Okay.
Okay. So, any doubts you have, Dr. Mazira? For a change, I will be the candidate, you become the examiner. Any questions?
Masira, if you have any doubts, I think Azim is an authority. You can just ask some questions to him. Clear your doubts.
Even the other participants, I think there are 5 chats. Any questions in this? I'll just check. Any question in? There were 5 chats. I didn't see any question here. Is there any question from the audience?
Sir, Azim sir,
Yes, sir.
Actually, in fact, I agree with you. The reconstruction option is free, microvascular free flap with fibula.
Yes, sir.
But in case if the expertise is not available, maybe
Sir.
you can just guide us on how to go about in reconstruction, because the mandible is removed here.
Yes, sir. Sir, in our country, the hard truth is that still pectoralis major is the workhorse for head and neck reconstruction.
Yeah, that is why I wanted to come from horse's mouth only, sir.
The reason is
not many centers have that
exactly
particular option.
See, slowly the free flaps are coming in. So every surgeon should get trained in microvascular free tissue transfer. But everyone should be familiar with pectoralis major because it reduces the operating time. Free flap requires a 2-team approach. You may not always have that. And our
plastic surgery assistance is also required.
Yeah. Our patients majority are undernourished. Some of them have peripheral vascular disease. True. So everyone should be well versed with pectoralis major or any axial flaps also.
Correct, sir. That's
Yes,
what
sir.
actually I wanted to stress. And
Yes, sir.
Unless we know this PMMC in and out,
very true.
Of course, it is ideal to have a microvascular reconstruction, but as you said, for all practical purposes, it is the pectoralis major what is being used.
Yes, sir. Even in our hospital, majority are pect majors. How much time do we have, Dr. Badish?
Is 1 hour, sir. I think
Okay.
now you can summarize.
Okay.
Any others?
Okay. So, Dr. Masira, would you like to summarize it?
Yes, sir.
Yeah.
A patient, a 62-year-old male with ulcer in inner surface of the cheek since 2 months, with burning sensation and bleeding.
Not burning sensation. No, I would say with probable submucous fibrosis.
Yes, sir. With probable submucosis, and he has risk factors of areca nut and tobacco chewing. And on examination, there was a proliferative growth on left buccal mucosa.
So he has a tobacco-induced oral malignancy, probably squamous cell carcinoma, involving his left buccal mucosa, which is clinically T4A-N1, isn't it? So I would go ahead with a contrast-enhanced imaging with a puff cheek technique, a CT scan, and because it's T4A, I would preferably go in for segmental mandibulectomy, preferably hemimandibulectomy. If bone erosion is there, if it's not there, there is option for marginal, and it will be little extended marginal where I would remove the entire coronal process, anterior half of ramus and the alveolar plate. Okay. And with that, a composite resection, that is wide excision of the tumor with at least one plane deeper than the base of the tumor, and a comprehensive neck dissection along with reconstruction, preferably a microvascular free fibula or a pectoralis major myocutaneous flap, and going for adjuvant radiation. In the adverse event of any extranodal spread or positive margin, I would give adjuvant chemotherapy with radiotherapy. So this will be the summary. Okay.
Okay, sir.
Right. Now, we have been talking of chances of extranodal spread. If there is extranodal spread, how will your staging change?
Extranodal spread, then it go for N3B, sir.
Very good. So this change was brought in 2018 in AJC classification. Yes. Any extranodal spread, even if it's a small single lymph node, it will straight make it N3B, and the stage will be
4B, sir.
Yeah. Okay. Any questions from the audience? Is there anything in the chat box? Can someone read out if there's any question?
As of now, there are no questions.
Okay.
Chat box. Okay. But
you know, if questions are not there, there are two possibilities.
No, more like
either audience has understood everything or understood nothing.
More likely that the first one, yes, sir.
Okay, thank you.
The discussion has been wonderful till now.
Thank you, sir.
Azim sir, this is just for just exchange of our views. Like, is it Arcanut is a carcinogenic or coloring agent is a carcinogenic agent?
Both. Arcanut is a very. Someone's mobile is on. Arcanut is a very strong carcinogen. See, Arcanut.
Appaji, sir.
Arcanut is a very strong carcinogen. The reason being it has aracholine, and aracholine induces submucous fibrosis as well as oral cancer. And there are various types of Arcanut usage. If you see our region, South India, they use Arcanut proper, which is dry. Whereas if you go to Manipur and all, Northeast, Meghalaya, they use raw Arcanut, which is much more carcinogenic. It just burns the mucosa. And any coloring agent is a carcinogen. And when we say tobacco quid, it's a cocktail there. You have Arcanut, you have bitter leaves, you have slaked lime, what all. Tobacco itself has almost 63 carcinogens. So all these are carcinogenic.
Thank you,
coloring agent is very dangerous then.
Yeah. Yes, sir.
Sir, Dr. Kanaka Kumar has a question here, sir.
Sure,
we can start radiotherapy if there is a flap.
If there is?
If there is a flap reconstruction. He has not mentioned whether it is a free flap or...
no, whatever flap it is, yes, it has to heal within 10 to 15 days. Even if there is a leak. If it's a small leak, within 3 to 4 weeks, it will heal. So, between 3 to 6 weeks is the ideal time for radiation. Post-operative radiation, maximum of 2 months. More than 2 months beyond the surgery, it will lose its value. The reason is, what radiation we are giving is for microscopic disease, if any. Once that builds up into macroscopic disease, it doesn't help much. Or if it spreads along the violated tissue planes due to surgery, it doesn't help much. So ideally, within the first 6 weeks, I would prefer radiation.
Thank you, sir. I think
Thank
Dr.
you.
Kanaka Kumar, you got the answer.
Thank you.
Any inputs from any other examiners?
Nothing, Dr. Adish. Nothing.
Yes, yes, sir. Thank you very much, sir.
Thank you, sir.
I think we are coming to the end of the second session.
Just 2 minutes, I would request our presenter, our student to change the role. We would want her to be examiner and fire questions at us.
That's wonderful, sir.
Dr. Masira.
Dr. Masira.
Let us see how it feels on the student side of the table. So you fire the questions.
Okay. So what are the carcinogenics in the tobacco chewing, sir?
I told you, tobacco itself has 63 carcinogens. With that, our people use tobacco quid, which is a combination, a cocktail. You'll have areca nut in that, you'll have bitter leaves, you'll have select lime and whatnot. So all these are carcinogenic. Maybe the only thing which is not carcinogenic is they put little lemon or something sometimes.
So, but initially I have read like in like some books, sir, because it is more like chewing smoke tobacco has nitrosamines as the carcinogen, whereas like smoking has like hydrocarbons.
Yeah, but both are present in both the sources. It's only the proportion. Okay.
Okay, sir.
And if you ask me at the cellular level, tobacco causes hypomethylation and hyperacetylation of the histones, thereby inducing carcinogenesis. Okay? It suppresses the tumor suppressor genes. Okay.
Azim, like Sulia, where I work at Sulia KVG Medical College.
Yes, sir.
I think dental department, they have a screening program of, it's an endemic area where you have a lot of oral cavity cancers and all those because of coconut and tobacco habits and all
Yes,
those.
sir. Yes, sir.
But the screening, what is the best way of screening, mass screening of oral cavity cancers?
Sir, the health workers, however junior, even if they are paramedical, can be shown the pre-malignant lesions as well as the appearance of oral cancer. A simple torch and tongue depressor examination is enough to pick it up. The famous Dr. Shankar Narayan study, which was published in Lancet, they screened more than 1 lakh patients, and so many cases were picked up, what would have probably got missed. Yes, we should stop concentrating on, rather depending on Western inputs. This is our disease, which has maximum prevalence in our country. The incidence is increasing with gutkhas and pan masalas and whatnot. So we need to bring in clinical research for it. That's a good step you have taken, sir, the screening program. We need to have more of this. And not only that, once we screen the cases, the patients which have a lesion, we should look for repetitive mutations, if any. Then later on, screen the local population for that repetitive mutation and see those who are going to be probable candidates for this disease so that we can pick them up early and have better results.
Yeah, thank you, Azim.
Thank you, sir.
Thank you, sir. So,
Thank
Azim,
you.
sir,
Yes, sir.
does betel leaf protect against carcinogenics?
No, it doesn't. It doesn't. It doesn't.
Yes.
See, if you ask a person who is addicted to liquor, if for a happy occasion, he will say celebration and drink. For a sad occasion, he will say depression and drink, but he will drink. So those who are addicted to bitter leaves, there's an excuse. It may not be as strong a carcinogen as areca nut or tobacco, but definitely it contributes.
Thank you, sir.
Thank you.
Shall we conclude the session?
Sure, sir. Thank you.
I thank all the examiners, Dr. Azim sir, Dr. Mohanappaji sir, Somaji sir, Mahesh SG, and Rajeshwari madam, and also Dr. Sapna. Dr. Sapna madam had to leave in between due to some emergency calls. I thank all the examiners for sharing their precious time and sparing their precious time and sharing their knowledge with us. And I thank Dr. Masira for taking this stage to present the case for the benefit of all the delegates.
Thank you, Dr. Masira. You did very well. Only thing, little more practical application should come. It will come with experience. And I would like to thank all the co-examiners and the audience, and mainly the organizing committee for having given us this opportunity. It was excellent being here. I think I will be logging out of the meeting now. I'll be leaving the meeting because I'll have to catch the flight in the evening to Mangalore.
Yes, sir. Yes, sir.
It was excellent being here. Thanks a lot.
Thank you very much, Azim sir. We'll meet you at around 8:30 in Mangalore.
Thank you, sir. Thank you, Dr. Ganga and Dr. Gangadhar Somayaji, sir, Rajeshwari Madam, Mohan Appaji, sir, Dr. Mahesh. Thanks a lot.
Thank you, Azim sir. We learned a lot.
Thank you.
Thank you, sir. Thank you.
Vadish, thank you.
Thank you very much,
I'm also logging out because of official work here. And
Yes,
again,
sir.
I'm available in the afternoon if you want.
Thank you very much, sir. Even Azim sir, if you are not driving, then probably you can.
No, I'll have to drive. It takes,
I know.
Yeah, it takes nearly 1.5 hours from here.
I don't know, sir.
2 hours before flight.
Yes, sir.
Time we need to be in airport.
Yes, sir.
There is 7 o'clock is my flight.
Yes, sir. Thank you very much, sir.
Thank you, sir. Thank you.
Thank you, sir. Dr. Masira, you can. Thank you very much, sir. Sir, Appaji, sir, you are staying back or?
Yeah, maybe post lunch I may join, but little busy.
Yes.
I'm little busy.
Yes, sir.
Okay,
Yes,
thank
sir.
you very
Yes.
much.
Thank you very much, sir.
Thank you.
Sir. Thank you, sir. Dr. Masira, you can stop sharing your screen. And now the third case will be a laryngology by Dr. Nikhila from Karnataka Institute of Medical Sciences, Hubli. And the examiners for this is Dr. Suja Sridharan, Professor of ENT from Kasturba Medical College, Mangaluru. Dr. Balakrishnan, Professor of ENT from Kasturba Medical College, Manipal. Dr. Arun Kumar, Professor and Head of ENT, STM, Dharwad. And Vijayalakshmi Madam, Professor and Head of ENT, Yenapoya Medical College. And Dr. Azim Sir, whenever.
Yeah, I think in a few minutes I'll be leaving, sir.
Yes, sir. So you are welcome for all our cases, sir.
Thank you, sir. Thank you.
Thank you.
Nice to see you, sir.
Nice meeting you all, madam. Thank you. I'll be meeting you in person tomorrow.
Yes, sir.
Thank you.
Dr. Nikhila, stage is yours. Good morning, Suja Madam. I think I saw Madam here. Yeah, she's here. Arun Kumar sir had some technical issues with joining. He told he will join soon.
Oh, okay. I was not unmuted. Good morning.
Good morning, Suja Madam.
Sorry. Good morning. Yeah. Should we better to mute ourselves? Is it? Should we mute ourselves and stop the video also?
Yeah. No, video can be kept open, ma'am. That is optional, ma'am. But better to mute and unmute when we are speaking, ma'am, because otherwise there will be echoing.
Nice to see you, Dr. Azim.
Nice meeting you, madam. Yeah, pleasure being here. Only thing, in few minutes I'll have to leave.
Yes, I know, and I don't let anyone persuade you to drive and take a class, because Dr. Azim drives very fast. Very dangerous.
I'll be among you tomorrow, madam. I'll be there.
Okay.
Yeah, Dr. Nikhila, you can start presenting.
Good morning, Nikhila.
Good morning, ma'am.
Yes.
Am I audible?
Yes,
Yes,
you're audible.
yes,
You can start. Yes.
The moment I say Kim's Hubli, I guess nostalgic. My alma mater.
Okay.
Good afternoon, everyone.
Good afternoon.
Can I
Dr.
start
Nikhila?
with my
Yes,
presentation?
Yes, please.
Yes,
Yes,
Nikhila,
please.
just go on the slide
Can I start,
mode.
sir?
Yeah, go on the slideshow mode and start. Yeah.
Yeah. Yes, ma'am. Is it clear, ma'am?
No, we are seeing your slide, but you're not yet gone on the full screen mode. Go on the slideshow mode.
Hello, ma'am. Still, it is not coming in full screen.
Yeah, go on top where your home button, your file insert is there. There's a slideshow mode. There's a slideshow button on top on the screen. You click on that and say go to slideshow. I think if you're not able to, yeah, now it's going, I think, yeah. But you've gone on the presenter mode of the slideshow.
It is okay. If you're not able to do,
It's okay. You go ahead. It doesn't matter. You go ahead. You present. It's okay. Dr. Nikhila, you can start. It's okay.
Okay, ma'am. Good afternoon, everyone. I'm from KIMS Hubli. I'm doing a case presentation on Mrs. Kamalava. Mrs. Kamalava, a 50-year-old female coming from Gadag, who is an agricultural worker. She presented with chief complaints of change in voice since 4 months, complaints of difficulty in swallowing since 2 months, and complaints of difficulty in breathing since 7 days. History of presenting illness. Patient was apparently normal 4 months back, following which she presented with change in voice, which was insidious in onset, gradually progressive. It was hoarse type of voice, not able to raise the pitch of her voice, and it was constant throughout the day, and there was no diurnal variation. There was no aggravating or relieving factors. There was no history of excessive use of voice. She also complains of difficulty in swallowing since 2 months, which was insidious in onset, progressive. She is able to swallow semi-solid food, but she feels the food is getting stuck in the throat while having solid food, and it was associated with pain during swallowing. Patient also complains of difficulty in breathing since 7 days, which was insidious in onset, progressive. It was present on exertion and relieves with rest. There was no diurnal variation. There was no history of noisy breathing, cough while swallowing, nasal regurgitation. There was no history of fever episodes or cough. No history of loss of appetite or loss of weight. No history of any ear or nose complaints. Patient took treatment from local hospital on OPD basis, but her symptoms was not improved, and she presented to our institute for further evaluation. Past history, no history of diabetes.
Before past history, Dr. Nikhila, right?
Yes, sir. Yes, sir.
So what do you think it is based on the history so far?
Sir, based on the history, she is having change in voice, difficulty in swallowing, and difficulty in breathing, sir. So
Which happened
probably
first?
It could.
You said change in voice happened first.
Change in voice happened first, sir. Following which she developed a difficulty in swallowing, and recently, last 1 week, she is having difficulty in breathing.
What was the change in voice?
So I suspect, sir, it was hoarseness of voice was there, sir. There was no diurnal variation throughout the day.
You forget the diurnal variation and all that. If it's progressive and associated with dysphagia and all, I would not even think of diurnal variation here. That's only for change in voice.
Yes, sir.
So what do you think it is? Is it a glottic problem which has gone to supraglottis, or supraglottic which has gone to glottis, or is it hypopharynx? What is it?
Sir, since her presenting complaint, it started with change in voice. So I suspect a glottic pathology, which is going to supraglottis or other structures. Sir.
Okay,
Primarily, it is I suspect a glottic malignancy, sir.
Okay. So if glottic malignancy is also associated with dysphagia, what can be the reason?
Sir, from history-wise, I feel either it could have extended to the post-cricoid region or the involvement of the piriform fossa involvement. Like
how it would have reached the piriform fossa?
Sir, in the glottic malignancy, usually the early stage, it is rare to present with
That's why I'm asking you. That's why I'm asking you.
But
That's why I'm asking.
History, I'll be able to tell like either a spread of the like glottic malignancy.
Spread posteriorly into cricoarytenoid joint. Posterior spread to cricoarytenoid joint. Am I audible? I think I've lost you on the audio.
Yes, sir.
Yeah. Could it be posterior spread into cricoarytenoid joint?
Dr. Nikhila, are you able to hear us?
Hello, sir.
Are you able to hear?
Yes, sir. Now I can hear. Sir.
Could it have spread posteriorly to cricoarytenoid joint?
Sir, sir, can you?
The glottic malignancy,
Yes, sir.
could it have spread posteriorly to the cricoarytenoid joint?
Sir, if there is like posteriorly, it can involve a cricoarytenoid joint. Sir.
Otherwise, how can you explain the dysphagia, isn't it?
Yes, sir. Yes, sir.
Okay.
Is it?
Sir, is my screen is visible now, sir?
No.
No.
You are visible.
Okay, sir. 1 minute. Yes, sir.
Okay.
Is it a difficulty in swallowing or is it painful swallowing? And what is she able to take now?
Actually, initially she had difficulty in swallowing, and it was mainly for solids, ma'am. And she was able to swallow semi-solid food, but while having solid food, she is feeling like something is stuck into the throat, and it was associated with the painful swallowing also, ma'am.
Would you ask for anything else during swallowing? Does she get cough on swallowing? Bouts of cough?
She has asked.
There was no history of, I have mentioned, sir, there was no history of cough while swallowing, sir.
Okay, okay. Okay. Okay, then proceed.
Yes. Sir,
yeah.
Past history, sir. Past history, no history of diabetes mellitus, hypertension, pulmonary tuberculosis, bronchial asthma, cardiac diseases. There was no history of any recent surgeries in the past, and there was no history of any drug allergy. And family history, nothing contributory. Personal history, diet was mixed, appetite is good, sleep is adequate, bowel and bladder habits are regular. There was no history of smoking, alcohol consumption, or any chewing habits. Obstetric and menstrual history, she is para 2 with 2 living children. She attained menopause at the age of 45 years, and she underwent tubectomy 25 years back. And socioeconomic status, she hails from a lower socioeconomic status.
Okay.
General physical examination. Sir, am I audible, sir?
Yeah, yeah.
Yes, doctor.
Yes, yes. Can I proceed, sir?
Sure.
Yes. General physical examination. A 50-year-old female patient was moderately built and nourished, conscious, cooperative, oriented to time, place, and person. Her vitals was stable. There was no pallor, generalized lymphadenopathy. There was no icterus, cyanosis, or pedal edema.
Again, as I said in the last case, I would not expect icterus here. In this case, who has come with difficulty in breathing, I would look for clubbing, cyanosis, dilated veins in the neck or upper chest. These things I would look for. Okay?
Yes, sir.
Okay. Right.
Ear, nose, and throat examination. Oral cavity, mouth opening is adequate. Oral hygiene is good. Lips are normal. Gingivo-labial sulcus is normal. Gingivo-buccal sulcus normal. Gums normal. Teeth, dental caries noted in the right upper molar. There was no loose teeth. Buccal mucosa normal. Bilateral retromolar trigger normal. Anterior tooth. Oral cavity other than caries tooth, it was normal. Sir.
Okay, proceed.
Yes, sir, normal. Yes. Oropharynx was normal, sir.
Proceed. Proceed. Yeah.
Indirect laryngoscopy examination. Indirect laryngoscopy examination, sir.
Yeah.
Base of tongue, median and lateral glossoepiglottic folds, bilateral vallecula, epiglottis, bilateral araepiglottic folds, and bilateral arytenoids was normal. There was a proliferative growth noted on the entire length of left true chord and anterior 1/3 of the right true chord with involvement of the anterior commissure. And the left true chord was fixed and left false chord was bulky. The right chord was mobile. Glottic space was visualized posteriorly. Bilateral pyrrhophofossa appears normal. Sir, I have a 70-degree endoscopy video. I'll play it, sir.
Yeah. Can you play it once more?
Dr. Nikhila, can you describe the lesion as you play the video to us?
Play it once more and describe. Yeah. It's not visible. Video is not visible. Video is not visible, Dr. Nikhila.
Can you replay that?
Yes, sir. 1 minute, sir.
Just double click so it will go on the full screen mode. You'll be able to. Okay.
Sir, is this video is clear there?
We are not seeing your video at all.
Yeah, I'm not seeing the video at all.
Sorry, sir. 1 minute, sir. It is not shared.
Vadesh, if you have the video, you can play, I suppose.
My screen is not visible, sir.
Screen is visible.
Your slide is visible, but not the video.
Sir, now my screen is visible.
Slide is visible.
No, only slide is visible, not video.
Maybe you go to presenters mode and show it to us again. Sometimes in full screen, it doesn't play.
Okay, ma'am, I'll try.
Dr. Nikhila, you can unshare your PowerPoint and share only the video. That will work. You have the video file with you, right? So you can share that.
1 minute, ma'am. Sir, is it coming now?
No, we are seeing only your PPT screen. No.
Okay.
We are seeing the slide where you're seeing that the patient presented for further evaluation after taking treatment from local hospital on OP basis. That screen we are seeing.
I'm very sorry, sir. My laptop got stuck. 1 minute, sir. I'll rectify it. Okay, I'll try.
disconnected.
You have images of the same patient instead of video?
Yeah.
Oh, no, sir.
If you have, sir, good morning, sir. Dr. Azim, sir.
Good morning.
Good morning. Dr. Arun here.
Nikila, you can share the video file directly. When you share the screen, you have the
If
option
the
to share the video file
is not
directly.
playing, we can share the images if photographs are there.
ഓപ്പൺ ചെയ്തിട്ടില്ല ഇവൻ അത് അന്നത്തെ പ്രശ്നം കണ്ടപ്പോൾ സ്റ്റാർട്ട് ചെയ്യുന്നുണ്ടോ വീഡിയോ?
Is it visible now?
Yeah, now the video is seen, but it is not playing.
Hi, 7 minutes.
Yeah.
Sir, is it coming now?
Yes, go ahead. Yeah.
Sorry, sir. Sorry for the delay.
No problem.
No, yeah.
Okay, describe it, Dr. Nikila.
Sir, there was a proliferative growth noted on the entire length of the left vocal cord, involving the anterior 1/3 of the right vocal cord also, sir, with involvement of anterior condition. And left vocal cord appears fixed, sir. And the left false cord looks bulky.
Okay, continue.
In this video, I feel like subglottis also there is involvement, sir.
How will you define subglottis?
Sir, it's 1 centimeter below the level of ventricle to the lower border of cricoid cartilage.
1 centimeter below the vocal cord anteriorly or posteriorly?
Sir, anterior.
What about posterior? 0.5 centimeter.
0.5.
So the line joining these 2 points till the lower border of cricoid
cartilage.
Okay. So continue your findings.
Yes, sir. Sir, neck examination. Inspection, trachea appears normal. The laryngeal framework was normal. On palpation, trachea was central. Laryngeal crepitus was present. There was no palpable lymph nodes and there was no tenderness on palpation of larynx.
What is Boca's sign and what is Moore's sign?
I said the absence of the laryngeal crepitus is called as Boca's sign, sir.
At the level of what?
At the level of cricoid cartilage, sir.
Yes. What is Moore's sign?
Sir, Moore's sign is the normal laryngeal crackles.
No. Loss of crepitus at the level of superior corner of thyroid
cartilage.
Okay. It's the superior lamen of cricoid and superior corner of thyroid which rubs against the vertebral bodies. Okay. What is Jackson's sign?
Sir, the pooling of saliva in the piriform sinus, sir.
Okay.
It's not as Jackson's.
Okay, continue.
Ear examination, bilateral ESC was normal. Tympanic membrane was normal.
Normal, isn't it?
Yes, sir.
Okay.
Systemic examination was within normal limits, sir.
Okay. So
neck examination. Did you finish neck examination?
Yes, sir. Finished, sir.
Can you brief because at that time audio was.
Yes, sir.
Okay.
Next examination was normal, sir.
As per you.
No palpable nodes, sir.
No palpable nodes.
No, sir.
Okay. Would you expect palpable lymph nodes from glottic primary?
Sir, it is very rare, sir.
Why?
Because it is less of lymphatics in the glottic, sir.
Almost nil lymphatics for vocal cord.
Yes,
okay,
sir.
then
unless it is spread to supraglottis or nearby
No,
laterally it
it
is
can.
spread, there is no.
No, it can
It is
happen.
very yes, sir.
It can
Levels.
happen. It can happen little late in the disease, but it spreads to level
Not,
6.
yes, sir. Level 6 involvement. Yes.
Right. So, what is your diagnosis?
Sir, my provisional clinical diagnosis is a malignancy of glottis with T3, N0, and MX with stage 3, sir.
Because of T3, N0, MX, it's stage 3, isn't it?
Yes, sir.
Okay.
Nikhila, given the clinical picture that you described, why do you think this patient has got difficulty in swallowing? Now you can tell us. Yeah.
Yes, ma'am. Ma'am, according to my clinical examination, I couldn't find any growth in the piriform sinus or even the laryngeal crepitus also I felt it is present only. So a hypopharyngeal post-cricoid growth or it is I can't suspect at this stage. So either it could be a separate or a second primary in the upper esophagus or
If it is second primary, what would you call it? Which type of second primary?
synchronous.
Okay. Could the fixity of cricoarytenoid joint cause adenophagia or dysphagia?
Sir, it can cause.
How? The vocal cord is not mobile due to what?
The fixity is like it is. Yes,
so if it was fixed, it could have cartilage, isn't it? It could have affected the joint. It could have irritated the cartilage also.
Yes, sir. Yes.
That minimal erosion will not even pick up on CT scan, let alone scopy, isn't it?
Yes, sir.
Okay. Okay, proceed. What is a transglottic tumor?
The transglottic tumor is either a tumor of the glottis or a supraglottis which transfers across the ventricle.
Across the ventricle or any other space?
Involvement of subglottis.
No.
Any space?
Paraglottic.
No. Para what? Not pharynx. Para?
Paraglottic space.
Yes.
Can you tell me what are all the reasons why in this patient you can get fixity of the vocal cord? You said the larynx is fixed, the cord is fixed.
Fixity can be due to cricoarytenoid joint involvement.
Yes.
Okay. Thyroarytenoid muscle involvement.
Very good.
The paraglottic space involvement also can cause fixity, sir. And the mass effect also can cause reduced movement of the cord. And in case of recurrent laryngeal nerve involvement also, fixity can be.
Will recurrent laryngeal nerve be involved in a glottic primary? Unlikely. Very rare.
Yes.
Very rare. Before that, where does the nerve enter the larynx?
Yes, sir. Thyroid.
Enter the larynx from the outside, from the neck. Where does it enter the larynx?
So the recurrent laryngeal nerve on the right side, it will take it.
You are taking me back into chest.
No. Don't go there. You tell how it's.
How the recurrent laryngeal nerve enters the larynx.
Yes.
There is a joint.
Yes, sir.
The joint between two major cartilages.
Cricoarytenoid joints.
Crico?
Arytenoid joint.
Crico, I said two.
No, big cartilage.
Cricothyroid.
Yes, so medial to that, isn't it? So getting involved at that small point is very unlikely. Nerve paralysis, I would accept in a malignancy in the neck, like thyroid or in the chest. Okay?
Yes.
Not in larynx. Here you said cricoarytenoid joint fixity agreed. You said thyroarytenoideous fixity agreed. You said paraglottic space involvement agreed. Don't bring nerve here.
Okay, sir.
Continue.
Sir, I'll be investigating the patient with, since I'll be planning for a direct laryngoscopic examination and biopsy, I'll be getting routine blood investigations, which will include hemoglobin, total count, platelet count, the bleeding and clotting times, random blood sugar, HIV and HbSAg. And because it's a malignancy, the liver and liver function test and the renal function test also I'll be carrying out. And I should get.
I would have kept cut, but you said because it's a malignancy. What's so special about that being a malignancy? Liver function test.
Sir, metastasis can occur and.
Will it cause liver failure by having 1 or 2 nodules metastasis? No. That is a wrong concept. Okay?
Yes.
Yeah.
Akila, even if you're writing short forms, first of all, don't write. I mean, it's not required for you to write. We will ask you.
Yeah.
Investigations and exam. Even if you're
Yes.
writing, there is a way in which you have to write all this RBS and all. No, it is not short, small letters.
Small letters.
Okay.
HbSAg.
HbS antigen, very careful here to be.
Yes, ma'am. Yes, ma'am.
So, which is a capital and which is small. Okay.
Yes, ma'am. Yes,
yeah.
Would you do a X-ray neck at all?
Yes, sir.
Why?
Chest X-ray to look the.
Chest X-ray, I agree.
Yes,
I'm talking of X-ray neck. You have written lateral neck. Why?
Sir, to see the airway, like she was.
Patient has got exertional dyspnea. You have seen growth involving the entire length of one cord and anterior 1/3 of other cord. So what is there to see on X-ray?
Whether it is extended to subglottis or.
Will it show on X-ray? You are doing a CECT. Would you specify what type of CECT?
Sir, CECT neck.
What type? Would you like to talk to a radiologist? He will take 4 or 5 mm cuts. Your glottis will pass in 1 or 2 cuts.
Sir, 1 mm cuts.
Yeah, at the level of larynx, you require 1 mm cuts.
1 mm cuts.
Rest of the neck, he can take routine cuts. Okay?
Yes, sir.
So when you are doing such a high resolution imaging, what's the need of an X-ray? Not required. X-ray chest, I agree. Okay?
Sir.
Yeah, continue.
So what do you want to see in CECT neck? What are you looking for in this patient? Who has got both breathing difficulty, change of voice, and difficulty in swallowing. Yeah. So what are you looking for in this patient when you're doing CECT neck? As far as the tumor is concerned?
Okay.
Can you hear me?
Yes, ma'am.
Okay.
What are you CECT neck I'll be doing to see the extension of the disease, ma'am. Whether there is involvement of the cartilage involvement, it is extending to the pre-epiglottic paraglottic space. Whether there is
can you be more specific which cartilage involvement you are looking for?
Thyroid cartilage, ma'am.
Okay.
And any nodal involvement.
Then no, don't leave the tumor so fast. Tumor, so paraglottic, which space involvement?
Ma'am, paraglottic space involvement.
Paraglottic space involvement. Then what about subglottis? You said you feel
yes,
it is down to the subglottis.
Yes, ma'am, subglottic involvement.
Okay. From the paraglottic space, can the tumor go out somewhere? And how does it go out?
And from paraglottic space?
Yes.
Outside, extra laryngeal she means.
It can erosion of the thyroid cartilage and it
that
can
is
spread
direct.
to.
Yeah, but that by even by your palpation tenderness, maybe there can be a widening, broadening of the cartilage. But any other way it can go outside.
Anything enters or leaves?
If you tell us the boundaries of the paraglottic space, probably you'll get an idea.
Paraglottic space medially bounded by the quadrangular cartilage and conus elasticus.
Quadrangular membrane or cartilage?
Membrane, quadrangular membrane, sir. Conus elasticus. Laterally by the cricothyroid.
Why cricothyroid? Why not cartilage? Which cartilage?
Thyroid cartilage. And posteriorly by the anterior reflection of the piriform cells.
Yes.
Okay.
Here the anterior commissure is involved, isn't it?
Yes, sir. Anterior commissure is involved.
So what is the risk in this case? What we are seeing as stage 3, can it become stage 4? Can it be stage 4? Is there a chance?
Yes, sir. It can involve the thyroid cartilage and
Where? Where?
At the point of attachment of anterior commissure.
What is the tendon?
Broy's ligaments.
So there is no inner perichondrium at that level.
Yes,
okay.
Sir. So easy spread to the thyroid cartilage and
which we may not even see on CT scan.
Yes, sir.
Okay.
So what about the esophagus? You said you may have something in the esophagus.
Exactly. I was just about to ask that. You have written direct laryngoscopy and biopsy. You have been talking of second primary.
I would like to do an upper GI scopy examination also to rule out any other pathology in the esophagus.
I am not sure whether you need to say upper GI scopy as a separate one, because anyway you have to take up the patient for direct laryngoscopy, biopsy.
Yes, ma'am.
So at the same time you can say I would like to do an esophagoscopy, hypopharyngoscopy, esophagoscopy.
Yes,
what would you call it then?
Panendoscopy.
No, when you include nasopharynx, it's panendoscopy. Otherwise, it is Endoscopy. What is it?
Trachea also. So
bronchoscopy, direct laryngoscopy, and hypopharyngoscopy.
Yeah. Triple scopy.
Triple scopy.
Okay. Yeah.
Okay. Any other investigation can be done if you have the facility here? You said dysphagia and all. I didn't see any tumor on the arytenoid. I want to confirm. Can you put anything else in your operating microscope to check?
Sir, we can do a supravital staining, sir.
Supravital staining where in larynx? In oral cavity, I agree. So to stain, you'll put the patient under GA, wash it out, and then induce again, is it? Instead of that, will you use anything else with the operating microscope?
Sir, narrow.
Say it
Narrow band
loudly.
imaging.
Narrow band imaging. What are you doing there?
The color.
Color filter.
Yes, sir. Color.
So which light are you using for narrow band imaging?
Sir,
Say it loudly. Blue or?
Blue or green.
Wavelength?
Wavelength.
$400
to 650 nanometers.
Okay, sir.
Okay, and what is it that you see when you're using narrowband imaging? And in which situations it is useful?
The area where there is a pathology, it will appear blue.
No, the background will be bluish or greenish. It will appear
greenish. The background will appear bluish or green.
What will the tumor look like?
Black.
Oh no, red or brownish. Okay.
Yeah, and you are trying to see the vascularity. Okay, you see the pattern of vascularity, and also you will be able to see nuclear cytoplasmic ratio, that mitotic figures, all those things.
Okay.
That is how you make a judgment whether this is tumor or not.
So suppose you are seeing the subepithelial blood vessels. What other terminology will you use other than narrowband imaging?
Subepithelial blood vessels.
Ah. What is contact endoscopy?
So contact endoscopy is
I have given you the answer.
Yeah, but
I have given you the answer. Do you know the various types of blood vessel arrangement there? At least what is normal, what is tumor? Don't know?
contact endoscopy.
Okay. Right. Presuming it's T3N0.
Yes, sir.
How will you proceed with management?
Sir, since there is vocal cord fixity and T3, we can go for a total laryngectomy, sir, but we should.
No. No. Not in this era.
And first, we should go for a conservative.
30 years back, I would have agreed.
Sir,
any other option? No, okay. You think of something else, some other option that can be done. You must have heard the words going around, isn't it?
We can go for a concurrent chemoradiotherapy.
So what would you call it as?
Conservative.
You are preserving something, so.
Voice preservation.
Voice preservation or organ preservation?
Or organ preservation, sorry.
What is voice preservation? You pulled me into it. What other surgical option you have here to preserve the voice?
Like we can go for not in this case, sir. Like endoscope, if it is.
Fixed cord, would you do endoscopic? No.
No, sir. That's no. Not for this case, sir. In this case, with voice preservation and near total laryngectomy can be done, sir.
Near total can be done if the interarytenoid region is disease-free, or if there is no extension into hypopharynx, like what is looking on your video, and if the lung reserve is good,
yes, sir.
you can do something else. What is the subtotal laryngectomy for glottic tumor?
So vertical partial laryngectomy.
No. That's partial. Subtotal.
The subtotal is
Supra.
Supraglottic.
Hey.
Epiglotic.
Supracricoid. You can do, okay?
Yes.
Provided subglottic spread is not reaching the lower border of cricoid, and provided lung reserve is good. Near total is a safe option, okay?
Yes.
So I would preserve the organ, isn't it?
Yes.
If there is no cartilage erosion on CT scan, I would preserve the organ.
Yes.
So you said concurrent CTRT. Do you know which study popularized it? You are a lady, so a lady popularized it. Tell me. You know it?
I've read it several times.
RTOG 9111. Who is it?
Yes.
Who is it? Arlene Forestier. What do you understand by concurrent CTRT?
Hello, sir.
Yeah.
What? Yeah, tell me.
Sir, can you repeat the question, sir?
What is concurrent CTRT?
Concurrent CTRT, sir.
Concurrent means what? Can you, I think we have lost her again.
Yeah, we have lost your audio.
Yeah.
Hello, sir. Am I audible, sir?
Yeah. What is concurrent?
Sir, concurrent CTRT is chemotherapy and radiotherapy is given like together.
How? Once in how many days you will give chemotherapy?
Once in 3.
Once in?
Once in 3 weeks, sir.
So day 0, 21 and 42.
21, 42. Sir.
And what about radiation?
Radiation 6 to 7 weeks, sir.
5 to 6 weeks. Okay. What dose of radiation will you give with, and which is your first line drug for chemotherapy?
Cisplatin.
What dose of radiation?
Radiation 60 to 70 grams.
Very good. Any other option other than cisplatin?
Paclitaxel or doxycycline.
Taxanes. Now you tell me the cell cycle checkpoints where cisplatin acts and where taxanes act.
Sir, cisplatin act at the S phase, sir.
Yes.
Paclitaxel junction. G1 is junction.
Yeah, I missed. Where do the taxanes act?
Sir, is it in G2 phase? Sir?
Junction of G2 and M phase. That's the second checkpoint. Okay.
Okay, sir.
What is the principle behind chemoradiotherapy? Why we are giving all these two together? Any idea?
It will arrest the cell cycle in S phase, like DNA synthesis is inhibited, so that further disease proliferation is arrested.
Then? Chemotherapy, it will sensitize hypoxic cells for radiation.
Yes, ma'am. Radio sensitive.
Then radio-resistant cells, it will kill.
Yes, ma'am.
In the S phase. Okay.
Yes, ma'am. Yes,
so answers you should know.
Yes, ma'am.
Something is, if you want to put a patient to for chemo radiation, there is something very important as far as the patient is concerned, not something to do with the tumor. What is that? Because chemoradiation, it is a toxic treatment or it is a mild treatment?
Yes, ma'am. It is toxic treatment.
Toxic treatment, isn't it?
Yes, yes, ma'am.
Finds the effect of chemotherapy and radiotherapy. So, what is it you need to, in your examination also, I think you should stress on that. How do you assess the fitness of the patient?
Yes, ma'am.
Any scale is there? Did you mention it?
I think I saw some KPS.
I have not mentioned, sir.
Okay, I think the previous candidate.
At least, do you know the names? Do you know the names?
Karnofsky scales.
Okay, any other scale you know?
Echo,
Very good.
echo scales.
I'm sorry to intervene.
Sir, you are muted, sir. Azim, sir.
Just wanted to thank everybody. I'll have to leave. If not, I'll be missing my flight today.
Thank you very much, sir.
Tomorrow in Mangalore.
Yes, sir. Yes.
It's a pleasure being here among all of you. Thank you. Thanks, madam.
Thank you very much, sir. Arun Kumar sir is here, sir. I think.
Okay.
Sir, I think. Oh, sir is muted. Some audio issues sir was having.
Thank you, sir.
Some problem with our network, sir.
Yeah.
Yes, sir. Yes, sir.
Thank you, sir. Nice being with you, with Suja madam, with Vijay Lakshmi madam, with what is sir. It's been an excellent experience. Carry on, Dr. Nigela. You are presenting well. Thank you.
Thank you very much, sir. Azim, sir, we'll see you in the evening, sir.
Sure. Thank you.
Yes.
Thank you.
Sir, we'll continue with the case, sir. Thank you very much, sir. Dr. Nikila.
Hi,
Now,
sir.
yes.
Okay, so you were telling something about Karnofsky scale, so that it's important. So when you are sending the patient, you're thinking about chemoradiation for the patient. Patient has to be very fit for the chemoradiation. Okay?
Yes,
because this is not palliative treatment. This is radical treatment.
Yes, ma'am.
Almost like the patient, as much the patient should be fit for surgery, that much the patient should be fit for chemoradiation.
Yes.
Yes?
Yes, ma'am.
What complications are there after radiotherapy? Can you tell me?
Sir, ma'am, after radiotherapy, there can be a dryness of the mouth, mucositis changes can
You can
be there.
divide it if you want, acute and late.
Acute changes like patient can have fatigue, nausea. The edema can be there.
Okay.
Mucus. Dry mouth can be there.
Xerostomia. Then
Xerostomia.
What is it? Mucosa. You started saying something.
Mucositis can happen.
Yes. There can be mucositis. Can be there. There are grades of mucositis. Yes. Then what about anything? This is larynx case, isn't it? So radiation it's not from the inside; it's from the outside. So a lot of tissues are there, isn't it? What happens to
nearby structures? It can
skin.
Discoloration of the skin can happen.
Discoloration, yes. What is it called? Dermatitis.
Hello, ma'am.
Hello. Dermatitis. Yes. Hello. I can't hear. I don't think you can hear me.
Yes, ma'am.
Skin changes can be there, isn't it?
Yes, ma'am. Skin discoloration can be there.
It's not only discoloration.
Is it discoloration?
Dermatitis or
Okay. Okay. Then what are the things?
The other structures can malignant transformation can occur.
No, in this patient, intermediate changes. Can you tell me? In this patient, you think of chemo RT. You're giving this patient chemo RT.
Yes.
Intermediate, any complication can be there, and you will have to do something. This is a glottic malignancy. You said
laryngeal edema can occur.
Yes, and so
that the patient can go into stridor.
Oh, patient can go into stridor, very much so.
Yes,
because this is a very compromised airway.
Yes,
and if you, in fact, some radiation oncologists will ask for a tracheostomy
before starting.
Yeah, so that is something. Then late complications.
Late complications can be malignant.
No, that is not that late. That we have to look at 20-25 years. What happens? There is a tissue right in front. Yes, fibrosis. Yes, the neck. Yes, of soft subcutaneous tissue. Yes. Then, what are the late complications of radiotherapy? So these are the questions that you have to anticipate. Okay.
Yes, ma'am.
Because you don't know in which way the patient. See, you planned for total laryngectomy in your mind. Probably in your mind you are running through the complications, all that, but the examiner may be thinking more of chemo RT or RT. So you have to prepare for both.
Yes,
which way the questions will go, you cannot predict.
Yes,
okay. Dr. Arun Kumar, Dr. Vijay Lakshmi, please.
Yeah. Dr. Arun Kumar has some network issues.
Oh, network issue.
Yes.
Yeah, Dr. Nikila, what are the agents which have been used for targeted therapy along with your chemotherapy?
Ma'am, monoclonal antibodies can be used like cetuximab.
So how do they work and what are the problems associated with them?
epithelial, they act on the epithelial growth factor receptors.
The problem, main problem, can you tell us? Ma'am?
Hello, ma'am.
What are the problems with using cetuximab? One problem at least you tell, the more major problem.
Problem with cetuximab, ma'am? Like available.
You want to say availability? Yeah.
Ma'am, like cost.
Cost, yes. She's asking about side effect. Dr. Vijayalakshmi is asking about
side effects.
Yeah, I'm asking about side effect. Cost, yes. We can't say.
Yeah. That we cannot.
Side effect.
Okay. So what? Very bad skin reactions there.
Okay, ma'am.
Very bad skin reaction. So, so that is one of the known side effects.
Okay.
You were talking about near total laryngectomy, no? What is near total laryngectomy?
Near total laryngectomy is preservation. One cricoarytenoid joint is, if it is free, it is
and half the cord
so
of one side. Yeah.
So the patient will have voice, but the nasal respiration is not preserved.
Okay, we leave it at that. So you create a myomucosal shunt, isn't it?
Yes.
A myomucosal shunt has to be created between the trachea and the remaining pharynx over the remaining arytenoid. So arytenoid and maybe one half of the cord may be there on one side, like in this patient. As you said, that is a very good treatment option for this patient. If you're thinking about surgery, or otherwise, yes, wide field laryngectomy. If you're talking about laryngectomy, total laryngectomy, that is also an option. You cannot say that's not an option. So, can you tell me some basic steps of total laryngectomy?
The Glex-Sorensen incision is made,
very
good. Which will involve the preposterior tracheostome site also.
Okay. Even previous tracheostomy, if you have done.
Yes, ma'am.
Okay. Then.
And flap elevation is done.
Okay.
Flat. Then the muscles are.
Pardon?
The soft tissue dissection, muscles are separated, and the skeletonization is.
Skeletonization, yes. Which muscles?
The strap muscles.
Okay. Strap muscles are separated, or it is the strap muscles are removed, isn't it? Along with the larynx. Huh? So skeletonization, when you're doing skeletonization, which part you're doing? Which bone? I given you the hint. Hyoid, yeah. Hyoid. So supraoid muscles and all have to be separated. Supraoid, yes. But the rest of the strap muscles will go along with the all infraoid muscles will go along with the specimen. Okay, then what do you do?
Devascularization
of the devascularization of the thyroid. Okay.
Superior thyroid and
so the steps, not superior thyroid. If you are preserving the thyroid one lobe, then that blood supply can be preserved. Okay, superior and inferior thyroid arteries. But on the other side, both has to be taken off. So then, in that sense, you can say devascularization of the larynx, not of the trachea and all. Okay, and then you take off the specimen. What is the suture that you use for suturing the pharynx? What sort of suture material do you use for suturing the pharynx?
PDS. So, pharynx.
Yeah, PDS is not a bad option. Anything else routinely used? Yes, Vicryl
we can use.
Yes, Vicryl we can use. Okay, now anything else, Vijay Lakshmi? We are the only two left here with Dr. Vadesh.
Nothing else, ma'am.
Yeah, so how much more time do we have, Dr. Vadesh? Can you tell me how do you rehabilitate the patient after total laryngectomy?
Rehabilitation. We can tracheoesophageal prosthesis can be done.
Okay.
Other options like electrolarynx or
yes, electrolarynx is there. Then what is
voice
the
prosthesis?
I understood. TEP you want to do and the prosthesis you want to insert.
Any other option which we have to train the person? We have to train the person. The person has to swallow the air, and then what is that called?
Esophageal.
Yeah. What is it? Esophageal voice, isn't it?
Yes.
What else is there? Esophageal voice.
Esophageal.
Difference between esophageal voice and tracheoesophageal voice. How is voice different?
The esophageal voice, it is coming from the esophagus, so the quality will be not good as that of tracheoesophageal.
Quality will not be good. Anything else? It is hard to comprehend. Yes. Then what else? There is some main difference between these two. What is the reservoirs of? So
breathy.
Breathy, I'm not saying, but it is how it is per breath, a number of words, or it is per belch number of words in esophageal voice. So how does the patient produce esophageal voice? So these details you should know. Yeah, they have to swallow air, and swallowed air has to come out. So every swallowed, every belch, the patient has to speak. So 50 ml only is the capacity of the esophagus to hold air. So you get around 4 to 5 words per belch. While tracheoesophageal, you're connected to the lungs, isn't it?
Yes.
So 500 ml of air is available. That's the tidal volume. So about 25 to 30 words the patient can speak. In esophageal voice, every 5 to 6 words he has to belch again. So it's interrupted, which is slow, you can't understand so well. So that is the main difference. Okay. So if you get a case like this, that other than reading only about the pre and the the investigation still there, you just read a little bit beyond that also, because sometimes your question will land up there.
Okay.
In fact, you can be asked questions on voice prosthesis itself separately, because those details you have to know.
Okay.
Yeah. Then what else is there? So we have covered radiotherapy, we have covered surgery, all the different aspects. Anything else you want to ask, Vijay Lakshmi?
Ma'am, nothing else, ma'am. Only the rehab part. She'll have to read up in detail. I suppose more in detail.
Yeah, correct. So I think we can we end here, because I think it's already 1 hour, no?
Yes, madam.
Yeah, Dr.
Yes,
Rajesh,
madam.
thank you.
Okay.
So feedback for me is that I think you're answering very well, in the sense whatever you know, if you know well, you're answering well. You are very clear, and you're able to, your thoughts you're able to bring out very clearly. I mean, you have that, you're fluent and articulate. That is an added advantage. And of course, some areas you're not so very sure, and these areas now you know that you have to brush up. That's all. I think I'm very happy with your performance. Dr. Vijay Lakshmi?
Yes, ma'am. you did fairly well, except that you need to, read up a little more in detail. And
Yes, ma'am.
whatever you knew, as Madam said, you answered quite okay. But still, despite all the glitches that you had with the technology, you managed quite well. But when you face examiners, you'll have to answer more confidently. So
Yes, ma'am.
that's,
Okay.
I think, a little more, when you read up a little more, you will be able to do things much better than what you've done today. So good presentation. Yeah.
Okay.
Okay.
Yes, ma'am. Thank you.
So, Dr. Rajeshri, we can leave.
Yes, madam.
Thank you.
Thank
very
you,
much.
Sudha,
Thank you
madam.
very much.
Thank you very much.
What
And
is
I congratulate the entire team from KSHEMA, from past to present to future, who is having the dedication to carry on with this particular type of workshop and conference year on year. It is a great boon. I think the people. I think now people from all over the state are coming forward, isn't it?
Yes,
That's very good.
yes.
Congratulations
Actually,
to you.
yes, we have delegates from Delhi, Chandigarh, Cuttack, and a few other centers also. North India also.
Dr. Vadish,
Even Gujarat,
I was
yes.
the participant of your first workshop way back in 2003, I think.
2004, I think.
I was a participant then.
Yes,
Oh,
2004.
yeah. Oh, that is a special. That is very good. Participant has become. Yes, very good. Very good. Very good, all of you.
So
Dr.
evolution,
Rajeshri,
that
everyone.
shows the evolution of our program.
Yes, yes.
Okay, I think, yes, ma'am. Thank you.
Okay.
Ma'am, actually, Sujay madam, we could not see you because your camera is showing switched on, but somehow we are not able to see
You're
you.
not able to see me?
That's, I was messaging you probably. You could
Oh, okay. Okay, I don't know. It's a new laptop. I think I'm not just not configured it, or I don't know what.
maybe, ma'am.
Because my
that's
video
what.
is on. My video is
Video is
on.
on. Video is on, but probably setup might be.
Okay, okay. I have to do something. Okay, okay. Thank you.
So thank you very much. Thank you very much, ma'am. Sujay
I
madam.
deliberately
Vijayalakshmi
turned my video off to save on the bandwidth because the candidate was having troubles, and I'm also in a place where many people moving around in the background, so that's why. Yeah.
Bye.
Thank you so much. Yeah.
I thank very profuse thanks to Dr. Azim sir, Suja madam, Vijayalakshmi madam, and Arun sir. Arun sir told he'll join again for the next class, and I thank Dr. Nikhila for presenting a case for the benefit of other delegates. So we are planning to start our next presentation at 1:45 p.m. instead of 2 because I think it's more of a virtual lunch break. 1:45. 1:45 should be more of.
Are you sending us lunch,
everyone?
Vadish?
Okay. Virtual lunch break. That is something I've not heard. Yes, okay, Vadish.
So I think, sorry, ma'am. We'll start at 1:45.
Okay.
Thank you very much.
Okay, thank you.
Thank you, Vijayalakshmi. Thank you. Have a nice day.
sir. Right, sir, your audio, I think we can't see. Probably you have to select audio. Tirtha, I am making you co-host so that you can share your slide at 1:45 whenever we start.
This one, okay. Video has to be
Good morning. Good afternoon, Shanbag sir. We can't see your audio. Good afternoon, Maheshwar sir. Good afternoon.
Good afternoon, Dr. Vajish.
I think Shanbag sir's audio is having some issues. Probably he'll join soon.
Yeah, no problem. We'll wait for it. He's the
Yes,
boss.
sir. We'll wait for a few more minutes. Good afternoon, Shanbag sir. Sir, your audio, I think it disappeared again.
What time would you be? Good afternoon, sir.
ನಮಸ್ಕಾರ, ಹೇಗಿದ್ದೀರಾ?
ನಮಸ್ಕಾರ. ಆರಾಮ್.
ಈಗ ನಮ್ದು ಸೆಷನ್ ಇದೆಯಾ ಈಗ?
ಹೌದು ಸರ್.
ಓಕೆ, ರೈನಾಲಜಿ. ಓಕೆ. ಗೋಯಿಂಗ್ ಆನ್, ಆಲ್ ವೆಲ್.
ಅಶೋಕ್ ಸರ್ ಮೀಟ್ ಆಗಿದ್ದೆ ಸರ್ ಮೊನ್ನೆ
ಗೋವಾದಲ್ಲಿ.
ಹೌದು.
ದಟ್ಸ್ ರೈಟ್. ಹೌದು, ಗೋವಾದಲ್ಲಿ. ಕರೆಕ್ಟ್. ನಾವು ಭೇಟಿಯಾಗಿ ಯಾವಾಗ ಪ್ರೀ ಕೋವಿಡ್ ಕಾಣುತ್ತೆ ಅಲ್ಲ?
ಹೌದು.
We met before COVID 3 years ago.
You had a talk, ಅಲ್ಲ sir? You gave a talk.
Yeah. ಈಗ ನೀವು, ನಾನು ಮತ್ತೆ ಇನ್ನೊಬ್ರು ಯಾರು ಇದಾರಲ್ಲ, ಇನ್ನೊಂದು 3 ಜನ ರೈನಾಲಜಿಯಲ್ಲಿ. Case presentation.
Good afternoon, sir. So I was seeing you, but your audio was flickering. So I thought you are some Shanbag sir.
No problem. ಈಗ ಸರಿ ಇದೆಯಲ್ಲ?
Yes, sir. Now is absolutely fine, sir.
Yeah.
So we are all set for the next session on rhinology, sir. Welcome back, the delegates. Now for the rhinology session, we have Dr. Raghunath Shanbag, from Professor of ENT from SDM Medical College, Dharwad. Dr. Mahesh Bhatt, Professor and former head of the Department of ENT, Father Muller Medical College, Mangalore. We also have Dr. Kailesh Pujari, who will be joining in another 5 minutes. He was stuck up in OT and he is just getting ready. And we also have Dr. Somayaji, sir, will be joining in another 5 minutes. Dr. Tirtha from Bangalore Medical College will be presenting the case. Dr. Tirtha, you can start. Raghunath sir, you can take this.
Can you just give us a few tips whether we can ask questions before they finish presenting? Or...
Anything, yes sir, anytime sir. Starting from the first line, you can interrupt. Just like any PG examinations.
Okay, fine.
And we have 1 hour time for the case presentation as well as discussion, sir. And next 15 minutes we can debrief, sir, what went better, what would have done better, and other tips.
Sure.
Thank you, sir.
Yes.
Over to Dr. Tirtha.
Good afternoon, one and all.
Good afternoon.
Respected judges and panel members, today I'm here to present a clinical case on rhinology. Am I audible? Is the slides visible, sir?
Yes, Dr. Tirtha. We are seeing only the title slide. Probably you can go to the next slide.
Okay, sir. Today I'm here to present a case of Praveen Kumar, who is a 17-year-old male patient who is a student by occupation and is residing in Gulbarga, Karnataka. His chief complaints are he complains of bilateral nasal obstruction since 2 months and also complains of bleeding from the nose since 2 months. The history of presenting illness, patient was apparently all right 2 months back. After then, he noticed right-sided nasal obstruction. It was incident in onset, gradually progressive for the duration of 2 months. Initially, he developed
obstruction on the right side, and later on it progressed to the left side, which was since 2 weeks. Nasal obstruction is continuous throughout the day, with right-sided nasal obstruction being complete, while left-side nasal obstruction was partial. There was no diurnal or positional variation noted, with no aggravating or relieving factors. He also gives history of bleeding from the nose, 1 episode of nasal bleed, 2 months back. It was spontaneous in onset, bright red color, and it stained the handkerchief and stopped on applying the pressure. Patient gives, yes, sir.
You went from nasal obstruction to nasal bleeding, right?
Yes, sir.
Did you tell diurnal variations with respect to nasal obstruction?
Yes, sir.
As any relieving or aggravating factors, did you tell,
yes, sir.
What's the duration? 2 months?
Only 2 months, sir.
Okay. Did you tell what was the type of onset? Any predisposing event had happened which started 2 months? And
yes, sir.
15-year-old boy. What must have happened for the nasal obstruction to start 2 months ago? And you said right side it's a complete obstruction, left side it's a partial obstruction. What do you exactly mean by partial obstruction?
He gives it with comparison to the right side, sir. Right side, comparing him to the right side, left side, he is able to breathe a little bit. So history in comparison to the right side, left side was partially obstructed.
Okay, is there any aggravating relieving factor?
No, sir. There was no aggravating or relieving factor for the nasal obstruction.
You should mention it, no?
Yes, sir. I have included that also, sir.
Yeah, okay. Fine. Okay. Go ahead with the nasal bleeding.
Yes, sir.
Patient gives...
yes, sir.
Sorry for the interruption. We have seen your first slide only, the title only till now. Are you changing the slides or?
Yes, sir.
Yeah. Oh, okay. Yeah, this one. Okay, fine.
Okay, sir.
Now I can see.
Okay, sir. Patient gives history of bleeding from the nose. It was 1 episode of bleeding from 1 episode of bleed which occurred 2 months back. It was spontaneous in onset, bright red in color, and it stained the handkerchief and stopped on applying pressure. Patient gives history of nasal twang in voice and mouth breathing and snoring.
Excuse me.
Yes, sir.
May I know the bleeding is from which side? Because you have nose block occurring on one side first and then.
Yes, sir. It was profuse bleeding from both sides, sir. He gives history of bleeding from both sides.
From the beginning. From the beginning.
Sir. From the beginning, from both sides. One happened 2 months back, sir.
Okay.
There was no history of.
No, listen, please.
Okay,
because this is a sort of a practice, we would like to be a little more diligent on this. Go back to your nasal bleeding slide.
Yes, sir.
When doctor asked you, you said it's profuse, right?
Yes, sir.
How do you decide profuse bleeding or less bleeding? How do you decide?
Sir, based on the history what he gives, sir, like he is telling if it is staining the handkerchief or it is just
staining of handkerchief, profuse bleeding.
No, sir. Depending upon the quantity, what he would tell, sir.
How do you decide the quantity? By taking history. How do you decide?
Sir, if the bleeding was only there in the nasal cavity, like when he could appreciate only on if it was noticed by someone else or it was just staining the tip of the nasal cavity, we may tell it is a minimal amount of bleeding. Why? The quantity is so much that he was using 2-3 handkerchief or even more number of cotton pads or something, we can quantify it as a profuse bleeding, sir.
I don't agree with that. Look, what happens with patients is, especially if you're saying staining of handkerchief, it can't be profuse now. It's just staining. Obviously, whatever happens in the nose, they will use a handkerchief. And how many handkerchief, how a person uses, some people may come and say even 1-2 ml of bleeding as, my God, I saw blood coming. It all depends on how the patient tells you. Yes. Secondly, what you noticed is most of the time the shirt will be stained or something like that. Looking at it, they get alarmed, they get scared, and they come and tell you that, oh my God, I have this, right?
Yes,
so you can't really conclude only on the basis of the patient's perception of the bleeding. Haven't you noticed people, some of them are very anxious. They say too much blood, tumba blood hoitu and all that. That should not decide. And especially you're contradicted here because you just said stained handkerchief, stopped on applying pressure. But when sir asked you, said it's profuse.
Yes, sir. That was contradicting, sir.
Yeah, that's very important. You can actually ask whether it is just like a blood mixed mucus, or it was dropping, drop by drop. How much time did it take to stop? What did the pressure? What did the patient do? What time of the day the bleeding happened? Whether he was in the toilet straining at stools, whether he was lifting weight, whether he was running around in the hot sun. A lot of things matter.
Yes, sir.
And your history of nasal bleeding is only one episode, is it?
Yes, sir. Only one episode.
Then how do you put it as the second complaint? It looks like now that he had an episode of nasal bleeding 2 months ago, and then onwards he's having nasal obstruction. Is this correct? I don't know.
First event was nasal obstruction, sir, followed by nasal bleeding, sir.
So you said nasal obstruction 2 months, and you are telling one history of nasal bleeding 2 months.
Yes, sir. I had included in chief complaints because he complained it that also, sir. But only one episode was there, sir. One was first event was nasal obstruction, followed by bleeding, which happened one episode 2 months back, sir.
All right, fine. Go ahead, but we are just trying to tell you how we can make it better.
Yes, sir. Sure, sir.
Okay.
Okay, sir. There is no history of
sorry.
Okay, sir.
We can cut you. Go back to the previous. You said nasal twang. What is nasal twang?
Nasal twang is typical voice change, hypernasality of the voice.
I got you there. I knew you will say this. What is hypernasality of voice?
Sir, so depending upon the how do we sir, there is hyponasal and hypernasal voice, sir.
When is hyponasal voice heard?
Sir, hyponasal voice is when there is any mass in the mass obstructing, when there is any palatal insufficiency or something, which it will cause hypernasality of the voice, sir.
You started telling hyponasal, now hypernasal. Does this patient have hypernasal? You said no.
This patient
does this patient has hypernasal or hyponasal?
This patient had hypernasal, sir.
Hyper.
Yes, sir, hypernasal.
And he has mouth breathing. His nose is long. And he has a hypernasal voice.
He has a nasal mass, no? So what it should be, hyponasal or hyper?
It should be hyponasal, sir. Hyponasal mass. Whenever there is a mass, it will result in hyponasal voice, and palatal insufficiency will result in hypernasality of the voice.
See, sir is asking very particularly about, he's searching for a word there. You know, rhinolalia clausa, rhinolalia.
Yeah, rhinolalia aperta. Yes, sir.
Yeah, that is what sir
is it aperta or clausa?
Examiner.
In this case, it was rhinolalia clausa, sir.
Then is it hyper or hypo?
Hyponasal voice, sir.
Then is it nasal twang or flat voice? See, whenever you present a case, I mean, this is of course learning, you should be very clear, very careful about what words you are using.
Yes, sir.
Shanbog, there is a saying, you know, if you cannot convince, confuse. So that is what she is trying to do.
No, it's all right. But because this is before the exam, these are the points you should learn. So that,
yes, sir. Sure, sir.
Okay, fine. Go ahead. You're doing fine. See, no, don't run. Mouth breathing. What exactly do you mean by mouth breathing? The whole day, night, the person is mouth breathing?
No, sir. He has difficulty in breathing through nose, so he is breathing through mouth.
When? The whole day?
No, sir, at night.
At night. So
More
you
at
should
night.
be specific, right?
Yes,
Why
sir.
a person with subtotal nasal obstruction? He doesn't have total nasal obstruction, correct? There is
Yes,
a
sir.
little bit of breathing from the left nasal cavity, but still, during the day, he is able to breathe through the same nose with partial obstruction on one side and full obstruction on the other. In
Yes,
the night,
sir.
what happens? Why does it become complete and why does he end up becoming a mouth breather? Only in the night.
Sir, in the night, it is when we are sleeping, it is not an active event, it is a passive event, and involuntary respiration.
Is it? When you're breathing at night, it's a different type of breathing, is it?
No, sir, it is okay. I'm not sure about that, sir. Why? What happens that?
Do you mean to say during waking hours we breathe consciously? No, it's involuntary. Right? So
Yes,
what exactly happens when the person lies down? I'm giving you a hint. Okay, I think we'll come back to this. You mentioned, okay, I don't know much about this. We'll get back to that. But
Okay,
let me
sir.
ask one more thing. You said snoring.
Yes, sir.
Now tell me, what is snoring?
Snoring is noisy, noisy breathing, sir.
That's it?
Uh,
Any noisy breathing is snoring?
no, sir. Noisy breathing which occurs at when the patient is asleep.
All right, fine. How is it different from sleep apnea?
In sleep apnea, there is a period of cessation of respiration, sir. Like the patient will sleep.
Respiration. Listen to me. You said cessation of respiration. What's the difference between breathing and respiration?
Sir, respiration and what is the difference between breathing and respiration? Sir.
To the coordinator, Dr. Vadish, is it possible for some other PGs who want to answer? Is it possible for them to contribute? I don't know.
No, sir. Actually, they can type the answer in the chat box in the YouTube, sir.
Okay.
They cannot directly ask. That's what we are periodically checking.
No problem. Just, I hope I'm not sort of, interrogating her too much.
No. Yes, sir.
If the session has to be useful, then this is the method.
Absolutely, sir. Absolutely. Because we are sure that all presenters will take everything positively. That is why they are volunteer.
Otherwise, there's really no point in being very nice to you now.
Absolutely, sir. Exactly.
We like to be nice during the exams.
Yes,
okay, see, Doctor, whoever is presenting, knowing
breathing,
right?
Yes, sir.
It's all right. Yeah, it's all right. You
Yes,
find
sir.
out and you will
Yes,
solve it. Okay, let's go further.
Yes, sir. Hello, sir.
Yeah, please go ahead.
Yes, sir. There is no history of nasal discharge, headache, or protrusion.
I lost her voice.
Discharge and headache. There is no history of, yes, sir.
But we lost your voice for. Can you start with the
Yes, sir.
negative history, sir?
Yeah. There is no history of nasal discharge, headache, protrusion of eye or double vision, and blurring of vision and drooping of eyelid. There is no history of ear or ear pain. Patient also does not give any history of cheek swelling, difficulty in opening the mouth, cheek numbness, or loosening of teeth, and any teeth which is unexplained. There is no history of excessive watering from the eye, and there is no history of necessitation. There is no history of nausea. There is no history of difficulty in swallowing, fever, weight loss, or loss of focal trauma. Moving on to the past history, there is a history of yes, sir. Yes, sir.
See, listen, you mentioned local trauma as the last point. A patient who had nose block for 2 months and he had some bleeding around that time. I would have asked the first thing.
Traumatic history, yes, sir.
Some traumatic history of trauma.
Okay, sir. Okay.
Very apt. Go back to your previous slide.
Yes, sir.
See, what are the types of nasal discharge?
Nasal discharge can be watery nasal discharge, watery or serous, mucoid and mucopurulent. Sir. Watery discharge and serous discharge is seen in infection or in case of CSF CSF rhinorrhea. Mucopurulent discharge is seen in rhinite, any infectious causes.
We lost her voice again.
Hello, sir. Am I audible, sir?
Yeah, listen to me just a moment. To all the PGs who are appearing for exam, what was the question I asked her? What are the types of nasal discharge? What happened? She suddenly started rattling away all the causes and all the types, and she started telling me the causes behind it. I didn't ask you the cause.
Okay, sir.
You have to understand this one simple suggestion. When an examiner asks you a question, understand the question and answer to the point. Do you understand? It is obviously good that you are telling why each type of discharge occurs. But if not asked, there's really no need. You answered that question correctly, which I told. You missed one important type of nasal discharge. You told watery or serous, mucoid and mucopurulent. That's it. What about blood stain?
Blood stain, sir. Yes, sir.
Yeah, you missed it.
Yes, sir.
What is the cause of blood stain discharge if it is there?
Blood stain discharge, if it is pink skin, based on the type of blood stain discharge, it can be due to, if it is rusty pink in color, it may be due to Klebsiella. And if it is pink, red currant pink in color, it may be because of pneumococcus. And also another cause of blood stain discharge is any trauma.
That's it. Blood
Also,
stain.
and also any benign lesions of the nose, like juvenile nasal angiofibroma.
Benign lesions of the nose, like angiofibroma, will lead to blood stain nasal discharge, is it?
It will cause, initially it can cause blood stain discharge, and later on it can cause epistaxis.
See, this is what we call as digging your own grave. Don't pull me into areas which you start shooting with. Anybody, Dr. Mahesh, would you like to throw light on this and teach them a little about this? Dr. Adish, it would be nice if others also talk. I'm feeling like I'm the only person. Hello.
So go ahead, no problem.
Yeah, because see, what I'm just trying to, this is a common thing among PGs when you're giving exam. Don't be in a big hurry to start the answer. Understand the question clearly. If you have not heard the question clearly, ask the examiner again, I didn't hear it properly, whatever that is, okay? Don't rattle away all that you know about this. Honestly, drag the examiner into a place where you will be not confident, okay? Malignancy, maxilla, okay, you didn't at all. Yeah? And you said the
yes,
maxilla and something is, where is this given?
Sir?
Where is this given? Pink blood is Klebsiella and something else you told? Some other color is something else? Some
yes,
other.
Sir.
Where is it given?
Sir, McLeod, I have referred, sir, in McLeod.
Fine, I don't know much about that. Anyway, you said protrusion of eye in a patient, 17-year-old boy with nasal obstruction. Why did you ask protrusion of eye?
Sir, I want to rule out if it is a mass which is impinging or causing a pressure effect on the orbit.
All right, good. Okay, what about headache? Why did you ask headache?
Sir, nasal obstruction and headache, I want to rule out any sinusitis.
What other causes can lead to headache in a patient with nasal obstruction?
DNS, yes, sir, DNS, deviated nasal septum.
What is that type of headache called as?
Sludder's neuralgia.
Yeah, yeah.
Why you are not confident to tell that? What is it? What's the other name?
Sludder's neuralgia or
which nerves? What happens in that neuralgia?
Anterethmoidal nerve, impinging on the anterethmoidal nerve.
Okay. So how do we diagnose it?
Sir, on DNA, if we find a Gross DNS with spur.
That's it. It should be flutters. And if the patient complains of headache, it is flutters. Clinically, how do you prove or disprove? There is a way of doing it. DNA. See, if it is irritating the nerve by impinging on the middle turbinate or somewhere, you anesthetize that area. Do you understand? With
Yes,
the
sir.
with the surface anesthetic.
Yes, sir.
So that should stop the headache. If that really works, then only you can prove that it is Ludus neuralgia and you can do the surgery, remove the impinging area. It's
Yes,
not a very
sir.
commonly seen situation,
Okay, sir.
right?
Yes, sir.
So if a patient has nasal obstruction and headache, it's not just about sinusitis. There are other reasons also.
Yes,
Am I
sir.
right?
Yes, sir.
Yeah. Even a patient of nasal obstruction at night will not have a good sleep. That could be the reason. So it's not that he has headache, so he has sinusitis. No, no way. Okay.
Okay, sir.
Double vision. Why did you ask double vision?
Sir, whenever there is involvement of any mass which is pushing the orbit, it can result in following ophthalmic problems like blurring of vision, double vision.
Okay. Fine. Okay. Drooping of eyelid. Why did you ask?
Sir, mass. Two reasons can be there. It is one is because of the mass effect, and another reason is involvement of the nerve.
Which? Obviously, we'll ask.
Yes, sir. It is because of the involvement of the oculomotor nerve, sir.
Good. Is somebody sitting by your side? Okay. Fine.
No, sir.
It's good. Good. Fine. Why did you ask? See, I have to ask you all this because this is how we can prepare you and find out where are all the faults. Okay?
Yes, sir. Yes, sir.
Cheek swelling, difficulty in opening mouth. Why difficulty in opening mouth?
Sir, it is involving, if the swelling is involving into the infratemporal fossa, it might present as cheek swelling.
Yes.
And also difficulty in opening the any nasopharyngeal mass which is involving into the infratemporal fossa. It can cause cheek swelling, cheek anesthesia, loosening of the teeth, and also difficulty in opening of the mouth.
What about cheek numbness? Why are you asking?
Sir, involvement of infraorbital nerves.
Infraorbital nerve. What is it a branch of? See, these are the lacunae you people have.
Yes, sir.
You're just telling me that this nerve, where is this nerve? Where do you see it during FES?
It is seen near the just above this.
Sorry?
You can give infraorbital block is given near the just above the upper alveolar region.
Why would you ask for a FES? My question is totally different. See, anyway, it's all right.
I'm not sure about that.
This, yes, but learn it, okay? The anatomy of infraorbital nerve. What is it a branch of? Where does it start? From where does it come? Okay? You should know this. Go ahead.
Okay, sir. Okay, sir. Yes, sir.
Yeah. Ergopraline ganglion. Chalo.
Okay, sir. There is no history of excessive watering from the eye.
That's all fine. It's obvious. No history of nasal regurgitation. Why nasal regurgitation?
Sir, if there is any mass which is involving into the intracranial and last cranial nerves affected, it can result in nasal regurgitation. And
my God, is it? So, along with that, what other questions you will ask? Nasal regurgitation. Water? Listen, you are telling me lower cranial nerve palsy. What are the other clinical features of lower cranial nerve palsy?
Excuse me.
Yes,
see, sir just told you don't answer. You have to know it in detail. You could have just told, since there's a mass, it could be the mass effect on the soft palate, isn't it?
Yes, sir.
where the mass won't allow the soft palate to close to the Pavlov's ridge, isn't it?
Yes, sir. Yes, sir.
And hence the nasal regurgitation cannot.
Lower
It's a
cranial
simpler
nerve.
answer.
Which
Okay,
tumor
sir.
will go there from the nose in a 17-year-old boy going? So I'll start asking now about everything about lower cranial nerves and the foramina. You have taken me to my favorite topic. See, doctor, this is what happens in the exam. Most of the time, we wait like hunters. It is you people who come nicely and open up the doors for such discussions which end up in serious trouble for you. So what I'm trying to tell you is before this exam, the final exam that you're going to do, you have to rehearse it and find out which question can be asked if I say this. Isn't it? No, a simple rule is this. Every word you utter, you should have an answer for that. If you say no history of nasal regurgitation, you should know exactly why you are saying it.
Okay, sir.
Next.
There is no history of nausea and vomiting.
Okay. Now I'm also getting bored. Fine.
No history of no history of difficulty in swallowing. No history of fever, weight loss, loss of appetite.
Why difficult in swallowing? I can't stop asking.
Sir, maybe because of the mass effect, sir.
It's looking as if you're like convinced that it's a mass, or you're sort of presumed, prejudiced that it is a mass, and you're asking all the questions accordingly. Okay, go ahead. Did you ask loss of sense of smell?
Yes, sir, I asked that, sir. There is no history of anosmia or any loss of sense of smell.
Okay. What is the word used to say altered sense of smell, which gives a bad sense of smell to the patient all the time? There is a medical word.
Merciful anosmia.
No. You did not even understand my question.
Okay. Yes, sir.
The patient feels a sense of bad smell all the time with no sense, nothing, no garbage is around. But the patient gets that smell.
Parosmia.
That's cachosmia is the correct word. Okay. Parosmia is altered sense of smell.
Yes, sir. Okay, sir.
Of late, we are seeing quite a few patients with this. Which condition?
Post-COVID.
A lot of these patients are coming with cachosmia, parosmia, anosmia, of course, in the beginning. So you should have that. Okay. Suppose, doctor, suppose a patient comes to you saying that there is foul smell felt only on one side nasal cavity. Patient can easily tell, I can feel the foul smell only in one side. What could be the cause?
Patient complaining of foul smell only on one side. It can be due to rhinolith.
Nasal cavity. Sorry, it could be?
Rhinolith.
Okay. What else?
Foreign,
Adult?
Foreign.
Adult. See, listen, okay, I can tell you, if a patient, first thing you should ask is any dental caries, and you should look for any dental caries of the upper teeth in the floor of that side maxilla. Okay, many a times we have seen dental infection going into maxillary sinus gives a typical foul smell. Okay, go ahead. Fine.
Past history, there is no history of tuberculosis, asthma, diabetes mellitus, or hypertension. There is no history of bleeding manifestation, or there is no history of any past surgeries.
Okay.
Personal history, he has a mixed diet with appetite good, regular bladder, sleep was disturbed. He is a non-smoker and non-alcoholic. History, there is no history of similar complaints in the family, and there is no history of bleeding disorders in the family. Physical examination, patient is cooperative, well oriented to time, place, and he is moderately built and nourished. There is no pallor, icterus, clubbing, or cyanosis, and lymphadenopathy. There is his pulse rate was around 88 beats per minute with normal rate, rhythm, and volume. Excuse me, sir. His BP was 120 by 74 millimeters of mercury with respiratory rate of around 14 cycles per minute, and he was afebrile. Systemic examination on cardiovascular system, S1, S2 was heard. There was no murmurs. On examining the respiratory system, it was normal vesicular breath sound with no added sound. On examining the periabdomen, it was soft and non-tender with no organomegaly. There was no clinically no abnormality detected on cranial nerve system examination.
Okay.
Examination of the nose, external nose, root tip dorsum appears normal. On tip raise sign, we did the tip raise and examined the vestibule. It was normal. On anti-rhinoscopy, there was a DNS to left with spur towards the left. Lateral wall, we found a bright reddish mass with a smooth surface, which was covered by mucoid discharge, which is arising from the middle meatus, extending up to the inferior turbinate. The floor was covered with mucoid secretion and roof appeared normal.
It's a simple thing. You said in that nasal cavity, you saw a reddish mass covered with, it should have been opposite way, mucoid discharge covering mass first. And then after you cleared the discharge, then you saw it as red.
Reddish.
Understood?
Yes, sir.
Okay.
Yes, sir.
Is your examination of the nose, anti-rhinoscopy over?
On left side, the findings were normal, sir. Yes, sir.
You said roof appears normal. Can you really see the roof of nasal?
Hello.
Yes, sir.
Hello.
Hello, sir. Am I audible, sir? Yes, sir. I can hear you, sir.
Can you?
No, question is,
how can
roof
you
appears normal. Is it normally seen on anterior rhinoscopy? Forget about normal, abnormal, whatever. Is it seen?
Hello, sir.
Did you hear me?
Yes, sir. I heard you, sir.
Is the roof seen on anterior rhinoscopy? I presume the point number 3 is floor, not 4.
Yes, sir. Floor, sir.
So roof is seen?
Yes, sir. A part of the roof can be seen, sir.
Okay, normally.
Yes, sir.
Okay, which part of the roof? Not with endoscopy, yeah? It is with tudicum speculum.
Yes, sir. Just the anterior part of only can be seen.
Anterior part of the roof can be seen.
Yes, sir.
Okay.
You mentioned this medial to middle meatus.
Yes, sir.
What do you mean by that?
Sorry, sir. I didn't get you, sir.
Can you describe that? What do you mean by this medial to middle meatus?
So the mass was arising from the middle meatus. In relation to middle meatus, it was arising medial to it, sir.
That is.
Sir, I have.
Is it to medial to the middle turbinate?
Yes, sir. Medial to middle turbinate, sir.
Where is it?
Medial or lateral?
Sir, I have the DNA images I have added.
No,
sir.
no. DNA is different. Anterior rhinoscopy is different.
Okay, sir. Sir, it was.
Doctor,
it was arrived. Yes, sir.
how did you make out that the mass is arising from wherever you are telling now? How did you make out?
Sir, on probing.
What structure? Were you able to see the middle turbinate?
Yes, sir. I was able to see the middle turbinate.
Now, in relationship with middle turbinate, where was this mass?
On relation to middle turbinate, it was medial to middle turbinate, sir.
You made a gross mistake in writing, madam. You should be careful.
Yes, sir.
And you are writing it is extending up to inferior turbinate means what? Superior inferiorly, or it is up to the roof of the inferior turbinate. Anteroposteriorly, what is the extent? Nothing is told. And you are telling probing, but you are not mentioned anything about probing. You are telling about probing only after our asking.
Yes, sir. I should have mentioned that, sir. I'll add it, sir.
In this entire case, this is the most important part.
Yes, sir.
And at postgraduate level, You cannot just write a few sentences and the roof appears normal is a gross mistake, madam.
Okay, sir.
Probably an undergraduate also will not make that mistake.
It's a well-known fact that you should not mention roof appears normal. In which condition the roof is seen, we always ask. Atrophic rhinitis.
Yes, sir.
Otherwise, do you really see a roof? Especially you are writing both sides, roof is seen normal. It's all a bit difficult to understand.
Okay,
This
sir.
kind of major mistake, you should be careful. And you're telling bright red mass with an episode of bleeding, and you're also telling probing in a 17-year-old boy. It's all a little, gets you into muddy waters, I can say.
Okay, sir. I'll make the changes, sir.
Yeah, I want other examiners also to please comment on this part so that we learn.
No, I just want to know whether she really did the probing. She said that, is it?
We asked her how did you make out from where it came? She said, I did probing. So that again became more of a...
See, basically these mistakes, see, as Dr. Shanbog said, one mistake leads to next and that leads to another 4 mistakes. That is the problem. See, whenever you mention the color as bright red, there is no question of touching.
I wanted to just test you and you fell to the trap. Everything is like black usually. You should be very, very careful.
And it's a basic thing that, anterior rhinoscopy, you cannot even be writing that roof word at all.
You should be very careful, doctor, about these basics. It can become a major blunder. Some things are you cannot say tuning fork test. If you make a mistake, there is no pardon. Okay.
Yes, sir.
You should realize this. Everything is basics. Please don't make any mistakes as far as basics are concerned.
Okay, sir.
Okay. Other examiners also to please contribute here so that the students learn.
Yeah, again in posterior rhinoscopy, I really don't understand this posterior rhinoscopy. A reddish mass seen in the coin obscuring the view of other structures. Whereas you have told there is complete obstruction on one side and partial obstruction in the other.
Patient was giving complaint.
Elaborate on that. Posterior rhinoscopy, could you see the eustachian tube opening, torus tuberous?
No, sir. All structures were not visible, sir.
So could you see the quena? If you are saying
there's a difference between obscuring the view of other structures, or you're saying other structures were not visible. Two different things.
Okay, sir.
And if you see coina, how can it obstruct all other structures?
Yeah.
So coina, the mass which was. Yes, sir.
You're telling me that the entire nasopharynx is filled in your posterior rhinoscopy because you have not mentioned eustachian tube opening.
Yes, sir. Eustachian tube opening was not visible, sir.
You're saying this reddish mass was in the nasopharynx?
This is since 2 months, both the sides.
Yes, sir.
It's okay if the patient says he can partial and you see like this, but doctor, when you say it, the mass is in the coina, it is your presumption, doctor.
Okay.
What you see is a mass in the nasopharynx. Whatever it is, yes or no, I don't know. I have not seen the patient. But whenever you make a statement, we can easily make out if there is a mistake in the statement.
Okay, sir.
If the mass has to obscure other structures, obviously it has to descend into the nasopharynx, no?
Yes, sir.
So you should be careful, ma. Okay, let me ask you, how do you do posterior rhinoscopy?
We use St. Clair Thompson's posterior rhinoscope mirror. First, we explain the procedure to the patient, and using Lux tongue depressor, using tongue depressor,
What's the name of the tongue depressor?
So, Lux tongue.
The forceps lax.
Lax tongue depressor. Yes, sir. Lax tongue depressor.
Go ahead.
Using lax tongue depressor, we push the tongue down and we insert the posterior rhinoscopy mirror and
that's it.
We try to structures.
What do you do to the mirror before you go in?
To prevent the fogging of the mirror, we can either use a Savlon or we can also rub it near the buccal mucosa, cheek mucosa.
You can either heat up the mirror or you dip it in anti-fog solution. You depress the anterior part of the tongue, anterior to the tongue, and you ask the patient to breathe through the.
What? This is sir is telling the whole answer almost. He's asking you to fill the blank. What instruction do you give to the patient, Ma?
We'll ask the patient to breathe through the nose.
Breathe through the nose with the mouth to be open. Okay. Why you tell that?
So that there are any fogging of the mirror.
No, the answer is wrong. Why do you tell the patient to breathe through the nose with the mouth being open when you are doing otorhinolaryngoscopy? It is.
What happens when he breathes through the mouth? Will you be able to see the nasopharynx?
No, sir. We won't be able to see the nasopharynx.
Why? What happens to soft palate? We are
soft palate. Yes, sir. Soft palate will be pushed upwards. When
the patient has to breathe through the mouth, so it will block the nasopharynx. You can't see anything.
Yes,
so when you tell the patient to breathe through the nose, soft palate falls antero-inferiorly. It opens up the nasopharynx. You can see the nasopharynx. That's the correct answer.
Yes, sir.
How do you identify Sinclair-Thompson's PRS mirror?
Sinclair-Thompson's, it have a bend, sir.
Bayonet shaped. Correct.
They don't say it as bend.
Yes,
it is angulated. Okay.
Angulated, sir. Okay, sir.
Okay, fine. Go ahead.
Yeah, and another one, when you're telling about the posterior rhinoscopy, what you missed is you have to hold it in a pen holding fashion and go behind the uvula.
Yes, sir.
Correct. Very nice.
Okay,
Yeah.
Right?
Okay, sir. Yes, sir. Here is the DNA image of the mass.
Can you go back? Yeah. If you look at this, where is the mass in relationship to the middle turbinate and inferior turbinate and the floor?
Why have you put the slide like this in a very artistic manner?
To confuse us?
I don't understand. One square is like twisted. I understand in the exam this will not happen, but don't do it anywhere. You know, just keep it simple, please.
Okay, sir. Okay, sir.
These answer sir's question. Where don't jump, we will not leave you. Don't jump. Now tell me, explain the right nasal cavity. What you are seeing in the DNA itself. You tell what you are seeing.
What we are seeing here is the septum, sir. This is the inferior turbinate,
okay.
and this is the mass which is there in the.
Hey, don't change the slide now. Just explain.
Okay, sir.
Where is the mass?
This is the mass, sir.
Okay. Now explain
Now explain finding what you are told. That is what sir is asking.
Sir, the mass medial to middle turbinate extending up to the inferior turbinate, sir.
What is medial to
middle turbinate? Medial?
What is medial? Is it towards the septum or towards the lateral wall?
It is medial to middle turbinate is towards the septum, sir.
Yeah.
See,
So
the pointer is the pointing at what structure now? That is, what is that structure?
Middle turbinate, sir.
Middle turbinate. Now show me where is the mass?
This is the mass, sir.
Well, now which is medial, which is lateral?
This is medial, this is lateral, sir.
Now where is the mass actually, medial to middle turbinate or lateral?
It is lateral to middle turbinate, sir.
And you said you did probing also there, Baba?
No, sir. I I didn't do probing as such. I
you're
just
not-
cleared the mucoid.
Right, come on. See, if you say, at least you should have kept quiet and said sorry. Now you're telling I did. Never contradict yourself. If you're not done, just say.
Okay, sir.
Hey, please be careful about all these things.
Okay.
First of all, doing probing in
Okay,
that
sir.
case was not justified things to do, especially with anti-rhinoscopy. What can you do probing so posteriorly? Fleshy mass, a 17-year-old boy. Okay. Go ahead. Left side, you explain.
See, even in the diagnostic endoscopy, you cannot actually say that it is arising even from the middle meatus. The mass is usually seen more inferiorly, hugging onto the inferior turbinate.
Okay, sir.
Right?
Yes,
yeah,
sir.
probably coming from the middle meatus, that is not depicted very correctly in this, right?
Yes, sir.
Yeah, definitely it's not medial to middle turbinate.
Okay, sir.
Right? What you see medial and inferior to the middle turbinate is probably the mucoid discharge or mucopurulent discharge, what you had mentioned.
Okay, sir.
Right? Okay.
Yes, sir.
And what you could have told extra also is probably the middle turbinate is pneumatized. It could be a concabulosa.
Okay, sir.
Could be. I'm not very sure, but it does look like a concabulosa.
Sure, sir.
And the other thing you had mentioned about, after the inferior turbinate, it is going
Yes,
beyond
sir.
the, almost reaching the floor. Look at this image. Posteriorly. So your description should have been a little more. Yeah. Okay.
Okay, sir.
And did you mention about the discharge between the septum and the mass?
Yes, sir. Described that there was a mass which was covered with mucoid discharge.
No, it is not covered. No, it is actually, I mean, at least in the first picture, it is between the septum and the mass.
Yes, sir.
Yeah, fine.
Due to the functional examination of the nose, smell is reduced on the right side while it is normal on the left side. Whole spatula test, fogging is absent on the right side and there is reduced fogging in the left side.
Again, once just hold on. The smell reduced on the right side. How did you test?
Sir, we have clinically we have tested using coffee bean and soap. And we have asked the patient if he is able to both side if it is equal or if it is reduced in one side.
Okay, so you just held a coffee powder in front of the patient's nostril, ask him to smell it. That's what you did?
We have used two things, sir. One is a soap bar and we have also used a coffee bean, sir.
Soap bar did you use? When you test a sense of smell, what are you supposed to use?
We are not supposed to use very pungent things, sir.
Anything else?
Often we use.
Anything else? Anything else you're supposed to use or not use? It should be very
We use
common
coffee
smell.
bean and
No, it's very common smells which are recognizable otherwise by the patient. Yeah.
Yes,
Can't use soap bar is a very anyway. Okay, please go ahead.
Hello. Doctor, continue.
Reduce fogging in the left side. Cotton wool test, there is no. Yes, sir. Cotton wool test, there is no movement on the right side while it is reduced on the left side. Hello, sir. Am I audible?
Yes, sir.
Yes. Cotton's test is negative on both sides.
What is Cotton's test?
Cotton's test is we apply pressure on the cheek. We retract the cheek laterally.
Okay.
And in patients with nasal obstruction at the level of internal nasal wall, if there is
excuse me. See, Cotton's test is done when? In your particular case, when you have already examined and you're telling me that the entire nasal cavity is blocked. Is there any sense in doing Cottrell's test? Because he cannot breathe, he cannot appreciate.
Yes, sir.
Doctor, basically what we are trying to ask you both of us together is, what is the principle of Cottrell's test? What is the use of Cottrell's
When
test?
there is obstruction at the level of internal nasal wall, at that time we use, there will be improvement on Cottrell's test, sir.
What? How do you do Cottrell's test?
We apply pressure on the
You said
cheek
something else, not
and ask
pressure.
the
You said
patient if there is a,
You apply
we
pressure on
retract
the
the cheek laterally
Right, yeah.
and so we retract the cheek laterally, sir.
You should use the correct words, ma.
Ask the patient if there is any improvement in nasal obstruction. Whenever
You know what modified Cottrell's test is?
nasal wall, the patient will reduce. Hello, sir.
Okay.
No, I'll ask you what is modified Cottrell's test. Modified Cottrell's test.
Sir, may I continue, sir?
No, sir.
Modified in modified Cottrell's
Dr. Kailash is asking. Yes.
Okay, sir.
Yeah, Dr. Kailash sir asked what is modified Cottrell's test. I think there was
In modified Cottrell's test, we use a Jobson and probe with and there is applied in modified Cottrell's test. We use a Jobson and probe, which is and we apply, instead of applying pressure by using tongue, we retract using that Jobson and probe, sir.
Right, you lift it up. You lift what?
We try to lift the lateral nasal.
There are two aspects of it. Modified has two aspects in it.
I'm not sure about that, sir.
You go and read up.
Yes, sir.
Go ahead.
On examination of paranasal sinus, it appears paranasal sinus is non-tender. Examination of the eye, the size of.
Wait.
Yes,
For
sir.
a PT exam, you are telling PNS examination non-tender. What does it mean? Huh? What are the sinuses you examine?
Frontal sinus, maxillary sinus, ethmoid sinus.
Correct.
Yes, sir.
How do you test for tenderness of maxillary sinus?
By pressing on the canine fossa. We apply pressure on the canine fossa and look at the patient's facial expression.
Okay. What are the boundaries of canine fossa?
Canine fossa is bounded anteriorly by alveolar ridge.
Anteriorly.
Anteriorly. I'll read up, sir. I'll read up.
You read up. Okay. Next.
Examine the eye, the size, aperture, and the ocular movements, vision, and infraorbital margin appears normal bilaterally. Examination of the face, cheek appears normal. Sensation of the face is intact. Cranial nerve examination is normal. Examination of oral cavity and oropharynx appears normal. Indirect laryngoscope, ideal examination.
Did you check for proptosis?
Yes, sir. I'll check for proptosis.
How did you check?
If there is any visible, by comparing with the opposite eye, if there is any visible bulging of eye, I'll see.
I look from front, above, to side.
Side view.
No.
I do on laterally, we'll examine if there is any visible bulging of the eye.
Laterally?
No.
I think so, sir wants to know where will you stand while examining for proptosis.
Correct.
I'll stand on the.
Just make sure they're getting zero billing, okay? Make sure they're.
I'll stand and I'll stand on the side of the patient, sir, on right side of the patient, and make the patient face the wall and examine.
Usually don't do that. It's not that is only if you're using an thermometer. If you're actually checking clinically, stand behind.
Okay, sir.
And then you should read up on who to examine for proptosis.
Okay, sir.
Because a patient with a nasal mask like this should examine for proptosis also.
Okay, sir.
If the eye
Silent
bulge
nasal
is
tumor.
in front of the ridge, then it is positive. Okay.
Okay, sir.
Yeah, that means there is proptosis.
For the ear examination, right ear preauricular region, pinna postauricular region is normal. External auditory canal is normal. Tympanic membrane is also intact. Left side, preauricular region, pinna postauricular region appears normal. External auditory canal is normal, and tympanic.
Again to counter your findings in post-nasal examination, if your mass was there in the nasopharynx, obscuring all the structures, you think your tympanic membrane will be intact?
No, sir. I would expect a dull and retracted tympanic membrane, but in this patient, it was not intact, sir.
So which one is correct? Your finding in posterior rhinoscopy or your tympanic membrane finding? Hello?
Yes, sir. I can hear you, sir.
Yeah. Which do you think is correct? Your tympanic membrane finding or your posterior rhinoscopy finding?
Posterior rhinoscopy is correct.
Is correct. Then how come the tympanic membrane is intact in spite of its obscuring? There's something called as mechanical obstruction of the eustachian tube, isn't it?
Yes,
like
sir.
in adenoids.
Yes, sir.
Mechanical obstruction can give rise to secretory otitis media or a retracted grade 1 tympanic membrane, eustachian tube catarrh.
Yes, sir.
Yes. So always, as sir told, you should be simple and straight while examining. What you see, you write. What you don't see, and don't write it and don't assume things.
Okay, sir. Okay,
simple.
Sir.
Keep it
Okay,
very
sir.
simple. Like sir said, if you have not done palpation, say you have not palpated. Why, they will ask. You can obviously say, sir, it was looking very reddish mass. It could bleed on the table. Fair. All the examiners, I think so, will agree to it. Am I correct, sir?
Yes, yes, of course.
Yeah.
Mahesh, 100% correct.
Yeah.
Okay, sir.
Okay, go ahead. Go ahead.
So coming to the diagnosis, it's a right nasal mass, which could probably be juvenile nasal pharyngeal angiofibroma.
Doctor,
Yes,
what
sir.
about
Hello, sir.
what about neck examination?
Neck examination, I have not done, sir.
How can you?
Yes, sir.
And why you said suddenly probably JNA?
Sir, it is a very young male with a mass and history of epistaxis. So it's more so probable diagnosis could be juvenile nasopharyngeal angiofibroma.
Any other mass can come there?
Yes, sir. Other masses which can be seen in nasopharynx, it can be adenoid.
Ask you any mass seen in nasopharynx, any differential diagnosis, this patient, this mass.
It can be, can also be an antrocoinal polyp.
Okay.
When you see a reddish endocrine polyp.
Yes, sir.
Sir asked you.
Sir.
In what condition you will get reddishness of a polyp?
When it is infected, sir.
Yeah, you can always tell like that.
Yes, sir.
Instead of saying yes, a polyp, you can tell infected, inflamed. Any other benign tumor is there? Which can
Fibroma.
Fibroma. Okay. Anything else?
No, sir.
Okay. Give me all the unilateral nasal masses that you know.
Unilateral nasal masses, antrocoinal polyp.
You can wait. You can classify it right from congenital.
Yes, sir. Unilateral nasal polyp can be congenital, inflammatory, or swelling. Congenital causes can be of any thorn wall cyst. Then inflammatory causes like
Anything else you'll get from the roof of nasal cavity coming down? Huh? Sorry?
Adenoid.
No, nasal cavity, not nasopharynx.
Hormones is where we get
In roof of the nasopharynx.
We are asking nasal mass.
Okay, sir. Congenital nasal masses like hemangiomas.
Suppose you see a small baby
Yes,
with
sir.
a polyp in the nose.
Okay, sir.
Hardly an infant.
Okay.
Could this be a dangerous situation? We are trying to give you a hint. Can something from the brain descend
Yes,
into
sir.
the cavity congenitally?
Yes, sir.
What? You said yes, sir. What are the two
You had a
things in
Furstenberg's.
cranial cavity? Meninges and
Meningocele. It can be a meningocele, sir.
Or meningoencephalocele. What's the
Cele.
difference between meningocele and
Yes, sir.
meningoencephalocele?
When only the coverings are duramat, when only the three layers of meninges are herniating, it is called as meningocele. Where along with the 3 layers of meningeal layers, if there is brain matter also is herniating, it is called as meningoencephalocele.
Sir was asking you congenital.
Yes, sir.
Go ahead.
Then,
okay, this is your probable diagnosis. Huh?
yes, sir. Yes, sir.
How will you proceed?
Sir, I would like to confirm my diagnosis by doing a radiological scan.
Radiological scan. What is that meaning of that word?
I would like to do a radiological investigation in this situation, which is apt as
Okay, doctor, you can use the word imaging.
imaging studies, sir.
Exactly will you write in that form? Which investigation are you getting it done?
Sir, I would like to do a contrast enhanced. MRI is more accurate, sir, but I would like to do a CCT. Contrast.
This is exactly what we don't want you people to do.
Okay.
See, did I ask you? I asked you only one thing. What will you get it done? Contrast enhanced CT is the commonest thing done and the correct answer.
Yes, sir.
MRI more. Who asked you?
Okay, sir. I would like to do a CCT, sir.
Avenues for us to. Yeah. Okay.
Yes, sir.
So you will do a contrast enhanced CT scan.
Yes, sir.
Okay.
Of nose and.
What are the preparations to be done if you have to get a contrast enhanced CT scan?
Sir, I'll ask the patient. Renal parameters should be normal, sir. So after sending RFP.
What's the contrast material used?
Contrast material used is sir,
Things on the tip of your tongue, you can't just go on thinking.
Yes, sir.
Okay, fine.
Yes, sir.
Okay, further.
Sir, if I would like to see the extent of the tumor, where it is, where and all it is involving, sir.
What are the classical radiological signs of JNA?
Allman-Miller sign, which is anterior bending of the posterior wall of maxillary sinus. Sir. Then on contrast enhanced angiography, we can find tumor blush and also absence of venous filling.
Anything to do with sphenopalatine foramen?
Sir, in yes, sir, there is a particular sign called as Ram-Haran sign, which is seen.
What happens here to Ram and Haran? You forget the Ram and Haran. You tell what happens, that's important.
It is the site where there is most commonly residual happens, sir. So,
Arre Bapre, I am just asking you classical radiological science upon JNA. Where are you taking us?
What happens to the phenosylvanian foramen because of the JNA?
So there will be widening of the sphenopalatine.
You don't have to go and elaborate on other things.
Okay,
Be very
sir.
simple in your answer.
Okay, sir.
Stick to the points. Completely different. Ramharan is completely different. Okay, then see, if you take me to Ramharan, I'll take you to chopsticks. No, it's all right. Leave it.
Okay,
This is what we're trying to tell in this session. The bottom line will be this.
Yes, sir.
Stick to basics. Don't jump. Okay, next.
Okay, sir.
Contrast enhanced CT scan.
Yes, sir.
Okay. Do you do bone window or soft tissue window?
I'll do soft tissue window, sir.
You don't want bone window?
Yes, sir. I want both bone window and soft tissue window.
Just now you said soft tissue. Why do you want bone window?
To see the erosion, if there is a erosion of the where and all it is extending with, if there is bone erosion.
It's a bony anatomy. In any case, when you're operating, you should see the bony anatomy. Contrast enhancement, soft tissue windows, you will see the heterogeneous enhancement, you will see bleeding, you will see all the other, the vasculature.
Yes, sir.
In a unilateral nasal mass, I'm not talking only about JNA, in a unilateral nasal mass, if it doesn't look like JNA, will you go ahead and do a biopsy? Fifth, I'll tell you, 30-year-old female has come. If this is a 30-year-old female, will you do a biopsy before doing the imaging?
No, sir.
Why?
Sir, nasal mass. Sir, in this case, pertaining to this case, there's a reddish mass, so it could be highly vascular. So I would avoid biopsy because it can bleed profusely.
Okay, if it is looking like a cyst, translucent,
even though still I'll not do biopsy, sir, because without imaging, we don't know the extent. What would be the content also, we don't know.
Can you be more specific? The two answers you gave, extent and content.
Yes, sir.
Which content are you worried about?
I'm worried about the meningocele and brain conditions.
Exactly. Any unilateral nasal mass, you should do a contrast enhanced CT and you also have the bone windows for two reasons. One is the vascularity, second is the intracranial.
Extension.
So if there is something like this, that is why you should not touch any of the nasal masses before doing the imaging.
Yes, sir.
All right. Now
Yes,
you are done with imaging. How do you classify the JNA based on imaging?
We have 4 classifications, sir. Fish, Chandler's, and Sessions and Radowski's. Based on the fish classification, it is divided into 4 categories, sir. One is limited to nasopharynx with bone restriction limited to sphenopalatine. While fish category 2, tumor invading the pterygomaxillary fissure or maxilla with ethmoid and sphenoid and bone destruction. Fish category 3 is further classified as 3A and 3B. 3A is tumor invading the infratemporal fossa without intracranial extension, while 3B is with intracranial extension, which is extradural. While fish category 4 is intracranial and intradural. 4 can be further classified as 4A and.
You guys are very good at these things. I know. Magap and part you will tell. Okay, let's go ahead. You have done this easily. Further,
yes,
how will you manage the patient?
If CCT, and we'll plan this question for surgery. Depending upon the, in this case, CT findings is confined only to the nasal cavity. So we had planned him and worked him up for endoscopic excision of this mass via dengue.
Doctor, in the exam, never tell. We had planned this patient, CT came like this. No, you are supposed to discuss the case as it is an exam case.
Okay, sir.
Okay? Never, even if you know what happened to the patient, you are never going to say that.
Okay, sir.
That's not how it is done.
Okay, sir.
Okay. Please, in the exam, don't tell this. Some examiner may get offended and they may sort of, don't do that. Just tell your plan. In fact, many times I feel knowing the case is a disadvantage to the candidates. I want other examiners also to comment on this. unnecessarily you are prejudiced and you keep talking only in one direction. You should be very open-minded and stick to the basics. Yes, you said it looks like JNA, you've done the CECT, you've done your classification, so now you plan the surgery. No, the moment you decide you are going to do the surgery, what are the first few steps you take?
Sir, first of all, I'll work up the patient for surgery. I'll send all routine investigation. I have to
What
see.
exactly are there?
Sir, CBC and complete blood count. I would check hemoglobin, pre-operative hemoglobin level of the patient. And I'll arrange and reserve blood adequately because I'm expecting a blood loss.
What exactly do you mean by adequately?
Sir, based on the amount of the hemoglobin level.
Oh, based on the amount of hemoglobin level, you will reserve blood, is it?
Yes.
If he is 16, he can bleed up to 10, huh?
No, sir, not like. I'll keep.
How many pints of blood would you reserve for a patient when you are operating for angiofibroma?
Sir, it will bleed profusely, sir.
Is it?
Yeah. So what do you expect to do?
We can do pre-operatively embolization, sir.
Yes. How do you do that?
Pre-operative embolization using when we are doing scan, that time only we can do pre-op embolization, sir.
What scan you're planning now? What scan is this? Yeah, earlier also you mentioned in CT scan, your CECT you mentioned a tumor blush.
Yes,
When
sir.
you
We'll
describe
do
this
digital subtraction angiography, DSA, and we'll find out which is the tumor. Tumor is feeding vessel to the tumor, and then based on that we'll embolize them.
feeding vessels from the external carotid artery system, be specific, right?
Yes,
The
sir.
canal
Feeding
is
from external carotid.
Yeah. Any other way of reducing the blood loss and reducing size of tumor perioperatively? Any medication has been described?
Hormonal therapy, sir. This tumor is known to be hormone sensitive.
Which hormone is this? What is
So we
it?
use, and we can also give flutamide, which is an anti-androgen.
Okay.
It can help in reducing the bulk of the tumor.
You don't have provision for angiography. Intraoperatively, when there's bleeding, how can you reduce it temporarily?
Intraoperatively, we can hypotensive anesthesia. We can.
No, it's a profuse bleeding. Can you sort of, by doing certain steps surgically, you can reduce the bleeding from the external carotid?
Yes, sir. Head and derivation.
Surgical procedures referring to.
You can
ligation of the we can do ligation, we can do coiling, or preoperatively we can find coil the.
We're talking about intraoperatively.
Intraoperatively we can do the endovascular coiling of the feeding vessel.
External, see, angiography bhi nahi hai. You can't do endovascular coiling. We are simply asking you external carotid artery clamp or ligation will reduce.
Yes, sir.
You should not get the impression that everything happens only because of coiling and embolization and all that. Okay. Anyway, what are all the methods, surgical approaches to angiofibroma?
Surgical approaches to angiofibroma, it can be transpalatal and lateral rhinotomy, transpalatal and sublabial approach, transpalatal and transzygomatic approach. Also combining all three, that is transpalatal, transzygomatic, and sublabial. Then there are few approaches like midfacial degloving, transmaxillary, lateral rhinotomy approach, and transnasal approach.
All right, fine. What exactly is the feeder to angiofibroma?
Most common feeder is internal maxillary artery, sir.
It's a branch of?
External carotid artery.
Okay, what are the branches of internal maxillary artery?
Branches of internal maxillary artery. Internal maxillary artery at different. Read up, sir. I'll read up.
It's okay. You read up. See, you should know the anatomy of sphenopalatine, ergopalatine fossa. Can you tell me something about pterygopalatine fossa structures?
Pterygopalatine fossa is mounted.
Other examiners also please ask questions. And then later you will say, Shambhag pura tane kelta kurtane.
ಇಲ್ಲ ಸರ್ ಕೈಲೇಶ್ ಸರ್ ಇದಾರೆ ಬಾಲಸ್ ಸರ್ ಇದಾರೆ ಸರ್ ಮಹೇಶ್ ಭಟ್ ಸರ್
I'm continuously asking questions, otherwise I'll go to sleep.
No sir, it is wonderful going on. Mahesh Bhatt sir has to go for some emergency. He left. Kailesh sir and Balas sir is there. But so much sir is there.
More questions. He is very reserved. Doctor?
Continue.
Tell us the anatomy of pterygopalatine fossa.
Voice is cut.
You're not audible. Yeah.
Hello, sir. Am I audible now?
Now audible. Now audible. Yes.
Pterygopalatine fossa is boundaries are anteriorly. It is by the posterior wall of maxillary sinus. Yes. Inferiorly, it is continuous with infratemporal fossa.
Okay.
So, roof is formed by the part of greater wing of sphenoid.
Are you reading from somewhere?
No,
if
sir.
Then you better read up later, yeah. Don't do
No,
all
sir.
this.
No, sir. I am telling my.
Okay. Tell me the contents of pterygopalatine fossa.
Pterygopalatine fossa contain pterygopalatine ganglion. But then.
She's not audible. It's okay. I think Dr. Vadish,
Hello, sir.
Yes.
Are we losing time?
Yes, sir. We can have 10 more minutes, sir.
Okay.
Last total. Yes, sir.
But also, sir.
Yes.
Hello, sir. Can you hear me?
Yeah.
Go ahead.
Pterygopalatine fossa. Yes, pterygopalatine fossa contain pterygopalatine ganglion, maxillary artery, third branch, terminal third part of maxillary artery, and also maxillary nerves.
Maxillary nerve. Okay. Which comes first when you open the pterygopalatine fossa anteriorly?
Artery comes first.
Okay. You didn't mention the fat, the structures. Maxillary nerve means which nerve?
So, second division of trigeminal nerve.
V2. Okay.
Yes, sir.
So, how does it enter the pterygopalatine fossa? From where?
It is it enter the pterygopalatine fossa with greater petrosal nerve.
Which
No, sir. Through the foramen of rotundum.
Foramen rotundum. Okay.
Yes, sir.
So if you know all these things,
Okay, sir.
Because see, finally we'll ask these questions. There's no question about it. Okay, fine. JNA. That is one thing. The theoretical aspect we will not ask. Okay. Okay. Let's go to other nasal masses. Inverted papilloma. What is the treatment of inverted papilloma?
Treatment of inverted papilloma is excision and radiotherapy.
Oh my God.
Madam, it's a benign lesion, no tumor. Unless, of course, it is associated with what? What is uniqueness of inverted papilloma? What excision? What do you mean by excision?
So it is complete debulking of the inverted.
What is it?
Yes, sir. So depending upon the extent of inverted papilloma, we decide the treatment.
Okay, what is the typical maxillectomy which is done most often?
He gave you the answer.
What are the types of maxillectomy you know? You can hear us?
Hello?
Hello?
The student?
We can't hear you.
You can't hear me?
No, Dr. Vadish, we are not able to hear the students speaking.
I think disconnected. Oh yeah, sorry.
It's all right. No, it's okay. These things happen. Can we sort of conclude now?
I think, sir. Yes, sir.
Yeah.
Because it is nearly 75 minutes.
Because finally the message has to go. I request Dr. Kailesh to please speak.
Yes, sir.
Yeah, I think there are a lot of corrections in our presentation. The way she has presented is not including findings. One is what she saw and what she described are quite different. Yeah, especially when the relationship of the tumor to the structures in the lateral wall. Right. We should brush up on this one. Her theoretical knowledge probably is okay in angiofibroma, but her examination finding and history she has to improve quite a bit.
Yeah. Dr. Somayaji. I think mic is switched off. I just want to say, not only with particular to this student or generally, what we notice is this one, don't go beyond basics. In practical exam, when you're especially presenting your cases, just stick to the methodology of presenting the case. That's what matters. Theory and too much of this knowledge should not be asked. It is all about how do you examine, which history did you take, why did you ask this question, what are the other possibilities. That's all that happens. Very, very important is stick to the basics, answer to the point. Just I demonstrated one example where I asked her something and types of nasal discharge. She went on telling me that happens to the student out of stress. You want to just go on telling. Don't tell what you're not asked. Invariably, you'll end up in a bigger trouble. All right. And don't lie. Don't try to cover up. If you are not done something, be sincere and say, yes, I did. Because we do understand that it is a stressful situation and something can be missed out, and those things are fine. Because as Dr. Mahesh pointed out, you try to hide one mistake, you'll end up doing one more mistake, and that will become a bigger one. These are all the common things we are trying to tell here. The questions asked will be, obviously it's a surgical branch, we'll ask the anatomy of that area. We'll ask you basics, like, the roof of the nasal cavity visible and normal is a blunder. Don't make these mistakes. All right. You be very clear. And one more thing, I just want to say this. Don't try to do anything special because it's an exam day. Many students I have seen, they try to do something different, something special they want to tell because it's exam day. Take it as a day-to-day routine case presentation. All right. Don't try to do anything special. Just stick to the basics. Tell the same things that you tell on a day-to-day basis to your teachers. When we ask you investigation, the same thing that you do in your hospital every day. Just stick to that. That itself is what we are asking. And what is the management? That's all. And if you're trying to tell something very specific, please be ready with a reference. Okay, this is what is given in this book, so I'm telling this. I think I want to tell these few points.
Yes, sir. That's wonderful, sir. Anyone else, sir? Bala, sir?
Same.
Yes.
Namaste.
Namaste, sir. Bala, sir, anything you want to specifically say, sir?
Sir, continue.
Oh, sorry, some other call. Sorry. Sir is busy in the OPD. I think one-man show going on. Sir, any specific things in rhinology you want to stress, sir? Bala, sir?
About the previous case?
Anything, sir. In rhinology in general.
What I think is fine. We have discussed at length. Basically, the clinical methodology is corrected. Theoretical aspects, they have to read up. Especially staging of angiofibroma, various approaches, how it expands, wherever it goes, external esophageal extension, all that they can read up.
Yes.
I think a lot of things have been highlighted about how to go in for a clinical examination.
Yes, sir. Yes. So I think that was a wonderful session. I thank Dr. Shanbag for making a session very lively.
Thank you very much for including me.
I really appreciate you. Really, when I remember my PG days now, sir, because I also did from Gujarat University, where sir is an alumnus, and patient used to come from OPD to the exam hall. So directly from OPD, they'll pick patients and get into the exam hall, where we are just as a new case we are examining. That is the advantage, that we don't know anything about the case till that day. So we are not biased in any way. So that is a wonderful message what sir has given, and stick to the basics. A wonderful message sir has given, and I thank Dr. Shanbog profusely for being with us from OT straight away coming into the session and joining us.
It's really a pleasure, and I'm honored. I would like to be part of it every year also, no problem. It really is educative to me also. It's really nice.
Thank you very much, sir. Thank you very much.
Really nice initiative people are doing, helping a lot of PGs.
Yes, sir. Thank you very much, sir. Thank you. And I thank Mahesh Bhatt, sir, Dr. Gangadhar Somayaji, and Dr. Kailesh Pujari, sir, and Dr. Bala, sir. Dr. Kailesh Pujari, sir, and Balakrishna, sir, will be with us for the next case also. And I thank Dr. Tirtha. Yes, I appreciate her, because after two people retracted from presenting the case. They agreed to present the case 3 days back, and they retracted, and they stopped receiving our calls. And I asked Dr. Tirtha yesterday afternoon around 3 p.m. and she agreed to present the case, and she has done justice to what she agreed to. And definitely it is going to help her as well as the other delegates who are in the session. And thanks everyone. Yes.
Very important message to the PG. This is important. Make mistakes before the exam. Offer to make mistakes and learn from the mistakes. Unless you present and make mistakes, you will not know at all. People come to the exam hall with blunders in their misconceptions in their mind. That is very dangerous. So offer to present more often to your teachers, discuss, find out what mistakes you have, and cover them up before the exam. That's very good.
Yes.
Okay. Thank you very much.
Thank you very much, sir. Thank you, sir. Good day, sir. Bye. So that is the end of the session on rhinology, and we are going to the next session, and the case will be Dr. Tirtha. Thank you very much. So
thank you, sir.
Next session, the next case will be presented by Dr. Ravina, and we are having Dr. Kailesh Pujari, Dr. Balakrishna sir, and Dr. Sapna will be joining soon. Madam is there, busy with something else now, and Dr. Sunil Pai, professor and head of the department of ENT from Srinivas Institute of Medical Science, Mukka. Dr. Ravina, you can start presenting the case.
Yes, sir. Good afternoon, sir. Good afternoon, all.
Good afternoon, Dr. Ravina, you can start. And Dr. Arun Kumar sir also will join us in some time. Sir has joined already. Yes, okay. Yes, Dr. Arun Kumar sir has joined. Thank you. Welcome, sir. Because morning sir had some issues with the network, and we are happy to have Arun Kumar sir here, the professor and head of ENT, SDM Medical College. Thank you.
Hello, sir. So is the screen visible, sir?
Yes, Dr. Ravina, you can start presenting.
Yes, sir. Good afternoon. Today my case is regarding Subraya Venkatappa Naik, 69-year-old, who hails from Kannawar. His occupation is he is a manual laborer. He complains of pain while swallowing since 2 months. History of presenting illness. Patient complains of pain while swallowing since 2 months, which is insidious in onset and gradually progressive, which is more severe on the right side and radiating to the right ear. No aggravating and relieving factors. No history of foreign body ingestion. No history of difficulty in swallowing, breathing difficulty, noisy breathing, voice change. No restriction of movements of tongue. No history of pain during speech. No history of fever, night sweats, and no history of ear discharge and decreased hearing. Past history. There is no history of similar complaints in the past. No history of neck surgery in the past. No history of hypertension, diabetes mellitus, bronchial asthma, coronary artery disease, and he is not on any medication, and no allergic drug history. Family history, no significant past history. Personal history, He consumes mixed diet, appetite is normal, bowel and bladder habits is normal, sleep is adequate, and also he is a BD smoker who smokes 15 BDs per day for last 40 years, and he is alcoholic since 40 years and betel nut chewing since 35 years. General examination, patient is moderately built and poorly nourished. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and pleural edema. Vitals, pulse rate is 76 beats per minute, which is regular, normal rhythm, and normal volume. BP is 130 by 80 Hg in supine position. Respiratory rate is 16 minutes regular, and temperature is 98 Fahrenheit. Systemic examination, CVS is S1, S2 normal, no murmur. Respiratory system, normal vesicular breath sounds heard. Per abdomen is soft, non-tender, no organomegaly, and CNS examination is normal. ENT examination, examination of throat, first oral cavity, mouth opening is adequate, angle of mouth is normal, lips normal, bilateral buccal mucosa normal, bilateral gingivo-labial sulcus is normal, gingivo-buccal sulcus is normal, gums normal, teeth normal, tongue is normal, floor of mouth is normal, hard palate is normal, and retromolar trigone is normal.
You told he is a chronic smoker.
Yes, sir.
Whether the oral cavity mucosa is normal or is there any
no, sir, no stains were there,
or
sir. No, sir, no stains were there. No, sir.
no stains? What is retromolar trigone?
So retromolar trigone, it's a triangular shape. It's a triangular base with the base in the third molar, and the floor is the ascending ramus of the mandible with the apex on the maxillary tuberosity.
What is the surgical importance?
It's known as a graveyard, surgeon's graveyard, sir.
Any other
because it is
importance?
If the cancer is extended to retromolar trigone, one, it is very difficult to for the reconstruction, and also it is very and also it's an inaccessible area, so that
okay.
It
What
is
is
difficult to
corner?
access. Sir?
What is Coffin's corner? Coffin's corner. Okay, you can proceed.
Yes, sir.
You can proceed.
Yes. Oropharynx, soft palate is normal. Ula is normal. Bilateral anterior pillar is normal. Bilateral tonsil is normal. Bilateral posterior pillar is normal. Posterior pharyngeal wall is normal. And base of tongue palpation, it is normal. Indirect laryngoscopy that shows proliferative growth, filling the right piriform fossa, which is extending postero-inferiorly to the postcricoid area, medially to the right araepiglottic fold and the false folds with edema of the right folds vocal cord, superiorly into the right vallecula up to the base of tongue and laterally to the lateral pharyngeal wall. There is pooling of saliva present in the right piriform fossa. Right vocal cords are not visualized. Left vocal cords normal and mobile. Left piriform fossa is normal. Epiglottis is normal.
Okay, based
This
on
is
this,
an indirect.
just based on this, your symptom patient had only was vaginophagia, pain on
Yes,
swallowing.
sir. He is only having pain while swallowing, so no change.
No dysphagia. No dysphagia
No, sir.
also. Okay, anything else you mentioned?
No change in.
Yeah, no change in
It's
voice.
extending to post-thyroid area. Is it post-thyroid area visible on indirect laryngoscopy? Can you see the
No,
post-thyroid
sir.
area?
No, sir. It is a hidden area, sir.
Then how did you say it is extending to post-thyroid area? You can see it's extending to the retroarytenoid area beyond the arytenoid, or in one of the posterior pharyngeal wall crossing the midline or whatever. If you are not able to see the post-thyroid area, you can't comment about it.
Yes.
Any
Anything
sign
else
of
you can-
aspiration or penetration?
Sir?
Any signs
Aspiration.
of aspiration,
No, sir.
penetration? What's
No,
the
sir.
difference between aspiration and penetration?
Sir, aspiration, patient will have cough while having food and water, sir.
No, on indirect laryngoscopy. Indirect laryngoscopy or rigid telescopy are flexible. When do you say it's aspiration? When do you say it's penetration? No.
Sir, the right vocal cord is, so if there is restricted movements of the right vocal cord.
No, if it, whatever is pooling of saliva is there, any pooling of saliva?
Yes, sir, pooling of saliva.
If there is spillover onto the larynx, but not going beyond the glottis, then it is called penetration. If it is crossing the glottis, is going beyond the glottis, then it is considered as aspiration. This becomes important point in the examination to make sure whether this larynx is a functional larynx or not, because a lot of decision is taken about the further management, whether it's a functional larynx or not. This penetration or aspiration, it is a non-functional larynx.
Yes.
So pooling of saliva on the opposite side is there?
No, sir, more on the right side.
Right side is a lesion, no?
Yes, sir.
So opposite side. What's the importance of looking for pooling of saliva on the opposite side? What is the sign called?
Chevalier-Jackson sign.
If there is pooling of saliva in the
piriform fossa.
On the opposite side, what information does it give you? That the lesion is going beyond, isn't it? It is going beyond towards the cricopharynx, and that's obstructing there, which is not visible here. The lesion may not be visible in the left piriform fossa, but it may be going beyond to the region of the cricopharyngeal sphincter. Is the right arytenoid visible?
Right arytenoid is not visible, sir. It was edematter, sir. So that
Ventricular band?
No, sir, it was edematter.
So why do you think it's edematous? What made it edematous? Why do you think the ventricular band has become edematous?
So it is because of the lateralization of the disease.
Lateral or medial?
Medialization, sorry, sir. Medialization because of
so which space is likely to be involved?
Paraglottic space.
Paraglottic space.
Postcricoid.
So it has become a transglottic lesion. The paraglottic space is likely to be involved. What about the cord mobility?
So right vocal cord is not cannot be visualized, but the left vocal cord was moving.
So then you say hemilarynx.
Yes,
mobility of the hemilarynx is fixed or restricted or normal.
Yes.
So in this case, it is fixed. Is hemilarynx mobility fixed? Fixed, no?
Yes, it was fixed.
Okay. Okay. Right. Next.
System.
Yes, yes. So did you palpate?
Examination of neck. Yes, sir.
No, I'm talking about after indirect laryngoscopy. Did you palpate the throat? Is it important to palpate the throat?
Yes, sir. Yes, sir. For the lymph node, we have for the nodal extension.
Not the neck. They're asking about the oropharynx. Where do you palpate? What?
Yes, sir. Base of tongue, I have palpated, sir.
Did you mention that?
Yes, sir. I have mentioned.
Okay.
Base of tongue palpation.
No, not only base of tongue. What else you're supposed to palpate? The lesion, you see the lesion is going beyond the pharyngoepiglottic fold in your indirect laryngoscopy. Superiorly into right vallecula up to base of tongue you've written. And on palpation is normal. It's contradicting, isn't it? So you should look for induration of the base of tongue on the tonsillolingual sulcus.
Yes.
And you have to mention it also.
Yes.
Okay. Proceed.
Examination of neck. Single heart fixed lymph node of size 2 into 1.5 centimeter in the right level 2 lymph nodes. There is widening of the laryngeal framework is present. Laryngeal crepitus was absent and no other palpable lymph nodes. Trachea central and the carotids bilateral palpable.
So So we don't go through inspection, palpation, and all that. Or straight away start with node, is it? What is the methodology?
Yes.
Examination neck to start with the attitude of the neck. Is any cortical, is any deformity, any?
No, sir, no deformity was, but there is laryngeal framework was widened, sir.
No, but then you should mention that in a systematic way. Whatever way you examine doesn't matter, but you have to present it in a systematic manner that the attitude of the neck was normal. On inspection, what did you find? On palpation, what did you find? And if necessary, percussion and auscultation, you can add on.
Yes.
Because in exam, they'll see your methodology of clinical examination, whether you're following a particular method or just skipping the methods. So what did you look for on inspection in this patient?
Sir, on inspection, we can see the laryngeal framework, sir. There is a widening on the right side. It was there. And we can see the lymph node at the size, approximate size of the lymph.
You can see the lymph node or you see a swelling?
Swelling, sir.
At the most, you'll see a swelling. You will not say it's a lymph node. You see that.
Yes, sir. It's a swelling, sir. On the swelling in the neck.
Okay, then what else you look for on inspection? Would you like to look at the thyroid membrane,
Yes, sir.
thyroid membrane, that area?
Yes,
because fullness, you can.
Yes, sir. Fullness.
The palpation may seem to be normal, but you keenly look for it. You may appreciate the fullness when you compare it to the opposite side.
Yes.
Of the cricothyroid and thyroid membrane. If it is there, what does it suggest? If the fullness is seen in the thyroid membrane on that particular side, right side, what does it suggest?
Yes, sir. There is extension into the extension.
External extension.
External laryngeal extension.
External laryngeal extension. Right. Okay. And what does you look for? If there are dilated veins, what does
Yes,
it
sir.
Dilated veins. In the skin of the middle of the neck or the larynx is involved, is pudy orange of that area. So you should be able to comment about the skin and dilated veins.
Yes.
The dilated veins, what does it suggest? Maybe mediastinal lymph nodes.
Yes, sir.
Maybe superior mediastinal obstruction. So you should not skip any part of the clinical examination.
Yes.
Right. Okay. Widening of the laryngeal framework. What do you mean by that?
Sir, it is because of the extension in the paraglottic space and invasion of the thyroid membrane.
Okay.
Widening of the region.
Thyroid cartilage.
Yes, sir. Thyroid cartilage.
Did you look for laryngeal tenderness?
Yes, sir.
Not mentioned. But you are mentioning only positive findings. But your written laryngeal crepitus is absent.
Yes, sir. Laryngeal crepitus was absent, sir.
Laryngeal tenderness?
Laryngeal tenderness, no, sir. It wasn't.
If it is tender, what does it mean? Just laryngeal
Sir,
cartilage.
it can be because of the perichondritis, perichondral invasion.
Extralaryngeal spread again. There's gross cartilage involvement.
Yes.
You know, so. Again, you should talk about teachability of the skin. And you told about node is fixed, is it? Hard and fixed.
Yes, sir.
Fixed in all directions or only transverse direction, vertical?
No, sir. Fixed in all directions, sir.
All directions.
Yes,
so if
sir.
it is fixed in all directions, what does it mean to you?
There is extranodal invasion, sir.
All directions. It's fixed in
That is,
any
it is,
direction.
that means
External
it is onto the underlying structure.
If it is fixed in the vertical direction, but mobile horizontally, what does it mean?
That it is on the muscles. It's over the fascia, so that.
Which muscle?
So level 2 digastric, sir.
The carotid sheath may be involved, The sternocleidomastoid
carotid sheath.
all the structures are running from below upwards. So sideways it will be still mobile. So it's still affixed to the interjugular vein. It may still be mobile on a transverse plane. If it's fixed in a transverse plane, what does it mean? It will be fixed to the prevertebral fascia, the muscles of the floor of the neck, posterior triangle. So it may be fixed to the prevertebral fascia. So hard and fixed, even the transverse direction means it is fixed with even to the prevertebral muscles or prevertebral fascia.
Yes.
Got it?
Yes.
And it's less likely a 2 into 1 centimeter will be fixed in the transverse direction. It is not that big. Possible,
yes.
But probably you're not examined properly. There are no other lymph nodes palpable.
No, sir. Only one lymph node was that right level.
When you are written about carotids, palpable, bilateral.
Yes, sir.
What is your what interests you about carotid in this case?
Sir, if it is into the encasing the carotid artery, so that the stage will be.
Encasing carotid artery where the node is sitting higher up there, no? This is like level 2. Am I right?
Yes.
Where is level 2?
Level 2 submandibular. No, sir. Jugular fossa.
Jugular fossa.
Upper jugular. Right level.
Okay. It is above the level of the. Above level of what? Above the level of the hard bone.
Above the level of head.
Retromandibular. Right. What is level 1, level 2A and level 2B?
Level 1 is submandibular. Level 2
what
is
is level
submandibular.
2A? What is level 2B?
Level 2A is anterior to the accessory nerve and level 2B is posterior to the accessory.
Anterior to the anterior border sternomastoid. 2B is deep to the sternomastoid. It's close to the accessory nerve. So at that level, do you think you are able to palpate the carotid? At what level does the carotid bifurcate?
At the level of C6.
No, you can't measure the C6 or when you're clinically examining. At the level of the hyoid bone.
Yes, sir.
Right. At the level of the hyoid bone, approximately at the level of the hyoid bone. So that is where your node is sitting there. So if you're palpating carotids below that, it does not give any information. So what more you would like to know? Whether the external carotid artery is involved. So you look for distal arterial pulsation, like pulsation of the facial artery, superficial temporal artery.
Yes.
Got it?
Yes.
The carotid may be palpable below the node. It will not give any information.
Yes.
If the facial artery or superficial temporal artery is weak on that particular side compared to the normal side, then you presume that the external carotid artery is involved. And if external carotid is involved, you presume that it's encasing the internal carotid artery also.
Yes.
Right. Proceed.
Sir, examination of nose. External framework is normal. Columella is normal. Vestibule is normal.
Okay, skip that. Everything is normal, no? Skip that part.
Yes, sir. Yes. Examination of ears, sir.
No.
Everything was normal.
Skip. Okay.
So my
No, systemic examination.
sir, I have one BLS video.
No, systemic examination.
Done, sir.
What system did you focus on?
Respiratory system, sir, because he was a BD smoker.
Respiratory system. Any other system?
Sir, serious also, sir.
Is the
Cardiovascular
hypoglossal nerve?
system.
Is the hypoglossal nerve involved?
No, sir.
Vagus
No
you can't
involvement.
comment about. Vagus is difficult to comment. What about hypoglossal? Accessory. Is it not important for us to look what is CNS?
Yes, sir. CNS I commented, sir, was normal.
No, you should specify whether you look for the accessory nerve function or not.
Yes, sir.
Have you commented
Shrugging
about
of shoulder.
tongue movement?
Tongue movements was normal, sir.
You mentioned about it.
Yes, sir. Yes, sir. That in the history of presenting illness.
No, history, not history, clinical examination.
Yes, sir. Examination.
So what
yes,
are
sir.
the times of hypoglossal nerve involvement?
So there will be a restriction of the tongue movement, sir.
What restriction?
Because all the muscles of the tongue are supplied by hypoglossal nerve.
What restriction is there?
Like protrusion.
If the hypoglossal nerve on the right side is involved, what will happen? What are the findings you will expect?
The tongue will be onto the same side, sir. It will, like there will be paralysis on the same side.
On protrusion
Deviation
of
onto
tongue,
the same side.
your answer on protrusion of tongue deviates to the same side. Why
Yes,
does
sir.
it happen? Why does that happen?
Hypoglossal nerve paralysis, sir.
Why should it deviate to the same side? One asking the patient to protrude the tongue deviates to the same side. That will be your answer, is not so. But why does it
Yes,
happen?
sir.
Which muscle is being tested now? Which pulls the tongue forwards? Which muscle is involved in protrusion of the tongue?
Sir. Genioglossus.
Genioglossus muscle. So the normal genioglossus will pull the tongue forwards so that the tongue protrudes or deviates to the affected side. What are other things that can happen to tongue in hypoglossal palsy? Can you look for wasting, fasciculations?
Yes, sir. Fasciculations. Patient.
See, unless you look for it, you may not see it. Unless your mind knows, your eyes will not see.
Yes.
So look for wasting of that side particular tongue.
Yes, sir.
So hypoglossal nerve is involved in this case. What information does it give you? Is it operable or non-operable?
It's not operable, sir.
Why not?
Because the entire tongue, base of tongue will be.
Because hypoglossal crosses the two carotids.
Yes, sir.
The hypoglossal crosses both the carotids, both external and the internal carotid, and that's where your node is also sitting there, which is fixed. So there's more likely that there's more and more encasing of the internal carotid artery there. So if the hypoglossal is involved, it's more likely that this patient will turn out to be inoperable with respect to the encasement of the carotid. That is the information you get.
Yes.
The accessory muscle is involved, accessory nerve is involved. How does it alter your management?
Sir, if accessory, then patient will have difficulty in shrugging of shoulders.
So shrugging of shoulders is affected. There is drooping of the shoulders.
Yes.
So what will it change your management? Will you try to do a modified neck dissection?
Yes, a modified radical neck dissection so that the spinal accessory nerve is.
If the
Yes,
shrugging
sir.
is affected, will you do it or not do it? Accessory nerve is already
If
involved
access-
clinically.
No, sir. Then
Will you try
no
to
point of
preserve it?
doing in.
So you will
No, sir,
not.
then-
You will go straight away with radical neck dissection. You are not even bothered about preserving the accessory nerve. Is it not so?
Yes, sir. Yes, sir.
That is why this clinical examination becomes important.
Yes, sir.
Somewhere you said mouth opening is adequate. What do you mean by adequate mouth opening?
So it is, there is no trismus.
Is there any grading of this trismus?
Yes, sir. If it is grade 4, it is more than 3.5. If it is grade, it is grade 1, it is more than 3.5 millimeter. 35 millimeter. 35 millimeter. If it is grade 2, is 25 to 35. Grade 3 is 15 to 25, and grade 4 is less than 15, sir.
Okay, some classification. You know the name of the classification? Who has graded this? Will you find it out?
Yes.
Okay. So we'll move on. Diagnosis, unless others want. Arun, Sapna.
Hello, sir.
Kelly.
No, sir. She can proceed.
Okay, proceed. Yes. So diagnosis. You said you're going to show the endoscopic picture.
Yes, sir. I have a VLS picture. VLS
Before that,
videos.
what is your staging?
So my staging is T4A, N3, B, and MX, sir. Stage 4A.
Why stage 4A?
Sir, it's because, sir, one, it is if it is stage 4A because there is a laryngeal framework is widened, so that there will be it is entering into the thyroid, cricoid, and hyoid cartilage.
So why is it widened?
Because of
You mean the
so
widening
laryngeal framework is widened, sir.
But widening will suggest it is involved?
Yes, sir. It is. It will be involved in the thyroid cartilage, hyoid, and cricoid cartilage, sir.
Yeah.
And
So why
then,
should there be spleen? Why should there be spleen of the cartilage? Is it the mass effect, or is it that the cartilage should be infiltrated and then involved?
It is infiltration and then going, sir.
And at the entry curvature?
Sir.
Okay. It's probably over-diagnosing that way. Okay.
You said
And,
N3B, is it? N, what did you stage your nodal?
N3B.
Yes, N3B, ma'am, because there is a fixed node, ma'am.
Please tell the nodal. Just tell the nodal staging.
Ma'am, N1, N1 is single ipsilateral, up 3 centimeter, not larger than 6. N2 is
no. Come again. It's a single ipsilateral node.
Up to 3 centimeter, not larger than up to 3 centimeter, ma'am.
Okay, and what is your patient having?
2 into 1.5 centimeter, ma'am.
So less than 3, right?
Yes, ma'am. But there is fixed node, ma'am. So there is extra nodal invasion, so it can be.
So any size with extra nodal extension is considered as 3B.
Yes, ma'am. Yes, sir. 3B, sir. So.
What are the other features of extranodal involvement?
Ma'am, if there is a invasion of the thyroid cartilage entering into the entering into the paraepiglottic space.
No, you're
I'm talking about nodal.
Talking about, about the node. What are the signs of extranodal extension?
Sir, the fixity and the movement, like not in transverse direction.
One is fixity. Any other?
Yes, sir.
We just discussed about that, no? The hypoglossal nerve is involved.
And the shape.
If the hypoglossal nerve is involved, will you consider as external extension? The accessory nerve is involved, will you consider as ENE? It is. It's extranodal extension. Extranodal means it is going beyond the node.
Yes, sir.
Okay, so there is involvement of the nerves around that external extension. If the skin over it is not pinchable, external extension. So there are so many other signs that will say this is external extension.
Yes.
It's not just okay.
Yes.
Okay.
The skin.
Right.
Hello.
MX or M0?
Sir.
You said MX or M0?
MX, sir. M0.
Clinically M0. Clinically M0.
Yes,
MX is also no problem because you have not really examined those areas, all the areas. Fine. So what is the stage now? Stage?
Sir, it's stage 4B, sir.
Stage 4B. Okay. Right. This stage 4B will become inoperable straight away or it is still operable?
No, sir. It will be inoperable, sir.
So with respect to node, it need not be. So the external extension involving the skin, you can still operate. External extension involving intrajugular vein, you can still operate. It can be infiltrating external sternocleidomastoid, you can still operate.
Yes.
Only when it is involving the prevertebral muscles, fascia, then it becomes inoperable or encasing the carotids. Just ENE positive does not mean that it is not operable. Still it can operate. Okay. Right, shows the finding now, your endoscopic picture. Okay. So definitely you have to palpate the base of the tongue and the tonsillolingual sulcus, vallecula.
Yes, sir.
You never mentioned that. Just base of tongue is not sufficient. Vallecula is also important.
Yes.
Heavy larynx is fixed. In fact, some amount of pooling of saliva is on the opposite side also.
Yes, sir.
Right.
Even epiglottis right side is also edematous.
Yes, yes.
Did you tell epiglottis is normal in your ideal findings? What is your ideal findings?
Sir, my ideal findings, sir.
Yeah.
Epiglottis
What
is
about
normal, sir. Epiglottis is normal, sir. Yes, sir.
Edematous on the right side.
Yes.
In the endoscopy picture.
Can you play it again? Can you play it again?
Yes, sir.
What is at the base of the tongue?
See the
Appreciate the pooling of saliva on the opposite side also.
you see the pharyngeal fold involvement and adjoining the edema of the epiglottis is there adjoining area. Not complete, just adjoining.
Right. So what do you do for this patient now?
Sir, better we go with like sir chemoradiotherapy, sir. Or else if you want to proceed,
please don't jump to that.
Yes, sir.
Investigation.
First, we have to start with investigations.
Okay.
What
What
like
investigation you
blood
want to do?
investigations we have to see. Blood investigations for the workup
So what
before surgery.
specific investigation?
Yes, sir. Urea and creatinine, sir. Urea and creatinine so that we can do a CECT, sir. From skull base to mediastinum.
What is the first investigation?
Blood investigations are with BLS. Video laryngoscopy.
Video laryngoscopy. You want to do it rigid or flexible?
Rigid, sir.
Rigid. Why not flexible? What's
So,
the advantage of doing a flexible
so that
video laryngoscopy?
sir, because if it is flexible, that spatial orientation, the cricopharynx.
Cricopharynx you cannot see on rigid telescopy, no. Rigid telescopy, why? I was asking why you prefer to do a flexible.
If you had facility for flexible scopy, there's nothing like that.
Yes.
What's the advantage of doing a flexible scopy in this case?
Because the cricopharyngeal involvement, if it is there, so that
Cricopharynx is difficult to see, madam.
if it is going to the
Post-psychosis is difficult to see. Of course, you can go beyond. You can go beyond. Yes, as you're right. You can use it as an esophagoscope. That's what you meant.
yes, sir.
You can use it as an esophagoscope. Yeah, that's right. But that is really difficult because cricoval sphincter is kept closed. So as you withdraw, you can see. As you withdraw the scope, you can see what is the status of the cricopharynx and the post-psychotic. Agreed. Any other advantage? About the laryngoscopy, hypopharyngoscopy. Can you do a Valsalva with flexible scopy?
No.
Can you open up the pyriform fossa with the Valsalva?
Yes.
That's the advantage. No? So you can actually ask them to do a Valsalva so that the pyriform fossa opens up. So you know whether the medial wall, lateral wall is involved. Because when it's kept closed, post, you may not be able to differentiate medial and lateral wall. And you may not really see how far it's going down. Okay, there's one advantage of doing a flexible scope. You can do a Valsalva maneuver. You can advance the scope further into the esophagus, and as you withdraw, you can see the cricovenous sphincter and the postmycoid area, the apex of the pyriform fossa. Okay, right. When do you want to take a biopsy? You want to do it
So
as
we will take
outpatient?
biopsy only after the CECT, sir.
After CECT.
Yes,
Why?
sir. Because
Right.
because if we take biopsy before, sometimes there will be edema because of that, and that will cause up staging of the disease in the CT. So that only after CECT we'll go with biopsy.
Oh, you take so much of biopsy, right, to cause edema?
Yes, sir.
We just need
Because
a small piece. We just need a small piece. But do you do it as an outpatient procedure? My question was, do you do it as an outpatient procedure or inpatient procedure? Would you like to take biopsy?
Here we will Dielscopy biopsies.
Dielscopy. Why not as an outpatient? You have done a CT scan. Patient comes to you with a CT scan. What stops you taking a biopsy in outpatient?
Sir, because of the spasm, sometimes it may go.
No, you are right, but you should be able to justify why you are doing it in the
laryngeal spasm, sir.
No.
So that
Laryngoscope is going to spray the throat. There is no obstruction to the airway in this case. If there was airway obstruction, then definitely you would have told laryngospasm. You don't want to stimulate the larynx. You don't want the patient to go into stridor. But here the airway is good. You can see the cords mobile.
Yes.
So always better to do under relaxation so that you can do proper assessment of the lesion and then take a biopsy. So we know the exact extent of the lesion. But then it is most of the time what we do is we take a biopsy in our outpatient, and if we are operating, we do a preliminary scopy and proceed. That is also accepted.
Yes, sir. As you said, I think mapping out of the entire lesion and to plan your approach for surgery, that's when you would like to take it. Otherwise, most of the times it's now done as a
outpatient.
Outpatient procedure.
So why CCT?
Sir, CCT from skull base to pediatrium, sir. If there is any like thyroid cartilage involvement,
CT scan or MRI?
CT scan, sir. MRI, if there is any tongue lesion, if it is extending to the base of tongue, then we can go for MRI, sir.
Not necessarily. The newer advances that even MRI gives you good information about the cartilage involvement.
Soft tissue.
Even the cartilage involvement.
CCT gives.
The CCT gives, but even MRI gives. What was thought that MRI will not give information on cartilage is now not agreed by the radiologists. They say MRI also gives you good information about the cartilage involvement. If you have a luxury, then MRI will be better, but CCT definitely is okay for us because we probably we can read better the CT scan than various sequences of MRI. Right. So what do you want to assess in the CT scan? Just enumerate what you want to assess in the CT scan.
So whether it's like nodes we can see for the nodal involvement, whether it's to where all it spreads, whether it is spreading to the opposite vocal cord, paraglottic space.
Like to know the status of the lymph nodes in the neck.
Yes, sir. Pre-epiglottic space.
Including the mediastinum.
Yes, sir.
Right.
And if there is any lung mets.
Can there be central compartment involvement in this case? Nodes?
No, sir. No, sir. No central compartment.
Can you pick up by CT scan central compartment lymph nodes?
Yes, sir. We'll be taking up to superior mediastinum, sir.
We can pick it up. We can pick up central compartment node. That's a big advantage. With ultrasound, may not be able to pick up. So CT scan, you have to read methodically. Even L6, L7, you have to look for. Right. So which malignancy is involvement of the central compartment nodes?
Sir, if there is thyroid or subglottis or it can be cervical esophagus involvement.
Subglottic or postcricoid or ricopharyngeal involvement, esophageal involvement. So lower down, there is more chance of paratracheal involvement. So if you are going to look at the lymph node status, what about the primary tumor status?
Yes.
Status of the primary.
Sir, here the right level 2 lymph nodes enlarged.
No. What are the things you are going to talk about primary tumor in the CT scan? What are going to see?
Sir, we can see the extension of the disease, sir.
Extension into?
Extension, whether it's involving to the glottis or subglottis and supraglottis.
What else?
And infiltration of the thyroid cartilage.
Pre-epiglottic space,
paraglottic space and paraglottic space.
Paraglottic space, posterior pharyngeal wall, prevertebral muscles. Okay, we're going to look at the extension, extralaryngeal spread where the cartilage is involved. Is it minor cartilage involvement, major cartilage involvement? So you're going to look for that. So you're going to do CT scan of the neck or including thorax?
Sir, CT. CCT skull-based mediastinum, sir. Thorax. With thoracic cuts we can do.
Mediastinum or thorax? Including entire chest?
Thorax, sir. So that we can see if there is any metastasis to the lungs.
So how does it look like? If there's metastasis in lung, how does it look like?
Hyperechogenic mass in the lungs, sir. Like punched out lesions.
What's your punched out? What is the appearance of the metastatic lesion in the lungs?
Cannot.
Yes, you're right.
You're right, say.
Cannonball appearance.
Cannonball appearance. Okay. So more likely to affect the periphery of the lungs, cannonball appearance. Any other metastasis you can pick up apart from the lungs?
So pre-epiglottic and para.
No. You're talking about distant metastasis. No, that's all over. Distant. Any other distant metastasis? Your chest X-ray, chest scan can pick up.
Liver.
Liver, yes, because it partly covers the liver also. When you take the entire chest. Okay. What else? Vertebral column. Yes, vertebral column. You're right. What else? Ribs. And also you can pick up pleural effusion.
Yes.
Right? So sometimes metastasis may be just a pleural effusion. When you have it, you tap it and you may get malignant cells in that. Okay, CCT, neck and thorax. Any other investigation? Biopsy is moderately differentiated squamous cell carcinoma. Any other investigation you want to do?
So we can go with upper GI scope, sir.
Yes. Why do you want to do that?
So
why do you want to do a
pain while swallowing? So we need esophageal involvement in second primary.
Endoscope. Yeah. Second primary, yes. Second primary. So earlier used to say triple endoscopy or pan endoscopy, oral pan endoscopy, including bronchoscopy. Okay. What's the incidence of second primary in hypopharyngeal malignancy?
Pharynx, or if it was 75% in post pyrethrum foci, 75%.
In the hypopharyngeal malignancy, what is the incidence of second primary?
So 75% pyrethrum
75%, too high.
No, I think you're getting mistaken for something else. You're asking about second primary in the lung. Okay, suppose you have second primary in the lung.
Even secondary is too high, I think, 75%. It's only about 10%. 10%, which could be synchronous or it could be metachronous. That means you may pick it up at a later date. Okay. So what is your plan of action for this patient? Any other investigation you want to do to assess the liver functions?
Sir, we can go with the USG abdomen and pelvis to rule out any metastasis. And then go with DL scope, biopsy.
Biopsy is moderately different squamous cell carcinoma.
So then,
what do we do?
So we can do a total laryngectomy with pharyngeal resections.
What is it? Stage 4B. So what is the way to confirm whether the carotid is involved or not? Here you have a patient with encasing the carotid.
So from CECT it can be.
So what do you look for the CECT about the carotids?
If whether it's encasing the carotid sheath, means whether it's encasing the carotid artery, so that the stage, radiological stage will become T4.
Just encasing may not be involved in the carotid. What will suggest is involvement of the carotid. Encasement is going all around the carotid. That doesn't mean that you can dissect it out. What will
whether
suggest?
It's like infiltrating the carotid.
So what in the scan will suggest that it's infiltration of the carotid. That it may be difficult for it to clear it up with the.
So behind the carotid sheath, Nodes in the
You look for the fat plane around the
carotid sheath.
You look for not sheath.
Yes.
Fat plane around the internal carotid. Even if the external carotid artery is involved, we are not bothered. Whether the internal carotid artery, is a fat plane around that is involved or not. Here, MRI will score much better. So, MRI will tell you better about the carotid, whether is infiltration or not. If fat plane is preserved around the carotid, even though the carotid is encased by the tumor, you can still resect the lesion. Okay. Then if in case you're going to tell us how much it is infiltrating, how much of the fat plane is lost. 90 degrees, 180 degrees, 360 degrees. Got it?
Yes.
Okay. So what is your plan of treatment? Well, your patient is going to ask you, how are you going to manage me?
So we go with the chemoradiotherapy, sir.
But that's not towards surgery?
So surgery, if it is not encasing the carotid sheath, if it is not involving the part of the carotid sheath, then surgery can be planned because the opposite vocal cord is.
So how will you tell that to the patient that this is the plan of action? You have to counsel this patient. You have to sit
because it's opposite. Its left vocal cord is mobile, so we can go for a.
No, what sir is asking you is you have to counsel the patient. So when you counsel, you have to tell the benefits and merits and demerits of surgery versus CCRT. So if you say that, see, option is finally the decision is going to be the patient's, not us. So in that case, why should a patient opt for surgery or why should a patient opt for CCRT? Can you tell us the advantages and the percentage of 5-year survival or what it is?
You have to counsel.
Yes, ma'am. If you're proceeding with, you have to counsel about the total laryngectomy with pharyngeal resection with the like the PMMC reconstruction. So patient may lost his voice, but the local disease spread can be removed. So that
you tell him there are two options of treatment, is not so?
Yes, sir. So
two
if
or
we
three
go with
options of treatment. What are the options that you have in your mind?
either surgical option or they can go for
Is it single modality or multiple modality?
Like multiple modalities, like even after surgery.
So first thing is you're going to treat palliative or curative. Intent is palliative or curative.
It's therapeutic. Sir.
Therapeutic, correct. You are doing treat only, but then is it palliative intent or curative intent? Because that should be very clear about it when you talk to the patient.
Yes, sir.
Is your intent of treatment a curative one?
It's curative. Sir.
Curative. So if it is curative, what will be you have to go for multimodality treatment. So what options do you have for the patient? Option
surgery
1,
plus
option
chemo
2,
RT can be given,
sir.
So either he can either just go for chemo RT or else we will give surgery with chemo RT.
Okay, surgery followed by radiation therapy is one
radiation
option.
Chemo.
With or without chemo.
Yes, sir.
Second option is chemo radiation. Third option is palliation.
Palliation.
Okay. So you're going to explain to the patient about the benefits and risks of each option that you have for the patient.
If it is only chemo RT, if there is the residual disease can again like patient may go for again metastasis. If we are going for surgery with chemo RT, the surgery is what we give is total laryngectomy. So patient may lose his voice.
So you're going to also tell how you're going to rehabilitate the voice. So don't say lose a voice. You can tell that you're going to lose a voice temporarily and we'll give you artificial speech after that.
Yes, sir. And also they need to go for a like flap reconstruction.
In case
surgery, in case.
So in this case, if it is considered to be operable, what will you do? So MRI shows that carotid is free and you can remove this fat plane around the carotid is intact.
Yes, sir.
What surgery are you going to do?
We go with total laryngectomy with pharyngeal resection.
Total laryngectomy?
With pharyngeal resection, sir.
Pharyngeal resection is what? Partial pharyngectomy?
Yes, a partial pharyngectomy with reconstruction.
total laryngectomy, partial pharyngectomy, completed surgical treatment.
With reconstruction.
You have to deal with the neck.
With a modified radical neck dissection, sir.
Which side?
On the right side.
So right side modified neck dissection. Prefer to do radical neck dissection because you said it's a fixed node.
Yes, sir.
Right, it's fixed node. But if it is pulsously mobile, better to go for a radical neck dissection. But if it is, you're going to start with the neck dissection first, and you're going to see the operability.
Yes.
Got it. If you find that it is inoperable, then there's no need point in removing the larynx. So first thing you're going to do is right-sided neck dissection and confirm the operability.
Yes.
If it's operable, if you got away from the carotids without any involvement of prevertebral fascia or muscles, then you proceed with the other neck dissection. What is the other side? So you're going to do radical neck dissection on the right side.
Yes, sir. And we can go with supraomohyoid neck dissection on the left side.
No supraomoid. Larynx, pharynx, no supraomoid. Supraomoid is for oral cavity.
Yes.
What selective neck dissection I'm going to do for the hypopharynx?
So lateral neck dissections can be done.
Lateral neck dissection. And
Yes,
2, 3, and 4 along with the carotid sheath.
Yes, sir. 2, 3, 4 along.
Okay. So then you can proceed with total laryngectomy, partial pharyngectomy. And how do you deal with the thyroid gland?
Yes, sir. Thyroid, while doing total laryngectomy, we'll be removing we'll be doing total thyroidectomy, sir. So we have to advise a patient that post-operatively he should be on lifelong thyroid medication and calcium.
You don't advise after the surgery, you should advise before.
Before, sir.
Okay. So will you remove the entire thyroid or can you preserve part of the thyroid?
Yes, sir. Part of the thyroid can be preserved, so that depends on the extent. Inferior, sir.
Inferior?
Inferior.
No, it's going to opposite side. Contralateral thyroid lobe can be preserved, provided there is no extension to the subglottis or the postcricoid or the cricopharynx.
Yes.
If it's extending there, then better to sacrifice the entire thyroid. If it is isolated into one pyriform fossa, then you can retain the other thyroid lobe. Opposite thyroid lobe can be preserved along with its parathyroids. Right. Okay. Then what reconstruction is it?
PMMC flap reconstruction, sir. Pectoralis major myocardial.
Why do you want to use pectoralis major myocardial? Can't you do a primary closure?
So primary closure, it will be difficult, sir, because here the apex of the pyriform fossas, and there is involvement of the post-cricoid area, so that it may cause stricture and cutaneous fistula. So it will be
present, no?
Sir?
The clinical examination, I think
No, absent, sir.
Absent. Okay. Okay.
So,
right.
So better we go with the approximation will be difficult, so that it's easy if we go with the reconstructions.
The post-cricoid area, the apex is involved, or if you have less mucosal mucosa that is there to close, how much mucosa you need to close primarily? How much mucosa you need transversely to close the pharynx primarily?
Superiorly, so 2 centimeter, inferiorly.
How many centimeters?
Superiorly 2 centimeter, inferiorly 1.5.
This 3 centimeter in it, right?
In
this 2 to 3 centimeters ideally. This good 2 fingers or 3 fingers ideally to suture around the right tube. Okay. What about the cricopharyngeal myotomy has to be done?
Yes, sir. Cricopharyngeal myotomy should be done, sir. Or else, patient will have difficulty in phonation, sir. To develop esophageal speech, there will be cricopharyngeal sphincter spasm.
So that is if you are doing a primary closure. If you are doing a patch pharyngoplasty, there is no need to do a cricopharyngeal myotomy. If you are actually excising part of the cricopharyngeal muscle itself, then there is no need to do a myotomy. That is why you do what's called as patch pharyngoplasty. No? Part of the cricopharyngeal muscle also. Then to reconstruct, you can put a patch. Right. Any other options? Then patch pharyngoplasty for a post-cricoid extension.
So gastric pull-up can be done, but
We do total laryngopharyngosesophageectomy and a gastric pull-up. So gastric transfer, pharyngogastric.
if there is involvement of the esophagus, then we can. With esophagectomy, we can.
So what is the advantage of gastric pull-up over a patch pharyngoplasty?
So fistula will be less because while gastric pull-up will be rotating the jejunal flap. So,
stomach is very vascular, so chance of leak is less.
Leak is less.
Any other advantage?
So stricture, formation of stricture
is less. Okay.
Because jejunal.
Yeah,
and no avascular necrosis won't be there because jejunal flap.
Anastomosis is higher up in the neck. So
Yes.
even if it leaks, involvement of the mediastinum will be less. There's less chance of it involving the mediastinum. If the leak is higher up at the level of base of tongue, it will tend to heal easily. Then if a patch pharyngoplasty which starts leaking, then there's higher chance of it leaking into the mediastinum. Right. And swallow is better because the entire thing is a muscular organ and the PMMC.
Yes.
Okay. So what will be your advice post-operatively?
Post-surgery, so we have to advise a patient to develop esophageal speech. We have to give him like more sessions to produce the esophageal speech. And we have to put him on lifelong thyroid medication and calcium medications.
Okay. So how do you decide whether to add on chemotherapy or not?
Yeah. So if there is any...
You already decided that patient go for radiation therapy. When you will decide about chemotherapy?
Sir, histopath.
Yes, what about histopath?
It is moderate. It was moderately differentiated. So
it is already moderately differentiated. It is already a moderately differentiated stomach necrosis. What?
Perineural invasion.
Yeah.
Perineural invasion, margins.
Okay. Margins, correct. The margins are positive. One. Anything else?
Depth of invasion.
It is not in case of pharynx. It's in case of oral cavity. Depth of invasion.
Nodular.
So external extension is already there. So that will go in favor of chemotherapy. So you have to add on chemotherapy when there's external extension. Multiple nodes, external extension, and are positive. There is no margins positive neck resection. Then you're going to add on chemotherapy. Right. Okay. What is the role of primary TEP in this case?
So primary.
TEP.
Primary tracheoesophageal processes. It is to produce like there are two types. Either we can keep it immediate or after 6 months secondary. So this will there will be flanks which will be over the trachea and on the esophagus. So which will trap the air in one direction. That will resonate the oral cavity and the pharynx to produce the voice.
So what is your take about primary TEP? Can we do it or will not do it?
Yes, sir. Primary TP can be done, sir. Like soon after the.
Can be done or not? Will you do it or
not? So here, no, sir, because it may cause fistula. So better we'll go with secondary TP.
Necessary. The thing is, you are doing a patch pharyngoplasty here. Then you would like to better to stage it.
Yes.
Some people prefer to stage, especially when there is a patch pharyngoplasty done. When you do it, even if you have done a primary TP, you will delay the putting the processes. You leave the catheter there and delay till the complete healing of the wound.
Yes.
Got it. Okay. Right. What about radiation therapy? Can you tell us about what radiation therapy you would like to give for how long? Fractions?
So we will go with 30 fractions or 60 grade 30 fractions for 6 weeks can be given, sir.
How many days a week?
Like 5 days a week with the weekly cisplatin.
So when do you want to interpose with the chemotherapy?
Sir, like chemotherapy will be given on 3rd, 7th and 14th days.
Okay, either give it weekly or 3 weekly.
Weekly, sir. Weekly cisplatin, sir. To radio sensitize.
3 weekly. There are different this one. 3 weekly also can be given. So it is a toxicity. Okay, weekly. So how do you assess this patient after his therapy?
After
treatment is over, after say about 1 month after the radiation therapy, patient comes back to you again.
Yes, sir. We
How
have to
do you
put esophageal speed. We have to see for any stricture of the laryngostoma, whether any fistula formation, any pharyngocutaneous fistula, whether patient.
Before itself, no? Before you're sending for radiation, you want to notice.
Yes, sir. And any esophageal speech. So recurrent BLS can be done.
Will you send the blood for calcium, TSH?
Yes, sir. Calcium, TSH.
So send the blood to calcium, TSH. You're going to assess the primary as well as the neck. If you have any doubt of a nodal recurrence, you can get an ultrasound done.
Yes.
What do you mean by stomal recurrence or parastomal recurrence?
So stomal, there will be like stoma will be.
What is stomal recurrence? What is parastomal recurrence?
If there is infiltration over the stoma, it is known as the like inside the lumen of the stoma. Yes. It is stomal recurrence.
Okay. The tracheal is involved in the stoma, then this recurrence visible.
So yes, sir, that is visible.
Parastomal.
Parastomal, if it is out.
It is at the level of the stoma, but it is submucosal or subcutaneous.
Yes.
That is usually due to the lymph nodes. Tracheal lymph nodes could recur. They could have malignancy in that. So how do you deal with that? Patient has come to you with a stomal recurrence or a parastomal recurrence.
Yes.
Comes after 6 months with a parastomal recurrence.
Yes.
What do you do?
If there is stomal recurrence, sir, we have to go for palliative.
Palliative. Any role for surgery at that point of time? Role of chemotherapy? Yes, you're going to add on chemotherapy for that.
Yes, sir.
Treat with chemotherapy. If you find that the great vessels are not involved, then you can as well go for resection along with the mediastinal dissection. If you feel that the carotids, the great vessels are not involved, then you can go in for a surgical resection. What is stomal stenosis?
So that laryngostoma will be steno, so that
Stenosis of the
we
stoma.
will be communicating the we will be communicating the trachea with the cutaneous, so that will be stenosed.
So how do you stoma? The stoma is narrow, but you can't put a tube.
Yes, sir. Yes, sir.
And the tracheostomy tube is narrow.
Yes, sir. That's right.
Even if you put a tracheostomy tube, it's a very small tube that the patient has got.
And either it can be because of chemo,
How do you
post-chemo
prevent
radiation, it can be.
Yeah,
Yes, sir, we will, because while having the radiation, we can keep a tracheostomy tube so that
how do you prevent
because
it
of
and how do you manage it? Stoma?
so while yes, sir, while if the patient on chemo radiation, sometimes the stoma may go for stricture, so that we can put a tracheostomy tube inside so that it won't go for stricture, sir.
Stomal stenosis is usually seen in females who have got small trachea. Okay. Males usually have a large trachea. And if you have not followed you're not preserved, you have to expose the cartilage during its, when you do a primary reconstruction of the stoma.
Yes.
Cartilage should not be exposed because perichondritis of the cartilage can give rise to stomal stenosis. So you should be careful about proper suturing technique. You're going to cut the trachea at the membranous trachea, not the cartilage. The cartilage should not be exposed. And precise suturing of the stoma will prevent the possible stomal stenosis. And even if it occurs, how do you treat it? Because radiation also will add to the problem. Correct, you said that right. Especially in this cartilage, perichondritis. How do you treat stomach stenosis?
Sir?
Any idea?
Sir, I didn't hear the question, sir.
Now, how do you treat stomal stenosis? Patient comes to
So
a
with
small stoma.
Sir, we can put a tracheostomy tube inside, sir. While tracheostomy tube.
You can
So
put
that.
a small tracheostomy tube, okay?
Yes.
And you can serially dilate it.
Yes, sir.
That's one way. Any other? Can you surgically treat stomal stenosis?
Like, so by doing the surgery, like the proper closure of the stoma, like during intraoperatively, while proper closure of the
Multiple
stoma.
Z-plasty, multiple Z-plasty to open up the stoma. You can have, you can cut the trachea in multiple places and allow skin flaps to get into those V-shaped defects, or the Z-plasty. Stomoplasty, it's called stomoplasty. Stomoplasty is when you create a bigger stoma by a surgical plastic procedure, You can do stomoplasty. Or you can go for a serial dilatation, as you said earlier. Or you can prevent it by placing a larger tube every night. Daytime you can remove the tube, or at night patient can sleep with the tube. So another way of preventing the spondyl stenosis. What is a Lary tube? Lary tube. Lary tube. Lary tube is nothing but a stomal tube. It's not a full tracheostomy. It's only a small, maybe 1 to 2 centimeters long tube, where it is intended only to stay in the stoma. Not like a tracheostomy tube which will go all the way down. A Lary tube is used post-laryngectomy. It's a very short tube and it's made up of silicone. It's a short tube which is well tolerated by these patients, and there's less chance of them developing stomal stenosis. So we can use this Lary tubes at least part of in their day. Like maybe at night they can wear it and sleep with that Lary tube. Can you tell me something about secondary TEP?
Secondary TEP,
which can stop me anytime. Can stop us.
So secondary TEP will be placed after 6 months. So it is of two types. One is welling and indwelling processes. Indwelling is kept by the professionals.
How do you do a secondary TEP? Before secondary TEP, how will you assess the patient? How will you evaluate the patient? You can't do a secondary TEP for all the laryngectomy patients. Only some are.
We have to assess the stoma, sir. Stoma we have to assess, and then
who
we
are
have
the candidates, suitable candidates for secondary TEP?
the
Who are
patient
not suitable candidates for secondary TEP? Yeah.
patient who has failed for esophageal speech.
Okay. Who failed to get a esophageal speech. Okay.
Yes. So that will.
Who are good candidates? Who are bad candidates? Just tell me that. Who are good candidates for secondary TEP?
Good candidates who have failed to get the esophageal speech will be the good candidates.
Good candidates are fully motivated patients.
Yes, sir. And bad candidates
Not motivated. Okay.
motivated.
Any other? Because they demand for it. They ask for it. They are totally motivated for it. Any other? Who are the good candidates for secondary TEP? Those people who are good swallow or bad swallow?
Good swallows. Because while all belching, the speech will be produced.
So they have got a good swallow, they are good candidates for. That means they don't have stricture or spasm of the pharynx. Right. For those people who have got stricture, they are poor candidates. Those who have got trichovenous spasm, they are poor candidates. Those who have too large stoma, poor candidates. Too small stoma, poor candidates.
Yes.
Why too large stoma, they are poor candidates?
Because there will be more air leaks, so that it will be difficult for them.
The thumb will not be able to occlude. They should
Yes.
be able to occlude the stoma with their thumb. No?
Yes.
So too big a stoma, it will leak. Too small a stoma, the process will cause obstruction for them to breathe. Or they got excessive cough reflex. Again, they will keep on coughing while trying to speak. They're poor candidates. Those who have excessive bronchoria, too much of secretion, they're poor candidates. Right. So how do you rule out cricopharyngeal spasm in these patients before doing a TEP?
Sorry,
Cricopharyngeal spasm.
Like belching, like while swallowing.
No, they do
They
what
will
is
not be
called
able
as
to
esophageal
produce the-
insufflation test. Have you heard of esophageal insufflation
Yes,
test?
sir. Yes, sir.
What is that?
Sir, like they will be with the positive pressure will be coming onto the esophagus, so that with that pressure, the glottis, the cricopharyngeal sphincter opened and the resonance can be.
I didn't get you. You may be right.
Sir,
Well, how is the esophageal insufflation test done?
esophageal insufflation, sir.
If
There
you
will
know
be pressure, big positive pressure on the esophagus, so that the cricopharyngeal sphincter will be open.
that needs an apparatus, insufflation test apparatus. Have you seen this apparatus? So this has got something like a tracheostoma, which is closed, and it's got a rubber, like your seagull speculum, no? Like a seagull speculum. It will have one area which goes to the stoma, which can be airtight, and this has got a nozzle which will be connected to a red rubber. And this red rubber is passed through the nose, goes all the way down into the pharynx, or passed through the mouth, goes all the way down into the esophagus, and you ask the patient to phonate.
Yes.
Right. If the patient is able to get a good voice, that means there is less chance of cricopharyngeal spasm. Basically, instead of putting a TEP directly, we're going to connect it through the nose into the esophagus or through the mouth into the esophagus. I hope you got it. It will be just similar to your seagull's apparatus. Instead of ear speculum, you have something that goes into the tracheostoma, which has got a red rubber catheter, which goes to the nose and it goes into the esophagus and is asked to phonate. If it's negative for spasm, means is able to phonate well. That is a good candidate for TEP. Okay, how is this done? How is the secondary TEP done? Have you seen one? How do we do? How do we do a secondary TEP?
Sir, over the stoma,
Where do you
give a
puncture?
stomal incision. At the
You don't
level
give incision. You puncture it. You don't give incision. You don't want big opening there. Will you do a scopy first?
Yes, sir. We do a scoping.
Rigid or flexible? Rigid hypopharyngoscopy. It is a rigid hypopharyngoscopy. It passes it down till the level of the stoma.
Yes.
Okay. And once you reach the stoma, you ask your assistant to keep moving the tracheal wall up and down, and you should be able to see the movement there through the scope. And the bevel of the scope is turned forwards. From there, the bevel of the scope is turned forwards. So when you puncture, you don't counter puncture the posterior esophageal wall. You want to protect the posterior esophageal wall. So where do you puncture now? So with the artery forceps, your assistant is moving that particular site of puncture, and through the scope, you should be able to see that movement. It means
So at the
you're able to
cricopharyngeal
visualize that
sphincter,
area.
once it reaches a 15 centimeter,
It will be in the midline, at least 5 millimeters from the mucocutaneous junction. 5 to 7 millimeters below the mucocutaneous junction, you're going to puncture in the midline in the posterior tracheal wall, and that puncture needle will go all the way into the esophagus, and you should be able to visualize the needle through the hypopharyngoscope. You pull the needle along the hypopharyngoscope, and you pass a catheter as a, this wire is used as a catheter guide wire for a catheter. There are different methods of doing it, but this is one of the methods how a TEP is done. When you put a red rubber catheter and leave it there, or straight away you can put a prosthesis. using that as a guide. Okay. What is the prognosis of a hypopharyngeal malignancy T4A 3B MX stage 4 hypopharyngeal malignancy? What is the prognosis? How long do they survive? What's that?
5 years.
Hypopharynx.
5 years survival rate.
What is the 5-year survival rate? In the stage 4 hypopharyngeal. Any guesswork?
5.
Stage 4 laryngeal malignancy versus stage 4 hypopharyngeal malignancy. What is the difference in the prognosis?
30, 10, 20 to 30.
Less than 30%. Hypopharynx is just around 1/4 of them actually survive, or more than so 25 to 30%. And that is considered to be good. Okay. Any questions you would like to ask?
She's already answered most of the questions.
Yeah, nice.
Yeah.
Shall we conclude?
Yes, sir.
Yeah.
Yes, sir. That has been a very teaching session, I would say. Balakrishna sir has been so patient to answer each and every question which is not answered by the candidate. And that requires, of course, a lot of patience, that too at the end of the day. Thank you very much, sir.
Thanks for the opportunity.
Thank you very much, sir. And Arun sir has to leave for urgent calls. Sir has left the meeting. I thank Arun sir also. And yes, Sapna madam, in between, madam has some other work and joined back. And I
No, it was nice. With Bala sir, I think, sir, I also learned a lot of things. Thank you so much.
Thank you, ma'am. And Kailash sir, yes, I like one man show again in Manipal with the few hands less. For just 3 days back, few people had taken leave. I think there was a huge burden on Kailash sir and Bala sir, but still, sir, took time to be with us. Thank you very much, sir. And Somaji sir is with us since morning. And from the inauguration time, in between, sir had to leave for a meeting and he joined back. I thank all the faculty. Today we had a wonderful galaxy of, and yes, thank you, Dr. Ravina, for a nice presentation of this case. And yes, that each case presentation is going to help not only the candidate, but all the delegates who are witnessing this event. And to conclude the day, I thank all the faculty who had a wonderful session since morning. First, we had a otology session and oral cavity, larynx, nose, and hypopharynx. And faculties, I should thank Dr. Azim sir, Dr. Bharati madam, Dr. Sapna madam, Anil Kumar sir, Harugop sir, Dr. Arun Kumar JS sir, Dr. Raghunath Shambhog, Dr. Gangadhar Somaji, Dr. Balakrishna sir. I always say Bala sir only. So now also I get to speak Balakrishna sir from Manipal. Dr. Mohan Appaji sir was from South. He went to East and still joined us with because of the love what he has towards KSHEMA. And Dr. Sujam madam was there, Dr. Kailash Pujari, Dr. Vijayalakshmi, Dr. Dev Prasad, Dr. Mahesh SG, Dr. Kuldeep, Dr. Sunil Pai, and Dr. Mahesh Bhatt. I thank all the faculty for taking time for us and for the benefit of the students who are registered, as well as those who are watching on YouTube. And I thank the presenters. I appreciate their courage to present in a platform like this. And Dr. Asin Kalam, Dr. Masira, Dr. Nikhila, Dr. Tirtha, and Dr. Ravina for their wonderful presentation. And yes, you have contributed a lot to the specialty, and your service will be appreciated by all the delegates. And I thank all the delegates who are registered for this and who are watching with, who are with us, watching and getting brighter at the end of the day. And I thank all the faculty and residents of the Department of ENT who have worked day and night for last few days to make this event successful. And yes, they are working now also preparing the OSCE stations for tomorrow's big event, that the live event that is to be conducted in KSHEMA Medical Academy academic block. And those who are registered for the OSCE, please be in the venue at 8 a.m. tomorrow, because the session will start at 8:30 a.m. And I thank the IT. Yes, online it is not very easy, and to conduct a virtual session, we need a strong IT backup, and our IT department have done a wonderful job, led by Mahesh Chowta, Savita, and Bharati. And yes, our non-teaching faculty, Sumita and others, have done their job and contributed well for the success of this workshop. And I thank one and all who have directly or indirectly contributed for the success of this workshop. That is the end of the day one of our workshop, the case presentation day. Thank you one and all. We'll see you tomorrow, those faculty and the candidates appearing for the OSCE program. And one announcement, feedback is sent to the email of all the registered delegates. Please fill the feedback and submit it to get the e-certificate. Thank you one and all. Have a nice day.
Thank you, Adish. Thank you. And a great event. Thanks the entire organizing team for having me. Thank you so much.
Thank you very much. Thank you. Thank you. So the IT team will disconnect the session. Thank you.